and at the age as it goes, so the tongue start moving from superior to inferior, up and down. So this tongue control, this tongue movement is very crucial for the solids. Many times we see autistic kid by the age of 6 months, 8 months, when they start giving the solids, the child gags, right? Why he gags? Because this feeding development in the mouth, the tongue movement is still not developed. They may move the tongue, but they are not moving in such a way with which they should be able to handle the soft food or the solids. But still, as we don't understand the cues from the child with an autism, we still force the child to take the solids, because now it is 6 months, you have to be starting a very soft diet. So we don't understand, because of autism, because of the delayed in the developmental milestones from the fine motor, activities of daily living, emotional, social, they have a significant delay. Because of that, the lingual movement and the sensation here, hypersensitivity, hypersensitivity. Because of that, if you give any food, they don't know how to hold it, how to move it properly. That food goes and triggers the gag. When we eat, gag is not triggered, right? But when they eat, it triggers, because they don't know how to send it without triggering the gag. So it is a skill. They have to learn it. If they don't learn it, they will gag it. So what we have to do for this child who is gagging with the solids at the age of 8 months? What we have to do? Okay. Can we give him the solids, or we have to take a step back? We have to train them. So till we train them, can we give the solids, or we have to stop it? Yeah. So predominantly we have to allow them the liquids until unless they develop the skill to hold and manipulate the semi-solids or this puree consistency. Many times it is soft, they eat it, but whenever there is a lumps, they gag it, right? So this is completely because of oromotor thing, number one. Number two, we have to see whether they are hypersensitivity to a particular smell, and all these things we need to assess. Many kids with this particular spectrum, as soon as they enter into the kitchen where there is some smell, they just gag, right? They see some other person who is eating, they will gag. So it is just a reaction they are showing. It is a communication they are doing to communicate that there is some reaction which is coming and they don't want to have a food right now. It is just one of the communication behavior. As sir was asking me, how do we differentiate feeding versus the sensory thing? So for that, we should understand the developmental domains properly, and we have to know clear-cutly that the sensory profile of this child, right? Is this child is auditory hypersensitive or hyposensitive? And the smell, how is he perceiving? So definitely an assessment by occupational therapist will give us the sensory profile, and we have to see the developmental domains. Many times we use COMDEAL to do a screening for all the developmental aspect. Being a speech pathologist or special educator, anybody, we can use a COMDEAL to do briefly screen where is the developmental this thing, and then we have to understand from a feeding point of view. So this developmental domains are very, very important, because each and every step is leading them to develop more. If they are stuck at one, that means the oromotor thing is not developing, or the other developmental aspect like the sensory, emotional, fine motor or smell, somewhere they are stuck. So we need to try to address by speaking to an occupational therapist. And now coming into this autism, as we know, most of these autistic kids are hypersensitive or hypersensitive. So so taking the sensory profile of the child is very, very important. So depending upon that will also help us to decide about this feeding, how we have to plan their intervention. It is not like all the kids with autism, they will have feeding issues. Few kids, they eat very well, right? Few kids, they don't eat. So we have to see their disorder, how is their react to particular disorder, and how is their communication, vestibular, and all the sensory systems are there. They're preferable this thing. So we have to, so they will be, few kids, they are very, very distractible and highly impulsive. So whenever you show a food for the kid who is very impulsive, he will also react like that, right? So it is all about what is his sensory profile and seeing into this feeding, how they are having this particular these things. So whatever the behaviors you are seeing outside, it's completely underlined by neurobehavioral patterns and the difference in thinking and learning. As yesterday you had heard to Manoj sir's talk, and today also you will be hearing to sir's talk about how their autism and the communication is happening. So it is very important for us to understand what is their sensory profile, their thinking pattern, so with which their feeding will be dependent completely upon this. So this is just for the literature. You can just take a picture. So this is about the feeding issues which will be there in the kids with autism. So for an autistic kid, if you present all these things, sometimes they are overwhelmed, and sometimes they may only choose one or two food particles. So they have specific issues like food selectivity by the type or the texture and the container. Many times they are very, very particular because their thinking process tells them they are already dealing with so many of the sensory things. Like their body tells them if there is any sound, their body tells them there is a sound, don't go there. And if you suddenly give a food, they're like, they are still trying to make sure they don't go there. If there is any sound comes here, they just pay attention here. So they are more worried about the sound that they may disturb them. So few of the studies also says that whatever this autistic kid looks, they may sometimes feel that object may come close to him, right? So they are still skeptical about that may move, that may come. So we don't know because they cannot actually communicate to us. So they are more spectacle, and their ears are just looking to protect themselves from the threat. And many times any smell, if he is more like sensitive to that, so he is just aware of there should not be any smell around him. And so with which their body is just thinking, reacting to this hyper or hyposensitivity matter, where the brain is occupied with that. On top of it, if you give rice to eat, it is more overwhelming for them. So that's where they're not able to be more regulative to eat the food. So as soon as you show the food, they walk, because that maybe they want to get away of this sound. So they want to sit in that calm, this thing, with which they can focus and try to enjoy the meal. So the main problem comes as they cannot communicate. And we as a therapist, we have to become a behavioral analyst to try to understand their behaviors, to try to understand what is really going on. And many times we have to follow them, because if they say, I want to go and sit there, we have to go and try to see if that is making them the comfortable. So this is all about understanding their sensory needs. If you understand their sensory needs, means you are understanding his brain, means you are becoming his friend, right? If you're not following his instructions, he is not going to follow your instructions, because whatever is there in your mind, he is not able to understand, and whatever he is communicating, we are not able to understand. So they are very good communicators, but certain times they are not at all very good communicators. So we have to open up our theoretical and the scientific clinical skills to understand their behavior and the cues to help them. So yeah, so what I meant by skill deficit is they're not skillful to move their tongue and the lips in a very appropriate way to swallow. They may not be very skillful to use their hand to take the food and keep it in the mouth and swallow. As soon as they touch the wet, they're like they don't want, right? So they will do this. When they're not able to touch, how can they take it into the mouth? So these are all the specifically very, very peculiar symptoms they have, especially for the kids with autism. So these are all the things we can discuss more, but I will just try to go to the more of the practical things. So they have a food preferences, they have a food disgust. So most of this kid, they don't like the fruits and the vegetables, and so most of the things they have issues with the texture, appearance, taste, smell, that temperature. So that is mostly they have a preferences. So mostly the food preferences what they have is the carbohydrates and the crispy and the crunchy snack food. So that's what they prefer. And so many times they say that the nutrient wise they consume less, but more or less the study says that ASD consumes the similar amount of the nutrition or the calories. But of course these kids, they may have some vitamin deficits. Of course my next speaker will be more highlighting on that. But more or less what I'm trying to tell you is whatever they are eating, that is what the system is telling them, that is what the sensory need and the biological neurobiological need. So many times we may have to allow them slowly modify whatever we can do in the therapy sessions, or slowly we have to modify it. But we cannot bombard them, don't eat that, completely eat this. So how many of your kids are following the gluten-free diet? You can just raise your hands. 1, 2, 3. Gluten-free and this casein-free diet. Okay. So nowadays the recent literature also says clearly that we cannot just force the kid to follow this diet, because their sensory system, their preferences are few. So in that, if we stop, as you can see, most of these kids, they want to have the carbohydrates. As you see, they prefer that. With this gluten-free and this casein-free diet, that's what we are going to restrict, right? So we have, if you try to restrict that, they will be just they are not to control themselves, because that is what they wanted to eat. So we need to slowly we have to take some time to transfer it. We can't just stop everything from tomorrow. So if you do that, their self-regulation will be more affected. So now, as being a multidisciplinary team, registered dietitian will say, let's try some supplements, and the behavioral therapist say this is the behavioral for sure. OT says this is more of the sensory. SLP says this is oromotor. So, and the doctor says let's do some of the blood tests and give the medicine. So who is right? Who is right? All of us is right? Yeah. So as I said, they're all right from their perspective. It is very important we all have to sit together and analyze the child, and then come to a conclusion for the next 2 months what can we do as a first priority. Maybe after 2 months what we have to do. So it is not we have to bombard everything at once, because he may not be able to take it. It is ultimately that he has to take it, right? Any questions so far? Please raise your hand and ask. Are we good till now? Yes. So we have to definitely, as a multidisciplinary team, I have to put my assessment on the table. His oromotor skills are very, very poor. We have to first work with that. If I say, team should be say, okay, then go ahead. If I say oromotor skills are there, but the sensory system is very, very, it is not at all regulatory. The child is not able to regulate himself. Then the OT will say, okay, then I will work with his sensory issues. Then the doctor may say, okay, then we will just withhold the medicines for a few more days. Then the dietitian may say, okay, then you work with the sensory issues, and the diet part I will see. If there is any deficit, I will try to add. Otherwise, we will wait for more 2 months. So this is how we have to sit together and see the child's the sensory profile and try to come up with our points, each and every team member. And then we have to go ahead by finally consulting with the parents. Ultimately, we have to tell them, as a team, we think this has to be done for next 1 month or 2 months. So we have to take their agreement or their disagreement. We can explain or hear to them, or we can add their 1 or 2 points, our 1 or 2 points, and start working. So this is one of the screening tool that we use. So this can be used by the multidisciplinary team to understand where is a feeding issues. So if we see any of this particular question where they are not able to answer, then we may say it as the child may be at a risk for the feeding disorder. So this is one of the checklist. So we have another checklist called this. This is a Bambi. So yeah. So this is a Bambi. This is also one of the screening tool. This is more towards the behavioral challenges, and also how does a child behave when he's eating, or this thing, how the parent and the child. So this is mostly can be filled by the parent many times, so or maybe a clinician can help. So this is completely consisting of 18, and the cutoff score is 34. So this also gives us the feeding issues with autism. So this is one of the thing what we follow more clearly, that food preference checklist. We try to see all the categories like the starch, fruit, vegetables, milk, dairy, meat, protein, what are all these things the child is eating. We'll try to tick, and we try to come up with a food preference, what is a child is preferring to eat. And then that we may discuss with the dietitian, saying that this is his food preference list. Do you think whatever he is preferring to eat is sufficient for him to gain the weight and height and everything? If they say okay, then we will go ahead and we'll slowly try to tick more. I mean to say, we give a feeding therapy with which they start taking more varieties of food, with which after 2 months or 3 months, the stick we slowly try to increase it. But there are few kids like where we stuck. It takes a longer time for us to increase their food preference list because of their sensory system or because of their nature of the disorder. So we may stuck, but many times we may go ahead according to the child's nature. And we also try to see what the textures that they like the best, and what flavors they like, and what are all the brands or the containers they prefer. So all these things we make a list so with which we know how we have to go ahead in working with this kid with feeding issues in autism. Any queries still here? So now the main point comes here. How do we understand the parent and child interaction? So attention, follow through, and the distraction and the siblings, this is all this thing what we have to understand in more in detail. So as you can see here, there is a antecedent and behavior and the consequence, right? So here, when the mother is feeding a child, would you like a bite? Please take a bite for mommy, please. You can play games on my phone if you take a bite. So take a bite now. So this is all the verbal request the mother does with the child, right? All of you are aware of this. So if you do this, what is the behavior of the child? He may show like, no, I don't like it. He may show the tantrums. He may cry. He may throw the food. He may be an unresponsive, not engaging, right? So when the child does that, what the parent does, what is the consequence? You are a naughty boy, or restraining the child until he or she eats. We just hold the child, make sure we force feed, and the force feeding comes. So allowing escape from the situation, letting the child leave the table without doing what was requested. So we just ignore him, we just try to punish him. So is this a good approach? That is what we need to think. So I am trying to feed a child, he's not eating, he's showing I don't want, then what is my consequence? That is what we are here to understand more. So we need to change two things. That is, we need to change this antecedent, how we react to the child, and ultimately if you change that, the child behavior also changes. Ultimately how we react, our consequences will also changes. So this is what we have to look more into that. So if for example when the child is eating, when the child is showing this reactions, do you feel the child is liking it or enjoying it? So now we have to read their cues. Many times this autism doesn't come on a day one, or the feeding issues doesn't come just like that all of a sudden. Gradually it starts. Being a parent or a therapist, we may just ignore it. We may not look more detail. So if these reactions are consistently there for 1 week to 1 week to the 2 weeks or the 10 days, then we may have to try to see why these reactions are there. Is he is not liking the food, or is not liking the smell, is not liking the taste, he is not knowing what to do once the food is there in the mouth, he is not knowing how to just manipulate it and swallow. So here also we see that the reaction is not very happy. So we have to see if these are all the reactions are there. As you see, it is a gag. So the food what they had given is not able to manipulate it properly and swallow. So with which he is showing the gag. Every child shows the gag. Okay, how many of you seen a normal kids who is gagging on food? 6 months, yeah, all the kid gags. But their gagging goes away after 2 to 3 weeks or maybe 1 month. So slowly the gags goes away for one food, it will be diminished after 2 weeks. Another food, once you introduce a new food, will be there for few weeks. So ultimately it has to go away. If it is persisting, then definitely that is an issue. So what we look is, these are all the main oromotor things what we look, being a speech language pathologist. Poor tongue lateralization, delayed chewing skill, they are not able to chew it, hypersensitivity gag, poor endurance, and the difficulty biting or the tearing the food. So this is what we see. So as you can see, this child is eating a bread, and as you can see, this bread is just staying in the above. So on the palate, that means he is not able to prepare it properly and swallow. Whatever he took, it is just going up and staying there. This is indicative of tongue which is not using properly for the feeding perspective. That doesn't mean the tongue is not weak. It is not weak. So weakness is different, and having a skill is different. So here the tongue is lacking a skill to be manipulated in such a way to push the bolus. Right? It is not exactly a weakness where it is flaccidity or where it is cerebral palsy. No, we are not talking about that. So the tongue has a good strength, but the movements and the skill of moving the food, it is not there. And we also make sure that they pass all this developmental chart where they are able to eat. So many of these kids with autism, they don't get exposed to all these things on a timely basis, even though because of their system is not ready. Their oral cavity is not ready. They are sensitive to smell. As soon as you bring any food, they smell it, they get fear, and they may not just allow the food. So this all happens because of that. So I can just skip this. So this is where the slide what sir has asked me. So this is about a child accepting a wide variety of smooth pureed but refusing or spitting out harder solid. That means there is a oromotor deficits. If the food is if the child is taking a smash food, but whereas the solids chewing is just gagging. If there is any lumps, he gags. That is oromotor. Whereas opposite is a child who willing chew on a selection of harder foods, but with the rice he gags. So that is again maybe the sensory kind of thing what we have to look. Am I clear? Yes. So if the child is chewing all the chips, biscuits, everything, that says he may have a very good oromotor skill. But with the rice, if he's gagging or he is just gagging with other food, means because of the sensory this thing, he may be just having that. As soon as they see a food, they just do that gagging. But if the child with the lump, without lump, all smash, eating well, any lump they gag, or with the solids they gag, that is a oromotor this thing. Okay. So this is one of the behavioral pediatrics feeding assessment scale. This is around 35 questions. This is very much in the assessment in more detail. So I have not put the complete thing, but this is just for your understanding. You can just Google it. So now we are coming to intervention approaches. As you can see, this is the right intervention approach. They are showing the chocolate, but they are giving the food, what he doesn't want. Is this the right intervention approach? He will develop the trust with you if you do this. With the mother, father, okay, up to some, but if it is prolonging, they may also really this thing. But somewhere is this good? It is very easy to say no. So the parents will say, like, you will tell so many things, okay, but you just feed my child. That's where the problem comes. So we have to slowly help them. But ultimately, if we see this kind of behaviors, we cannot stop them on day one, right? As soon as we see today, I cannot just tell them, like, from tomorrow don't give, because they cannot just stop it, because mother has been doing that, whatever the behaviors the mother is showing. So we have to take some time and slowly modify these things. If a child is sleeping like this, do we still feed him? No, because so many times what happens means parents have a strict timings. Morning 8 o'clock breakfast, afternoon 1 o'clock, like this. Even if the child is sleepy or not, but still they are not worried because they have to feed. Once they feed, they have some other work to do. Right? I am not blaming them, but that's how they are just trying to be occupied. They are. So many times for them, most of these kids, they don't have that cycle in their head yet. Many times us also, we don't feel like eating at 1 o'clock. But still we have to eat because every day we are eating at that time. So sometimes we may eat at 3 o'clock, that is fine. So what I'm trying to say is, we cannot just strictly tell them or make the child to eat on this time because I have to feed. We have to see how is his physiological status also. So this is very important to understand. So here, meal time, whatever I have been talking in my first slide of my presentation. So meal times and oromotor skill and the feeding, this all goes in hand. We have to understand. We have to understand. Sorry. Yeah. We have to understand the child's sensory system and the developmental domains, and we should also see what the child likes, doesn't like, and we have to see what child prefers, and then we have to also integrate everything into this feeding intervention. So in this feeding intervention, we have to consider feeding, oromotor, meal time. These three are one component that we need to add. So we have to manage their communication whenever we are feeding them. So in the meal time, we have to assume that everything the child does has a communication function, and observe the child pattern of the communication. Create a positive learning and the communication environment. Many times we use this communication boards. So whenever the child is eating, we use these communication boards to make the child to communicate by pointing. Do you want more 2 spoons, or do you or you are enough? So we can use this kind of communication boards also, whereas many times he may feel like, I just want the water. He may not be able to communicate to you. So we have to train these things with which they should be able to communicate, and they should be able to indicate to us. So these are all the communication boards. So finally, I just want to tell you that restricting the preferred food, and the child will get hungry enough to eat what you serve to all the family members. This may not work. This is just a myth. If you restrict what he wants, you are just making his craving to build up more, and he becomes more desperate to only eat that, not to eat rest all. So you are just strengthening that particular behavior. And the second myth is use preferred food as reward for eating unpreferred food. For example, we say, if you eat the chips, I will give you the rice. He will eat the chip and then he will escape. He will not eat the rice. So what we have to do here? So many times the parent does, first you eat the rice, I will give you the chips. Right? Is this a right approach or wrong? Yeah. So, but this approach is not right. If you eat the rice, I will give you chips. That doesn't. So we are trying to ultimately we are making him to aim for the chips, rather than we have to do reverse, but that doesn't work. If we tell them you eat the chip, you will get rice, he is not bothered. He will just eat the chips and go. So this where we have to work with a specialist, where we have to understand their sensory system, what is their developmental this thing, and then linking with oromotor, and looking into the food preference checklist, what do they prefer, and then we have to help the child. So ultimately we have to look into their gestures, eye contact, pointing, whatever it is, non-verbal, verbal. We have to observe their behaviors, their patterns, and we have to see whether they are liking it or not. So these are the few things that we try to measure the outcome. We try to see how an oromotor skill is developed. We try to see what is the improvement in the diet, growth, and the social factors. So how is the parent-child interaction now before 2 months back? So we try to assess all this thing to see how much is the improvement with the feeding therapy. So we have to make the meals fun. It has to be fun. It is for the kind of a play. If you make it more play and fun, they will be more interacting and trying to enjoy their meals. So ultimately, it is all about how you engage and how you make the child to see. In this particular picture, we are just following the cues. He is not forcing the child. He is just putting the food close by. If she opens, he will give, otherwise not. Here the child is exploring oromotor things. So many times we just say stop it, but sometimes I prefer wash the legs properly, allow the child to do it, because this is what is going to develop the oromotor development for the child. So having this kind of exploration in the mouth is going to help them a lot, and we cannot just more make them force, but if they are doing it, we have to just allow, because most of the kids, they know how to develop their own systems. So many times we have to allow this play, and many times they don't like it. So if they are not liking it, we have to slowly introduce, and as soon as they are just very much are not happy, we have to wipe immediately or wash. So we have to follow their clues and go slowly, slowly. As the child gets more interest, we can do it more. So, so now you have to tell me what is the take-home message. What are the things you have learned from here? Right. Any queries? Anything? Yeah, please.
When the kids who has already established routines, like 7 plus, 8 plus, or who are going in teen, and we see they have preferred food, they don't have oromotor issues as such, but their preferences are very limited. We see there is a nutrition deficiency. We can get to know that. So how do we bring that feeding preference changes and introduce this new style for them?
What is the age?
7 plus, if I take those group.
Yeah. See, we have to see whether that is a concern for us or not. As being a parent, yeah, of course, for the mother it is the concern. But we need to look whether it is really affecting the child's behavior, or whether it is affecting the child's growth, whether it is affecting or not. So if it is not affecting, then we can just leave it. Because how many of you don't eat curd? Yeah, see, how can you change them? Do you want to change them?
No.
No, that is their preference.
Yes.
So, but they are getting the nutrition in some other way.
Right.
Right. So, see, I don't eat some food. You can't just force me to change.
Right.
So, 7, 8, we have to see that what we have to change, or just leave it.
Yeah. But when parents are concerned, or
that's what I'm saying.
Yeah.
If the parents are concerned, we have to counsel the parents. Right. You are just overthinking, you are just concerned, that is not much, leave it, this is how it is, because now it is 7, 8, so the child is having his own personality, maybe in future he may eat, because it is not affecting to the growth and the nutritional way. Right. Many times I see parents doesn't eat curd, but they want their child to eat curd. Right? That is good, because somehow from their childhood they missed that good kind of enjoying the curd. Now they wanted, yes. So definitely we have to give some time, and we have to do in a different way to make the child to eat the curd. We can't just force them.
Right.
Yeah. Any other? Yeah. You may have to shout, please. Yeah, yeah, yeah. Feeding issues.
Preferably.
Yeah, so for them you may do the Bambi, or you may do this food preference checklist, try to see what all this thing they are doing or not, and then you can send it to an occupational therapist to yeah, sorry, yeah, then use a mic. So in that case you may send it to I mean to say speech language pathologist. Yeah, so we will try to assess how is this oromotor thing. If there is anything from an oromotor,
yeah, sir. I checked all the assessment for muscles of mastications. So his muscles of mastications are also okay. His gag reflex also normal. But thing is like that. Previously, that guy was drinking juice also. Nowadays also she's lifting juice, she's lifting fruits, and rice also she's stopped eating. So that's why his nutritious intake is getting low, sir. So that's why I cannot able to identify that is psychological or sensory, because sensory wise I checked everything, those are normals. But why this is happening, I don't know. According to Indian family mindset, I cannot able to identify, sir. Any suggestions for that?
Yeah, excuse PPT. Yeah, so this is clear-cutly says that few kids, they change their preferences as they grow. Mostly with this autistic kids, they change their preferences as they grow. That is their pattern. So by the age of 5, 6, 7, So whatever they used to drink the juice and all, they will stop. So they will do something else. They may start something else taking it. So in this regard, we may have to again speak to a dietitian, try to see whether this kind of change is normal or or not, and whether the nutrition is becoming a main issue here or not. Many times parents says this is becoming a very big issue, he is not gaining weight, but we may have to technically check with a dietitian and say that. So in this regard, we will use some approaches like SOS approaches. So where we try to, SOS is one approach where we sensory components is more, or the smell, or the visual appearance of the food. So we have to assess which is making him to not to come, because as you said, this aversion and the picky eaters, they have a specific shape or the specific smell, all these things that they prefer. So we may have to assess in more in detail to try to help, and also take an opinion from the dietitian or a speech language pathologist, with which we have to work together and try to see what else can be done.
Okay, sir. Thank you, sir.
Right. Yeah, sure.
Excuse me, sir. Excuse me. Sir, I want to. Sir, about keto diet, like, is it advertisable? I mean, or shall we not advise to sensory processing kids?
My next colleague will be talking about that. Yeah, sure.
Sir, just a minute. Yeah, sir, excuse me. Sir, I'm dealing with a autism kid now. So he eats too much amount of food. So I just wanted to know what is the condition, how to take it further.
Yeah, true. So as you can see there, so weight variability with the kids around 2 to 5 years more likely to be overweight or obese. So as the age grows, they're underweight, and there may be a match to the coherent. So if a child, many times few kids, they may develop this particular oromotor being more of their regulatory pattern. So if they eat more, they feel like it is more of a regulating for themselves, so they will be eating the food. So in that regard also, we may have to consult an dietitian to see how much is an overweight, is it more of the concern or not. If it is like that, then we may have to slowly cut down with their help. So they will try to tell, okay, so in the morning you give only this much, slowly. So we may take an opinion from them to actually cut down whatever is attributing to their overweight or attributing to their obese and all these things. If he's just eating more, but if you don't feel there is any weight he's gaining, see, many people are just, they eat more, but there is no weight gain or something like that. So in that regard also, we may have to once speak to a pediatrician to see if there is anything, medical issues are going on, something like that. So many times we ignore the medical issues. Many of these feeding issues may also come as being a reflux. Many times these kids will be having a reflux, regurgitation, that may also trigger their gag reflex more. So we may have to speak to the pediatrician to put him in some of the medication for the gastric reflex and all these other components, whatever you have been mentioning.
Would you like to add on, sir?
Yeah, I was just going to answer your RFID question there. We know from work with autism that 5 to 10% of children with autism will have sensory feeding difficulties. There is a huge difference between picky eating and fussy eaters. I don't know if you know the difference between the two. Fussy eaters are children who eat less than 30 variety of foods. Picky eaters are less than 20, and they are more picky in what they eat. If you look at the oral anatomy, which is the most sensitive part of our sensory system in our body, which is the most sensitive part? Mouth, right? millions of nerves and sensory systems are innervated into the mouth. And if you look at when does the sensory system develop in a baby, in an infant, or when does it develop? When he's out of the womb or when he's in the womb? When does it develop, the sensory system? When the baby is in the womb, the oral sensory system and the other sensory systems start to develop. I don't know if your mothers, and if it was to go back to the history of your children breastfeeding, there always be problems with their breastfeeding. It could be difficulty latching, difficulty feeding, difficulty managing the flow of the milk, difficulty bottle feeding. There is always a history for those children with sensory feeding difficulties. As a speech and language therapist, we have to make a distinction, which I think Sir asked, motor-based or behavior or sensory. If it is a motor-based, that is a pure FETS developmental, which I think my colleague Fanida here explained very well. If it is sensory-based, I would not touch it without an occupational therapist working with me, because what they know about the sensory system is not what I know about it, or we need to work together with that. So with ARFID, we work with mental health team. It is more of a mental health classification disorder that psychiatrists would be working with ARFID. It's a very dangerous thing, because we have a lot of children who have stopped eating and have been admitted to hospital because they can't get any food into their system. And it's a very dangerous area to touch into unless you know a lot about ARFID. Similarly, there is a lot of other conditions like anorexia nervosa, bulimia. Those conditions are quite common in children with autism, and that is why they are very sensory feeders. The problem is not just with the mechanism of feeding, that's all okay. It is the acceptance of the food as it goes into the mouth. Their palatal systems, their soft palate, they are never sensitized enough to accept and taste and make the other kinds of food go through their system well. There are fantastic programs available. There's a program called Fun with Food. I don't know if anybody's heard about it. So it is developed by one of the professors in the University of Ireland, along with speech and language therapists. There are programs like SOS that Fanida was mentioning. Again, they have to be done in conjunction with OTs. And there are other programs which are available for targeting ARFID children specifically. So if that answers your question.
So I just want to add on a line. Overeating in many of our children is quite commonly seen. Probably we never allow the child satiety center to develop in a proper way. Especially in the Indian families, as parents, we decide how much to eat, when to eat, how to eat. So from a very young age, we never give opportunity for the child's brain to develop, and especially the satiety center to say, I'm done. Nobody tells me, right? We know how much to eat. And it depends every day. We won't eat the same quantity every day, even though the food is same. Even biryani, it might be very tempting. One day we might eat more, the another day we might eat very less. That's a satiety center. I think as professionals, we should educate our parents to be cautious about it. And also, as Sir has mentioned, or Fanny has mentioned, the metabolism and the metabolic rate depends. So if there is no obesity, and if it's a healthy eating habits for the child, and if its metabolic rate is high, I think that is good to go. But I feel in the population, what we see, it goes in another way, not most likely that with a high metabolic kids. But it's because of the repetitiveness and because of non-functioning satiety centers. So probably that's where our nutritionist role comes up in giving what's a good diet. And our role comes up in teaching them for the acceptance of the good diet, because they're already tuned to eating something else. And a medical professional role comes in understanding and analyzing if there is any medical condition or a comorbid associated with that overeating. As I was mentioning about this anorexia and the other conditions. Thank you. Anything else?
Basically, this is from a special educator or even a teacher. In fact, I observed from my daughter 10 years back. When she goes to school, she's a normal child. No development delays, everything is fine. Teacher was teaching her good habits, bad habits. So teacher told her, don't eat too much chocolates. So, well, good. So she's obeying teacher's habit. But when she comes home, mom, teacher told me not to eat chocolates, but you give me at home, not at school. So how do you handle such situations? So they are more controlling parents than.
Nice one, sir. So, but yes, sir. In the meanwhile, Funny will answer that question. Meanwhile, we have a small activity for you guys. So, do you?
Yeah.
We'll just start it, and Funny will come back to you, sir.
Right. So for two people, we will be considering it as a pair. We will be giving you one small cup. So maybe half. So one person, if it is all okay for your partner, you can feed them. Take a small bite, feed them, or they can eat by themselves. That is okay. But I want all of you to observe their each and every pattern how they are eating. Right. So whether when you feed them, whether they are really liking to take it or they are showing any reactions like this. So this is just a small activity for you to be aware when you feed a child with autism or any of this feeding therapy. You should be in the present and look their cues and the reactions. Many times in our being a therapist, we just give the therapy to the child, but we are not there. I mean to say, we are somewhere or we are thinking or something else. We may just miss the cues what the child is giving. So all of you just observe to each other. You can just come here, ma'am.
Guys, can you please quickly pick up the biscuits?
And be
Please
as a
come
partner.
forward.
So just try to observe this. So and you can just give me any feedback that whether they're happy to take it or they're enjoying it or they're not liking it or they don't like this biscuit, this company they don't like, right? We also have preferences, right? So nowadays we all eat only marigold. We don't eat all this sugar. So many people, they will only eat this thing. So you can just ask them, do you like this biscuit? This is the right time to eat? Do you eat only in the morning or evening? You can just have a conversation. I will give you 5 minutes. If any doubts, you can ask. Otherwise, I will come back to you after 5 minutes. Your term starts now.
So biscuit is not only for eating and enjoying. It's not a midday snack, but for evaluation. Irrespective of the field, it would be nice if you all can try notice and then come back with your observations. We are running out of time, so if we could do this and wrap up within 5 minutes, we'll have nice objectives for Vahini to take over.
This is
You had a question about your daughter that you were asking. That can you let me clarify a little bit so I can answer your question? So she was told not to eat chocolates at school,
Yes.
and she came home and she was demanding to eat chocolates. So she
No. She was telling my teacher told me not to eat chocolates because it's a bad habit.
yeah.
But she thinks that it is only in school, and comes home and says, "Don't give me chocolates to school because my teacher told it's a bad habit.
Yeah.
But give it to me at home. I'll eat now."
Yeah. So children can be very manipulative and they are very smart to work out what works where, and they'll often use things one against the other. So whatever benefits to them, they will use it in a situation. So which also shows that she's smart, that she can differentiate the two different environments where rules can be followed and where rules can be broken. So my way would be is, fine, I'll give you, but maybe it's just one we'll give you, rather than just saying no at all. So moderate it and give it with a valid reason, and that sometimes does make it easier for children to understand. A lot of times we don't explain them why you're saying no to something. And also when you say no, like my own son didn't eat any chocolates till he was 4 or 5, because I lived in Singapore and nobody gave chocolates. When I moved to Ireland, every place there are chocolates kept in reception, there are chocolates everywhere. So wantedly or unwantedly, he started eating chocolates because it was there, you know. So that's what I'm just saying. So you just have to work it out in a way that you give a reasonable explanation, but saying no doesn't work, because there are definitely going to be, rules are going to be broken somewhere in school and or at home. So if it answers your question.
Sure, hats off to your child's cognitive abilities. And probably at home or with many of the, any of the families here, it is very common that our bonding with children is quite different from what a teacher's bond is and what a therapist bond is. So they know their boundaries and they know how to do these negotiations and the demands at home. And if it is really altering their learning at home, probably then I would prefer training the parents on getting that behavioral control over the child. And it's definitely not about saying no, as Sir has mentioned. It's about probably attaching and getting our way of applying and implementing our home rules. And in the chocolate scenario, we can always utilize it as a reinforcer and teach accountability for the child. Yes, they can get it, but yeah, as they grow, the challenges will differ. And it's very lovely to know that she became a CA. Are we done? Can we proceed? So, Funny has a liberty to pick up, and who will start with their observations? I have few people on mind. Can we start with the last people? Red and blue shirt. Yeah. Satish, can you pass on the mic?
Yeah.
Sir,
Just share your observation. That's it.
sir, it's sweet.
It's
Achha
sweet, very nice, very sweet.
Tasty hai.
Okay.
Good day biscuit is very sweet.
It's sweet and tasty also.
So, do you had a need to drink the water after taking the
Yeah.
biscuit? Yes.
Like
How many
after-
people had that need to have the water? Why? Right. So, if we take any other, like for example, if we take a fruit, do we have to drink water that much more obviously like with the biscuit? No. So, many times we may have to just try to understand the nature of the foods also. Because if the child is taking a biscuit, he may drink more water. So, if he's not able to communicate, a kid with autism or any other spectrum, so he may not be able to communicate, or he may say. So, we have to be a little bit more of a mindful how these things are. Okay, any other group? Maybe your observation? No? No observations? Yeah, just share whatever it is. Okay, who felt that their partner did not like it? Just like, this is not the time, don't give, I don't want to. Okay, okay. Yeah, what is the reaction of your partner?
She was my partner.
Okay.
So with the chakli, she was fine and she was eating well. With the
Okay.
biscuit, as soon as I saw her, she was like, "I don't want it. I don't like it." I'm like, "Acha, theek hai, eat a small bit of it."
Mm.
I might.
So
look,
you
I
forced
had
her,
a
okay?
At least I have to see her expressions, right, while
Right.
eating also. So I
Right.
gave her. She ate a bit and she's cleaning her mouth with her tongue and she was like, I don't want more and I want a water.
Right.
So as soon as she saw the biscuits itself, the expression got changed. So
Okay. So what do you say about her preference? Why she is more happy with that other thing but not with the biscuit? Her preference is the salt, right? Her preference is not the sweet. So for other people, the preference might be a sweet, right? So they may like sweets. She is more preferring towards the salty or the rest thing. Is an abnormal? No. That is okay, right? So this is just a good observations that we have to keep in mind when we see a kid with the feeding issues. Any other? Sorry? Texture. What do you mean by the texture?
So when we were having the crunchy thing, I personally felt like it was a little hard to chew, and the other part being where we are chewing the biscuit, it gets very mushy. So that's also like a preference. Some people might want to have something that's very soft and mushy, while some people like to have the crunchy, as in apart from the sweet and salt preferences.
Perfect. Ultimately, see, many kids they like the salty because salt is nothing but the sodium, and we have a sodium in our body, right? We have a sodium levels also in our body. So somewhere most of the humans they like the salty somehow. So everybody likes the murkus or all these things, the snacks and everything. So that's how the child becomes a little bit more preferred towards this particular chips or all the snack items. So that is not that they will be only restricting, but somehow that is how it is. So we have to just be mindful of how much they are eating and all. So two things I did not cover in my presentation, but that is for us we think like that is very, very important. Number one, using the talk tools or chewy tubes and all these things. How many of you uses the chewy tubes? Chewy tubes for the feeding of the kids with autism? Just raise your hands. Right. Chewy tubes definitely we can use as a supplement, but only chewy tubes is not going to give you the ultimate result, because ultimately we have to understand the child, his preference, his sensory profile, and then we have to go slowly according to that to modify it slowly. So feeding tools, whatever the talk tools or whatever the tools we have, that will help, but that is not the only thing that we use it with these kids. Definitely that is the reason I did not focus much upon it, because all of you are already using it. So I just want to give you more information, new information which has to be incorporated. And second thing, I was just thinking, I just missed from my head. Yeah, I will just get back to you if there is, I'm not able to recollect that. Any other queries? Sure. I thank organizers. I thank Yashoda Hospital and their team, and I also thank chair and the co-chair, and I finally thank all the audience so for giving me an opportunity to share my views. Of course, feeding is very vast area. So I conduct workshop for the 2 days about only this. So this is just a kind of a piece of information what I could just give you. But yeah, so thank you all of you, and yeah, if there is any queries, I will be here around. Thank you.
Thank you very much, Dr. Faninder sir. It was an hopeful insight on the swallowing in pediatrics and feeding too. So actually we are running out of time. On that case, I'll just introduce the speaker and okay. However, ma'am. Okay, so we'll go ahead with question and queries in a break time or any time with Josna ma'am if anybody is have query. And I would like to introduce our next speaker, Dr. J. Vahini. She is an associate professor in nutrition at the prestigious National Institute of Nutrition. She brings strong academic and research expertise in pediatric nutrition and dietary planning. Her work emphasizes evidence-based nutritional interventions, ensuring that children with autism receive balanced and adequate nutrition to support their growth and development. So on the display, we can see she is having expertise and multiple achievements on her name. So please welcome Dr. J. Vahani. Thank you.
Vahini has been working with NIN for the past decade, and she is one of the few nutritionists who could really curate a plan as per our special needs children, and who could sit with the parents and work within the sensory limitations of the child. I mean, even with respect to the food. So please give a big round of applause.
Good morning, everyone. I'm audible? Thank you, organizers. Thank you, Yashoda Hospitals. Thank you, Somshekar sir, and thank you, Joshna, for giving me this opportunity. And the topic which is given to me is From Plate to Progress. So before we progress, I would like to just show you something. Can you see what is this? It's my plate for the day, right? This is the general recommendation from ICMR and NIN, and this is the actual my plate which every person in the country should be consuming. So technically, taking you as a person, would you be able to consume this? Honest answers, yes, no? Yeah, but are you going to take, see, we have written 400 grams of vegetables the whole day, per person, not for the whole family. Is it technically possible for one person to eat almost closer to half a kg of vegetables? Yeah. What is misleading from the picture when we try to read is, we only read vegetables 400 grams. We also have fruits 100 grams. That logically makes that fruits and vegetables should be half kg. And the most primary issue which we have with autistic children is consumption of fruits and vegetables. Apart from this half, they are more comfortable in eating the other half. Yes or no? So remember this slide. I'll get back to this after few slides. So there are various feeding problems, and we need to be concerned when these feeding problems actually show nutritional risks or nutritional issues. So it is actually a complicated human behavior. How many of you actually agree with this? No, it is not just autistic population. Every person has this complicated human behavior. Yes or no? Right? Every day when we start moving out from the home, the first question we have is what to cook, what to prepare, isn't it? That itself starts there. And even if we don't have any special need person in the house, or we ourselves are not really into it, still the question of what has to be included always comes into the mind. So it is a complicated human behavior. And if we see, as my previous speaker said, that 69% of children with ASD are usually unwilling to try new foods. Now, why do we want the ASD population to try new foods? Because they are usually used to eating the same kind of foods, right? If we try to eat, suppose they are eating rice, curd rice or something, or maybe not curd rice, maybe they are eating some vegetable rice by default or something, which is little mushy or mashy, and suddenly I try to tell them, switch from vegetable rice to quinoa rice. Will the child be ready to accept it? First, no. Second, the texture. Second, the sensory issue. A lot of issues come into the picture. So what we need to be concerned when a person is having picky eating or a choosy eating is, we need to see if the child is losing weight or showing signs of poor health. How do you define your child or the person who is with ASD is not having a positive health? Whenever we see a lean child, we are not sure whether that lean child is actually lean or not, but with respect to say like 6 years old child, he's little thin, and then we try to say this child is underweight, is he not being fed properly? Normal child or ASD child, any kind of child. So most of us actually do not know what's the actual weight and the actual height the child should be having. Second thing is, most of the child have fewer eating type of foods or few foods in his or her diet. It need not be an ASD child. Any child in general also do not have large variety in their foods. I can give my own child's example. I am a person who eats the My Plate, which I showed earlier, and my son eats only 2 things. Dal rice. Very sadly, he just eats dal rice. And he's not an autistic child. And I, being a nutritionist, I'll be more concerned about why is he not moving from dal rice. That becomes a very challenging thing for me. So what do? I try to show the same texture, but give different kind of food. I try to give him in the form of khichdi. It is still dal rice, introduce fruits and vegetables. So it's about how gradually we are getting the change to the children. I'm little running through the slides because I want to teach something more important. What it is like? Most of the sensory issues often lead to restricted food variety, nutritional imbalances. Nutritional imbalances, here we are trying to see there might be a lot of micronutrient deficiencies, and especially if we are looking at teenagers, micronutrient deficiency at this age is more problematic, and mealtime stress for the caregivers. Right? Caregivers are the parents or the mother or anybody who's at home who's trying to give them food. It becomes stressful job for them to get variety every day. So usually these children show aversion or preference to textures. How many of you actually understand this? That children like crunchy or creamy? Which one do they usually prefer? Crunchy? Yes. A normal child also goes for crunchy. Even an ASD child goes for crunchy. Right? Then suppose if I give them a plate like this, will they try to put their hands or even think about this? It's a straight no. Even for a normal child or an ASD child, nobody tries to, even think of consuming what is there. So it's our duty to make these things, or the caregiver's duty, or the council, the parents or somebody, to give these in the most crunchiest form possible. The child may still go to grapes because they are little crunchy, sweet, gives them a chocolate kind of feel or maybe a candy kind of feel, but they will not go to the topmost plate. Will they ever go to the carrot plate? Never. They will never go to the carrot plate. Suppose I'm trying to give the same carrot little baked. Will the person still go? No, this time it is straight denial. Suppose I'm trying to just cook it or try to heat it on a flame, or maybe like kind of make a small barbecue kind of stuff. Will the child still go for it? Maybe the child goes for it, but we don't have time to make that and give that to the child every day, right? So all these issues usually keep coming for us to give a child. So you need to actually concentrate on giving different types of colors and different varieties in the foods which we are trying to give to children. So the more core principle is to meet, modify and expand. So what are we trying to meet here? We are trying to meet the list of safe foods. What are safe foods? Those which are safe. Now what technically means safe foods? Exactly, which are not triggering the sensory issues. Here safe doesn't mean being away from pesticides or being away from preservatives. No. Here we are trying to understand the safe food are the list of foods which are very readily acceptable. And say like for example, most of the times the rice may be the most common option, or maybe roti may be the common option of choosing for children. I'm not talking about chocolates or puri or other things. Primary things, rice or roti, any one of them they'll go. And we are trying to shift that person from rice or roti to something healthier, to millets or something. How are we going to do this is the biggest question. And apart from this, as I said, fruits and vegetable consumption becomes the biggest issue for children to consume. So what best can we do? We can change the way it has to be provided to them. It has to be made as a protein powder or a fruit powder, right? And these need not be purchased. They can be made at home as well. And the next thing is expanding. How are we expanding this whole issue to the child? We are doing something called as food chaining. Does anybody know what is food chaining? Anybody? Okay. So food chaining is basically, if you see the picture 1, what is there? It's paratha with curd, right? What's happening in picture 2? paratha with curd is probably an acceptable combination for one ex-child, and we are trying to switch him to more healthier vegetables or fruits by the end of the whole process. So we are trying to understand and communicate with the colors which are present in that food. If you look at that, the curd is white in color, right? So we are trying to put white rice beside it, making it similar feel to the person that, okay, this is white, maybe I should just eat it. And in the step 2, we are trying to decrease the amount of the roti. And we put a lot of curry over it, right? And here, we need to make sure that the color of the curry should be similar to the acceptable food curry. We assume that roti and curd may be the acceptable, assumably accepted food by the child. We are trying to make the curry in the similar color as the chapati, so that the child does not feel that there is some kind of change which is happening. And in the third case, we are trying to include salad. And here salad, again we are choosing something which is white in color. Can you name any salad which is white in color? Radish, okay. Cucumber, yes. Anything else? Primarily radish and cucumber, which are most commonly available. Again, we are trying to play with the colors. And lastly, we are trying to decrease the quantity or the number of the chapati and increasing the rice over here, switching the person from the gluten-rich food to the non-gluten-rich food, and making him acceptable or get used to this kind of food. And please try to understand that this process does not happen in 1 day or 2 days or 1 week. This entire process takes approximately 2 to 3 months. So it is the responsibility of the caregiver to be patient enough to come to the conclusion where they are able to eat all kinds of fruits and vegetables. So there is something called picky eating. As sir mentioned, there is a difference between picky eating and fussy eating. And the most common thing which we observe among the children is fussy eating or picky eating. Which one do we observe the most? Picky eating, yes. Children are not really fussy, but they are more really picky about what they want to choose. Why are they picky? As my previous speaker said, it's the fear of the new food. This thing is also called as food neophobia. Then because they are picky eaters, we have very narrow food choices. When we have narrow food choices, we have a large amount of food refusal. It becomes more difficult for us to introduce new foods or try to do new things. So we have certain strategies about how do we come to this whole story of giving the best food to the child. First one is to introduce tiny changes. How do we get these tiny changes? Can somebody give me an example of very complicated food which the child usually refuses? Which you assume that this is healthy, but the child may not consume? Sprouts. Okay, fine, I get you. Sprouts is a very difficult thing for the child. One, because of the texture. The sensory attributes do not correspond to it. It may be crunchy, but it is hard. Hard is avoidable. Now we are talking about different age groups. The same sprout given to a child who is 6 years of age may refuse. The same sprout given to 14 to 15 years of child may accept it. It depends on how they are trying to understand this. Now, how am I giving the sprout to the child? What tiny change can I make? I am combining it with something which is soft and mushy. What will I add to this? Any random guesses? What can I add to the sprout to make the person eat the sprout? Steam it? No. That is a very strong sensory profile. If I'm adding lemon or something, a straight denial also can come from the child. Think it the other way. Include the sprout in something else. If the child is trying to eat idli, they are comfortable in eating the idli. Put the sprout inside the idli. Make the idli with sprout inside it. Again, the gag wala thing can come here. Yes, I totally understand that, because that's a sudden solid food which is coming in between. But when you're trying to steam it or bake it, what is happening here? The texture is kind of changing, which makes it little appealable to the child. So these are the tiny changes you need to get. Then the second is use tolerated foods. Now every child has their list of tolerated foods. I don't have to define tolerated foods. Now how are you making a design of these tolerated foods is up to the hands of the caregiver. Next is building a routine. Building a routine here doesn't mean I'm asking them to eat at 9 o'clock, I'm asking them to eat at 1 o'clock. No. Building the routine is a behavioral routine. Like, for example, what is the routine these days children do when they are trying to eat food? Very easy to answer. Watch TV or watch mobile. Now, that is not the routine which we are trying to see here. We are trying to build a routine where they are interacting with the caregiver. We are trying to build a routine where the whole family is sitting together and eating. Do we see families sitting together and eating these days? No, nobody has time. With the work from home concept, still nobody has time. Sir? So with the work from home concept, this sitting together is becoming more difficult. So it's about the environment which has to be created to the child. First, make it more of a family event. Do not make it like a big event like, oh, it's a dinner time, the child has to eat, we need to spend more time. Don't make it like a special preference thing. Even when you're taking your child to any particular occasion or something, my child may not eat, so I won't be able to attend this function. Oh, I will feed him and then take. That is not the routine which we are trying to discuss. The routine we are trying to discuss is to cut a complete environment where the child finds it very enjoyable. They'll be like, yay, it's lunchtime, I should go and eat. Such kind of situation has to be bought. Then, repeated exposure. So the same food is offered multiple times in the case of ASD, right? And this usually becomes more difficult for us to get a new food. So we always have to introduce new food with the old food. Suppose the old food is 100%, make it 75%. Make the new food 25%. The child may deny it for the first week. Accept it. Show it again. Visual interpretance is more important. Show it again the next week. Keep showing it, until the child feels that this food is safe to eat. Then, no pressure feeding. Definitely no pressure feeding. Yes, we all may run short of time. We all want the child to eat fast. We do not have time to spend so much time for them to eat it, but still, no pressure feeding. Then, always keep mealtime positive. Encourage the child to eat more and more different kinds of foods. Make the child observe what you are eating. Your plate should be more colorful. When the child sees that your plate is colorful, they'll try to cut the same thing into them. And expand gradually. When you try to make your foods more rich in nutrition, you can expand the same thing to the child. Now, what are the most common mistakes? Forcing the food, expecting the quick results. So, child usually eats only biscuits is what is a common scenario. What is the similar texture to biscuit? What is the similar texture to biscuit? There's the answer is there on the screen. Toast, yeah. Toast is also hard, looks similar to the biscuit. So you can switch from biscuit to toast. Now the child is getting used to toast. Now change it from this toast to which toast? Multigrain toast or a jowar toast. You're slowly switching gradually from one food to the other. I'll go a little quickly. Yeah, so these are the normal feeding development and feeding development in children with autism. If we try to see in 0 to 6 months, we are trying to understand the swallow reflexes and other things, which may be better in the normal child and it may be weak or poor in the autistic child. But when you see from 18 to 24 months, here the normal child eats a variety of foods, but the child with ASD limited to food variety, preferences for specific texture or types of food. So when their child is very small, people usually assume my child doesn't eat anything other than mashed banana. I don't want to switch from mashed banana. Don't be so rigid. Like, try exploring within the smallest age possible. And 5+ years generally eats a varied diet, but a normal child may not be able to eat varied diet. I mean, like an ASD child may not be able to eat varied diet. Why is it not possible? Because the gradual exposure to different kinds of foods have not been done. Because one, the fear of the caregiver or the parent, that if I'm trying to give new food, the existing food what he's eating, he may forget or he may not eat. The fear usually doesn't allow the parent to try new things. So considering all these things, the NIN has developed something called recommended dietary allowances and nutrients for different age groups. And if you see this, 0 to 6 month children require 600 calories and 16 to 18 years child requires 2710 calories. Do you think both the scenario are possible? Scenario 1 is definitely possible because the child is exclusively breastfed. It is possible. Do you think a 16 to 17 year or 18-year-old child can consume 2710 kilocalories? You know what 2710 kilocalorie technically means? Having 4 idlis in breakfast along with sambar and coconut chutney together, followed by apple and orange at 10 o'clock, then tea, then followed by 2 roti, 2 cups of rice, 1 vegetable curry, 1 raita and sambar, and then tea and sprouts at 5 o'clock, and same dinner as lunch, and then ending it with buttermilk. Is this possible for a 17 to 18-year-old?
It's not possible even for me at this age.
It is not possible for anybody. But that is how a child has to eat. Only if he eats in that way, he will be able to get, if you see there are micronutrients like iron, zinc, B1, B2, B6, B12. I have focused only on those nutrients which are required for ASD child. There are a lot of other nutrients, like there is even potassium, there is even vitamin C, there is even biotin, but I'm not talking about all of them because all these nutrients are usually lost by a lot of reasons. You know how? The ASD child usually throws or vomits a lot. Whenever they are trying to vomit or puke, they lose a large amount of minerals, especially related to zinc. Low zinc in the body, low immunity, right? Low immunity, low development. And here I'm trying to focus on B6 and B12 because they help in proper neurotransmitter release. So that is the reason we need to focus specifically on these foods. So now coming back to my plate for the day, which actually appears like this, and for different age groups, it technically looks like this. For 0 to 6 months, you see there are a lot of, what are they? What is there? Unable to find the texture? Okay, fine. The first one is boiled eggs, but can we give it to 0 to 6 months? Do the picture says that? Is it possible? No, we don't give it to the child here. 0 to 6 months, no child should be able to eat anything. So these 4 foods should and must be present in the mother's diet if they are exclusively breastfeeding, apart from the my plate which I have shown. Then children from 4 to 9 years. Can you see the difference between toddler 1 to 3 years plate to children 4 to 9 years? Can you find the difference? What is the difference? You see there are large amount of protein rich foods in their actual forms in 1 to 3 years, right? You see there is paneer, there is salad, there is vegetable rice, and there is dal, right? When you see it with 4 to 9 years, what is there? You see there is not much of paneer, but a large amount of vegetables, fruits, and milk has been increased. Do you see the difference? So these are the various changes a person should understand in increasing the foods. So how many of you all know this? Everybody knows this, right? Yeah, no, there's no person who doesn't know this. This is basically a food pyramid. But there's a small change. You must have seen a food pyramid where the second row is present in the bottom and the bottom row is present in the second. That was the earlier food pyramid, where people used to tell eat more carbohydrates, moderately eat fruits and vegetables. But it is technically not the right way. You have to reverse it. Even for us, till now, if somebody is serving our plate, what do? We take this much of rice and this much of curry, which is logically wrong. Focus on increasing more fruits and vegetables, which will keep you healthy for a longer time. And yeah, so this is something called Smart Sensory Thali model, which has been made exclusively for this talk. So you have 3 different zones in it. Can you see them? Something called safe foods, something called modified foods, something called exposure foods. For safe foods, it's the normal food which the child usually prefers eating. The same rice, roti and other things. The modified foods are the foods like grated paneer. The child may accept the paneer cube as such, but try giving it in the grated form. They may eat little more. So we have something called as Indian food composition tables, where the entire foods which are present, which we are consuming, are divided into 20 food groups. We only know 5 food groups, right? Cereals, fruits and vegetables, milk and milk products. Anything else? Anything more than that? Anything more than that? Green leafy vegetables and condiments and spices. These are the common ones which we usually come into the mind. but there are 20 food groups in such, and you can mix and match and play with all the 20 food groups possible. So this is something called as sensory category, and how these different food groups are divided into safe food group, modified food group, and exposure of modified food group. For example, cereals. All the children usually are used to rice and wheat. They are the most common ones. So that is the safest food group, and this is the basic energy source. Now, how am I getting this person go to the modified and to the exposure zone? So modified zone is millets. So you have to slowly replace the rice with the millets. How are you replacing it? Are you just going and telling them from tomorrow we are eating jawar? No. You know, there's a way of mixing rice and cooking with jawar and giving that. Mix rice and jawar, mixed food, and give them. Slowly decrease the rice quantity, increase the jawar quantity. That's how you can switch from exposure safe food to the modified and gradually fix to the exposure food. Then nuts. How many children are comfortable in eating nuts? Any child who has asked, give me cashew? Do they know what is cashew? Okay, can we go to a little different age group of 8 to 10 years? Do they know what is cashew? Maybe they know. Maximum for nuts, they understand that cashew is the only nut. Can you define what are the other nuts we have? Almonds, yes. Walnuts, yes. All of us are very, rich. We go for all expensive nuts. Groundnuts, yes. Anything else? Yes. Coconuts, yes. So groundnuts, coconuts, and sesame seeds. These three are the most common seeds and nuts which can be introduced almost from 2 years of age. And in Indian scenario, we have the practice of using groundnut powder or sesame seeds in the seasoning or coconut powder in the curries. Somehow we are trying to introduce these nuts. The child already has taken them, but they do not know that they have consumed them. It's up to our responsibility to show them how these nuts can be incorporated in a larger way. Then green leafy vegetables, the most common food which is usually avoided by the child. Do children like green leafy vegetables? They like only when it is pani puri water. Other than that, they don't like to see that. Did you ever see a child telling, give me palak chips? You might have heard children saying, give me chips, but not palak chips. So this is how the switch has to come. You have to try making those chips more entertaining, make them with the palak puree, and substitute the normal chips with the palak chips. Then you have something called roots and tubers. How many children are usually comfortable in eating potato? Almost every child. Most of the child. If I tell them go get french fries, they'll be all ready to have french fries. Suppose I switch those french fries with sweet potato french fries. They went to the store, they purchased it, now they feel bad for it. We wasted a lot of money. Isn't it? So it's all the acceptance. Roots and tubers are mostly exposure foods. There is no harm in giving sufficient amount of roots and tubers. You get all the necessary B vitamins and fiber from the roots and tubers. But it is the amount which the child is accepting and the type which the child is accepting. They may only go for potato, but we need to switch from potato to carrot to beetroot and to sweet potato. So the first zone we have is called safe foods, which is usually dominated by cereals, milks, and smooth texture foods. The second one is the sensory familiarity. Mostly we are trying to puree the foods which we want to gradually give to them or introduce to them. And then third one is the new texture, new flavors, which we are doing minimally and gradually. From the safe foods, we are shifting them to the exposure foods. So there are various different types of diets which usually a dietitian or a person with autism or in general they would like to follow. The first one is GFCF diet, right? Most of the children follow gluten-free, casein-free diet. Why do they follow? Because both the gluten and casein contain glidomorphins or casomorphins, which give opioid-like behaviors, which makes the child more hypersensitive and does not allow them to have good mobility of other nutrients. So what do we do this? There is no proper evidence that actually gluten-free and casein-free plays a major role in ASD behavior decrease or finds it more beneficial for them. So it is not necessary that every child or having ASD should be skipped or giving milk, or should be skipped by giving wheat? How many of you have children for whom you give milk every day? Everyone? Any specific reason? Is it like because we have been drinking since childhood, let us give the child milk every day? Or do you think that it is a protein source, that is why it has to be given? The protein and calcium, but the amount of milk we give, sir, is not really sufficient enough to get both of them. Because we get almost like 50 to 100 mg of calcium from almost 1 glass of milk which we are giving children, and 1 gram of protein. Suppose we are replacing the same milk with ragi malt. You are giving say like 200 mg of calcium, maybe 40% of it will be assimilable in the body, and you are giving like 4 grams of protein. So not necessary that giving milk only gives beneficial protein or beneficial calcium. There are a lot of foods, it's only up to us of how we are trying to explore them. Then you have specific carbohydrate diet and ketogenic diet. A lot of people follow ketogenic diet. Why? Because it is high fat, low carbohydrate. Immediately when I am trying to decrease carbohydrate, I am assuming there is less pressure on the intestines. I am assuming there is less hyperactivity. That is, it is the most safest. But it is actually the most dangerous. You know what will happen if you continuously give a ketogenic diet to the child? Does anybody know what are the side effects? Yeah, the skin allergy is prominent, but apart from that, a large number of metabolic disorders are also common. Then you have something called gut and psychology syndrome diet. Does anybody know this? Gut and psychology syndrome diet is something like, people think that if I eat this food, I will perform better. This is a totally different kind of diet. Maybe it will come in the next 1-2 years. It is still in line. It will come. When it comes, you tell that is also kind of a fad diet. Then prebiotics and postbiotics. Do you know the difference between both of them? Yeah, we know them as good bacteria, we know them as bad bacteria, but what do they actually do? See, probiotics are something which are already present inside our body. They have to be well nourished for us to be away from the GI disorders. To get this nourishment, we take prebiotics. That is the food which is given for the growth of probiotics. So most common prebiotic foods which we know are curd. Anything else? Fermented foods. But logically, fermented foods are more beneficial over curd. People think that the curd is the most easier one, but when child or somebody is denying to have curd, switch them to fermented foods. They are more beneficial in giving prebiotics to the probiotics. There is a new term which will again come in few years called postbiotics. Now you know what is that? Postbiotics, when these probiotics are being consumed by the, when these prebiotics are being consumed by the probiotics, like the curd is consumed by the person, the postbiotics present in the intestine, the probiotics present in the intestine are eating the curd and they are generating some chemicals. They are called postbiotics. These postbiotics are more beneficial in not depositing the fat in the body, in increasing the short chain fatty acids, in regulating a lot of metabolic functions, in maintaining healthy neurotransmitter release. So these are the next upcoming things which will come in the future, and some more nutrients which I am trying to show focus on. And finally, these are the things which we can do to help the feeding issues. Set a feeding schedule, avoid all day routine or all day eating. Do you know anybody who does all day eating? It is me. I do all day eating. You should come and see me at my workplace. I take class at 9 o'clock, 10 o'clock I come and eat. I take class at 10:30, 11 o'clock I come and eat. I take class at 11:45, 12:30 I have my lunch. I'm a continuous eater. I don't appear like that. Maybe I'll appear in some more years, just like the postbiotics and other things. But here, what am I trying to eat? I'm trying to divide my meal. But that doesn't mean all day eating means I will eat dal rice 3 times a day, I will eat biryani 3 times a day. No, we are avoiding all day eating. 5 or 6 scheduled meals have to be made for a child every day. In school it is technically impossible. 4 meals is still possible because we have a breakfast, we have first interval, lunch, and once he's back home, snack time, and finally the dinner. 5 meals are anyway possible. And always provide comfortable and supportive seating. Limit mealtime and snacks to only 15 to 30 minutes. Timing is always important. We should never tell the child to eat fast, nor we should tell the child to eat forever. Always we should try to keep looking how fast the child is trying to consume or finish his meal. Then a good rule of thumb is only to offer 3 foods at a time for an ASD child. Do not give too many foods at a time. Suppose I'm trying to tell them to include lots of fruits and vegetables, doesn't mean I'm giving them vegetable biryani along with that some ice cream and I'm also giving them some starter. No, this is too much for them. We are trying to give them only vegetable biryani which already contains 3 different kinds of foods in it. So this is how we are trying to offer or introduce new kind of foods. And with this I would like to actually complete because we are actually running short of time and I'm more interested in taking questions. Anybody who has questions? Because a lot of nutrition questions were asked in while previous speaker was presenting. Yeah.
Very well explained.
Thank you,
even
sir.
the colors, everything. First question is, it is more inspiring me. Where do I get this food? Do you suggest NIN can, sir, or recommend any good place where we can at least once in a month can come and have this kind of suggested diet? That is one thing.
Okay.
The second thing, being a parent of autistic child, always everyone is telling B6 and B12 supplements or even diet gives neurotransmission improvement. Can you suggest what is that B6, B12 is found in which diet?
Okay, sir, B6 and B12. Always remember one thing. Whenever we are talking about B vitamins, we are talking something which has water. And where is water present? In fruits and vegetables. Any fruit and vegetable you take, they by default contain B6. And B12 is especially present mostly in non-vegetarian foods. That becomes a risk for the vegetarians to consume. Where do they get this? They get it from the fermented foods. So primarily, the 3 places where you get B6, B12, B6 fruits and vegetables, nuts and oil seeds, B12 you are getting from non-veg sources, and B12 from the fermented foods. These 3 are the primary sources where you get all kinds of foods. Now coming back to the question of supplements. Supplements are not really important every time to be consumed. It depends on the growth of the child. If the child is performing better, though little delayed, but he is achieving all the timelines, is able to represent, is able to talk properly, is growing properly, doesn't have an eyesight or something, you do not have to give them any kind of supplements. An overdose of supplement can be toxic, and we do not know when it is toxic. People think that folic acid supplementation is very good, but a large amount of folic acid supplementation can cause to irreversible neurological changes, which nobody knows. Because it's a very tiny tablet and we think that it is anyway water soluble, it will come out of the body. No. Supplements are to be given only and if necessary. Otherwise, we are not going. The maximum supplement which you can go without thinking is omega-3 supplement, because we are always short of omega-3 fatty acids. We try to take fats, but in a different way, in the form of chips, in the form of bhaji, in the form of fried foods, but not in the form of eggs, not in the form of fish. Even if we are eating fish, we are more interested in eating fried fish, where again the actual activity is decreased. So that's with respect to supplements. The third question, if you want more about counseling and other things.
Ma'am will be available outside.
Yeah, I'm available outside and
utilize the tea break and clarify all your doubts.
Yeah.
It's very difficult to get Vahini, so please utilize her.
Vitamin D also nowadays it is often identified as deficiency in almost 80 to 90%. Physicians do recommend sometimes capsule as a supplement.
I'll quickly answer this and wind it up. Yeah. So vitamin D is something which we are getting for free, and every time when we get something for free, we don't utilize it. We like to spend money. Everybody asks us to do physical activity. No, but we like to spend money in the gym. Go there, do that, and get the physical activity. Same way, vitamin D is very freely available from the sunshine. But not everybody goes to sunshine. Right? What is the best time to get this vitamin D? Everybody has an assumption that it's the morning time, but no, it's not the morning time. It's from 11 a.m. to 2 p.m. That's the peak time where you will get the vitamin D. But that is the time where we don't want to go at all. That is the primary reason for most of us to be vitamin D deficient. And coming to supplements of vitamin D, until it is prescribed at a very rare deficiency or at a very borderline deficiency, we are not going for that, because vitamin D is a vitamin which has toxicity of all the vitamins.
These days, if you see any of the lab report, that's a very common observation. 80% of the people that are giving it's deficient, especially in our
The
Indian
amount and the number where it is deficient matters. Even if you're borderline, they'll tell you are deficient. That can be still mitigated by going into the sunshine. Go to sunshine every day. After having lunch, come out of your workplaces, walk around, and then go back. We at NIN, we usually do this. Our lunch time is from 1 to 1:30. 1 to 1:10, everybody finishes the lunch. They make sure that everybody comes out, because we have a lush green campus, and walks the entire campus from 1:10 to 1:30.
Oh, wow. So
And this
covering
also
both
encourages
vitamin
social
D and
interactivity.
exercise at the same time with mental peace and more oxygen. That's so nice. We are very sorry to stop the session and make it quick, but the tea break is already going on. Please have a quick tea and come back, assemble here.
Thank you
Before
so
that,
much.
We will be happy to felicitate our speakers and the chair. So just for a moment, please.
Hello.
I request Thomas sir to felicitate our chair, and I request our chair to felicitate Dr. Vahini. Can we give one big round of applause before leaving? Yeah, thank you so much.
so that we start with the post-tea break session.
Attention everybody, here in the behavior session, someone forgot the phone. If anybody knows, please you can come to me and collect the phone.
very good morning, everyone. So, a very good morning, everyone. We will quickly move on with our session for the post-T. I invite our next speaker, Dr. M. Thomas Kishore, sir, for the talk, and chairperson, Dr. G.V. Subaya Chowdhury, sir. Please come onto the dais. Dr. M. Thomas Kishore, sir, is a professor of clinical psychology and consultant clinical psychologist at NIMHANS. He has several accolades to his name. These are very few moments when we get to say this. So he's editor in several and has 100 publications. He has contributed to clinical practice guidelines on intellectual disability and cognition. Thank you, sir.
Thank you. Chairperson is there? Chairperson. It's okay. I don't know about you, but I'm very happy to be here again on day 2. I wish at least the same with you also. Today, I'm going to talk about some important topic, that is cognition, information processing. Before I go further, why I'm able to stand here confidently at least, or showing confidence, because I read about it when the topic was given, or something that I'm partly trained. I need to top it up and break this entire title into what are these key terms, what is expected of me, whether I already know something about it, is that adequate, particularly given the kind of divergent audience are here, professionals. Then what more I need to top it up. And then as I read, I'm processing this information. Thanks to PPT, everything I don't need to memorize, but otherwise, it has to enter into my long-term memory as a concept. Based on that, according to the time, I should be able to come here and deliver it. But just because I had certain concepts and knowledge, it is not adequate for me to stand here and then talk about it. The reason being, I need to be quite clearly aware of the time allotted, for which I need to plan my entire concept in such a way the number of slides should not be too less or too high so that it does not fit into the time. I also should be mindful of other things that are happening in the hall, like say, if people are coming, of course I will be watching, but at the same time I should not get distracted. And then as I am talking about that, in case if I make any mistake, that I need to strictly correct it. So the second aspect what I am talking about is executive functioning. The first thing, my preparation and understanding talks about cognition, but how that particular information I'm delivering at this moment is what is guided by the executive functioning. Therefore, this is my primary talk about today. And quite often, how do we see this in the context of autism spectrum disorder? The first question that comes is that whether the child has adequate intellectual capacities or not, whether the child has ID, intellectual disability. Second thing is that can I reasonably expect the kind of learning and academic performance in the child or adaptive behavior? In case if the child is not able to follow, we try to understand where exactly the issues are located. Is it that the child is unable to comprehend, or comprehending but unable to memorize it, or memorizes because when we ask the child, don't you know how to say namaste to this uncle and aunt, he will parrot it and he will say, yes, I know. But again, when the time comes, there is no clear demonstration. So I believe that this intro is sufficient to help us to relook at cognition and executive functioning. I'll be going through how to assess intervention, particularly home-based support. These are the themes that I'll be touching upon. The question is, why do we understand cognition? Though fleetingly I did talk about, broadly we try to see in the context of intellectual disability, but cognitive functions are the bridge between the sensory inputs that we receive and we execute some kind of tasks. So they are primary mental processes involving acquiring information, storing the knowledge, and reasoning upon, and we refine, and whenever there is a need, we'll be using it. It serves as a knowledge base. Then cognition is like a ocean. It is a theoretical concept. So is there anything that very specifically we can understand within cognition? Though it is a single term, it encompasses multiple dimensions, multiple other things. There is no clear consensus as such to whether we need to restrict it to couple of elements under cognition or take it as a unitary concept. While that debate is going on, from a very clinical point of view, developmental significance perspective, the DSM-5, the Diagnostic and Statistical Manual of Psychiatric Disorder, it identifies 6 core domains of cognitive function. One is complex attention. It is not simple attention. Complex attention is that we are able to process information in a given time, multiple. For example, I'm looking at you. I'm also not just looking at you. In between, I'm shifting my attention from the screen to the audience. I'm acutely aware of the people moving. I'm also happy. It's not like I'm unhappy, happy because more and more people are joining. So this is not straightforward, one simple unidimensional one. It is a complex attention. And the memory and learning. We keep on learning every time. It is after many years I came over here. So when I'm reaching here, I need to know where Yashoda Hospitals are. It is the Somajiguda one or Secunderabad one or the high-tech city. Unless I know, I'll be going to the wrong place. So memory and I'm learning. And then execution. Once I know it is the near high-tech city, I need to really take an app or something, so locate it. Perceptual motor control. That is, when we perceive something, we need to, again, in real time, we need to coordinate it. And then language and social cognition. The last one is very important. Cognition alone does not serve real purpose unless it is applied in a social context. So these are the primary components which the clinical systems, diagnostic systems do talk about it. Within that, I'll be paying more attention to executive functioning. But what is important is that all these things could be either present in autistic individual in a delayed form or it in a atypical or deviant form. What does that mean? We would have seen children with autism who have no speech, that is completely delayed, or their speech capacities are little, slightly behind the expected age. But there are also children who are able to talk at an age-appropriate manner, but their pronouns are appropriate use of language, the emotions, these things could be different. The prosody and all, or the non-verbal, etc., could be little different. Just to take language as an example. So both delayed and atypical cognitive profiles across the 6 domains that I talked about could be there. And most importantly, these things are there. These things will be there independent of IQ. Just because somebody has average intelligence or above average intelligence, we know autistic individuals, at least 30% of them can have average intelligence and above. And despite that, difficulties or challenges or gaps in cognitive abilities could be expected. Little bit we need to have some understanding of why these things happen. It is not because of motivational issues. It is not because of something lack in the environment or parental efforts are not okay. There is a clear-cut biology, that is neurobiology. That is one, since I'm not able to use my pointer, I just request you to direct the attention to the one. The first one is the executive functioning, the reasoning part of our brain. It correlates with the maturation and activation of something called frontal lobes there. So quite often we see, despite having adequate IQ on standardized test, we see children having, performing in real time. That is either giving the adequate attention to a particular task or shifting at a time when it is necessary, moving on. Most importantly, the planning that is required to set a goal and then travel in that direction. Which part of the brain helps us in this? It is not that part of the brain which is storing the information as memory and the concepts, which is temporal lobe. It is the frontal lobe. But do we see any kind of structural abnormalities? No, there could be functional. And the second one is that limbic associated neural pathway, which are responsible for our social cognition. That is interpersonal reasoning, mindful, the perspective taking, being in the shoes of the other person. For example, when we are having conversation with somebody, say suppose somebody is grimacing or trying to strain, then we quickly understand that the person did not catch and I need to change it in the real time. But a child with autism, his job was to say it is executed, may not be exactly be mindful of what the mental status of the other person. Therefore, they may not be really interested or geared up to repeat the particular instruction or or a conversation. But what happens here, if I can draw your attention, it's quite a rough diagram here. That is down below the purple areas, what we are seeing is roughly the emotional part of the brain. And as we mature, there has to be connection between the so-called emotional brain, which is necessary for our survival, with that of more of a planning and reasoning kind of higher cognition. For instance, any child, infant, if is lying down, suddenly there is a loud sound, startle reaction will be there. But the same infant, as they're growing into toddlerhood or something, even if there is a loud noise, the child will first direct the gaze and see what's happening. And the source of sound is not very threatening. The child would continue engaging in a play or looking at the mother or something. Or next time they will be more curious as to where it is coming from. So that is where we would see that there is a connection between the lower centers of the brain and the higher centers of the brain. Sometimes we also think that in autism, the connections between these two are either delayed or not as expected. And the third one we need to understand is that there is hippocampus related. And what the neurobiological studies indicate is that the hippocampal maturation, it denotes the abilities in terms of spatial reasoning and the memory. Lastly, I leave that part because that's more of medical. Even things could be wrong at a cellular or genetic level, which interferes or mediates the sensory processing, and many systemic causes like neurobiological, immune, oxidative stress, and gastrointestinal dysfunctions, where we know gut microbes and bacteria and how it affects our brain functioning, etc. Many of these things which are at a speculative level, or at least we have some kind of educated guesses to know that there could be some mechanism, all of them could play out a role. And at any level biological, which we cannot see, sometimes we cannot really map up, that kind of technology is not there right away. And then within this cognition, to understand from a psychological and developmental point of view, there are three theories that stand out. One is the central coherence dysfunction or local processing bias. What basically it means is that you all would recall working with autistic children, where if you give them a toy car or something, they are more interested in the wheels or some particular aspect than the whole car as such. So the children will have, when I say children in a very generic sense, they will have this difficulty to focus on entire thing called whole, rather their attention will be there on the parts. This is what is central coherence dysfunction. The second one is theory of mind deficit. There is speculation is that perirenal or insular cortex and all, there could be some certain kinds of abnormalities leading to theory of mind deficits. Nothing but that we are unable to see the perspective. For example, I know that you will not be able to see the screen that is right in front of me because it is blocked from your vision. So that I can understand because I don't have the theory of mind deficit, because the brain has its own normal development. But for a child with autism, it is very difficult to understand, if he is in my place, that why other people are not able to see what I am able to see. And it might look quite simplistic at a very basic level. This also is fundamental to understand the mental status of the other people, so that we need to take a perspective, and also other people's mental states, their cognitive functions could be completely different. What I am experiencing at a given point of time can also, each one of them can lead to different behavioral issues. And the last one is giant attention. We know that from quite early, one of the first thing that we know is that infants are capable of directing their gaze to human figures. There are quite a number of experiments in psychology where they show the toys, they show the inanimate objects and people, there is a preferential gaze towards the human faces. And then the same thing continues as the bonding and attachment between the mother and the child develops. They are attuned, and then when the mother is pointing out to something, the child is scanning and turning the direction, gaze, and then they both of them are enjoying a common activity. And these giant attention, we see there are certain gaps. Speech pathologists would talk more, precisely about proto-declarative, proto-imperative. I'm not even going into that direction. But when we say something, point out something, or when we are shifting the gaze, the person who is on the other side also will automatically shift in that direction because there is something interesting going on. Lack of any of these things or impairments can lead to certain behavioral manifestations that are there. In this context, how do we make sense of the cognitive impairment? This is what is the clinical practice guidelines of the Indian Psychiatric Society that came out in 2025. And I've taken my entire thing heavily from there. They're advocating to approach cognition from two ways. One is non-social neurocognitive, the other one is a social. Social is much easier, I'll just explain it to leave it. Social perception, emotional recognition, and also ability to manage the emotion according to the social context. For example, if I'm unhappy, I'm hungry, even feel like crying, when there are people, completely strangers are there, I may not like to show my tears because I know it is very inappropriate here. Or sometimes even if I feel like laughing suddenly, if suddenly a joke comes, I will not giggle suddenly because I know that would be taken as inappropriate. So that emotional recognition, modulating that emotion according to situation, and then according to the theory of mind perspective, they all fall under the domain of the social. And a lot of literature is already there to prove that these deficits are there. These are akin to what we see in psychotic conditions like schizophrenia or maybe in major severe psychiatric conditions. But there are distinctive qualitative variations are also seen. The non-social per se, within cognition, the executive functioning, there is no consensus on that. Lot of things that I put it in the box are debated upon, but three things are taken out. That is, there is a consensus for three. That executive functioning, when you talk about, we need to understand we are referring to working memory, mental flexibility, and set shifting. What is working memory? Which I said in the very beginning itself, just having a long-term memory of this concept is not sufficient for me to stand and talk about it. I need to know in terms of the time, in terms of logicality, am I able to connect from the previous topic to current topic? The speed and the flow is adequate for me to reach the goal that I have set in. All these things are necessary. And then the mental flexibility is that I need to change from one topic to another topic is very smoothly. If not, there will be interruptions or I will be stuck at one particular thing only quite repetitively. So the last one is accordingly set shifting has to happen. They're all supported by our ability to plan, our ability to inhibit certain responses which either from the interference point of view or the responses that are coming from within. This is where motivation is important, problem solving skills are important, and for that we need to be vigilant and attentive so we can monitor the errors, and then finally impulse control. Unless the support from these functions are not coming, the working memory, mental flexibility and set shifting will suffer. What is significance of it? These are all quite esoteric. Sometimes we may wonder, people like maybe psychologists, commonly, otherwise any professionals trained in that, it is their duty to look at. But when we understand that these components interfere with our daily functioning, for example, working memory deficits are directly related to remembering a step in task. I might feel, for example, I am putting my dress on and I know that once I adjust the thing, I need to start with the topmost button first to secure, otherwise all my efforts will go waste. But children under the age of 6 years, if you see, randomly they start doing that, then they look at that why it's not getting adjusted, again they have to open it up, start from the beginning. So working memory is very, very important. And the cognitive flexibility is that, again, if I take the same example of buttoning my shirt, I need to first shift from, from holding to loop, or suddenly I realize that one part, one side it is really slipping away. Again, I need to adjust it back. So that set shifting is important. And suddenly somebody calls me, come Kishore, we'll go out and play. I need to control that temptation to go out and then continue with this task, and planning, organization, self-monitoring. So lack of this can, in different form, they can manifest in various forms and interfere with our adaptive functioning. But at the same time, does it mean that we need to start executive functioning training with everybody in the same manner? No, not exactly. Then why should we do that? Of course, as I said, it is directly related to language development, academic performance, and adaptive behavior. So we need to learn to intervene. And if you can look at the trajectories, during the early childhood, that is under the age of 3 years, it presents as a single component. That is, attention we are just giving it. There is not so much of regulation and directing capacities are there. But as we grow, next, what we call, literature identifies them as late bloomers. By the age of 3 to 5, children should be having adequate networks from the executive function point of view. Somebody is waving the hand. Executive functioning point of view. But again, in children with autism, they may have some difficulty. It is not well developed. The reason being that in the brain at a neurobiological level, synaptic formations are happening, but they're not very clear-cut, well-laid out pathways across different centers of the brain. As a result, the cognition, executive function will just present as a unitary component. But during closer to the adolescence, there is clear-cut pathways are developing at even biological, structural level, functional level, so many changes are happening. As a result, we will see another thing that is known as precise pruning is happening. That is, our brain, because of genetic certain mechanism, pruning is that the synapses are getting pruned out and networks are reforming. Then accordingly, we can very clearly see functional level, working memory, mental flexibility, set shifting could be there. Now, what is important for us to understand is that 60% of the executive functioning growth occurs during the age of 3 to 4 years. But it does not mean that we have to intervene during that age. We have to let the biology take over. Don't do much about it. What is the conducive time for us to really work? 4 to 5 is the time where improvements are seen, because that is where children with autism seem to demonstrate a delay as compared to the neurotypical children. So therefore, our intervention has to be between 4 to 5. So this slide will very clearly explain that executive functioning is not linear. It does not continue to develop in the same fashion across the lifespan. So the implications are there. When do we intervene? What is the venue, and what aspects we need to take care of? Whether enriched environment is sufficient, we need to go for targeted. The answer is that the venue is that across lives, wherever our life takes, that is home, community, school, everywhere this training has to happen. How early? For targeted intervention, it is better that between 4 to 5, and before 4 years, we need to have more of enriching environment. What does it mean? Like, lot of sensory stimulation has to be there. Lot of caregivers should be there interested in the child to interact. There has to be motor stimulation. Only above the age of 5 years, we develop particular activities that will target the 3 components that I said: working memory, mental flexibility, and set shifting. How do we go about the assessment? First one is take up the developmental assessment, go for adaptive behavior. Intelligence test, I put Wechsler scale because that also is considered as a neurocognitive or neuropsychological test, because it gives us quite a lot of information as compared to other scale or any global scale. I see Dr. Pooja Nair is among the audience who has done excellent work with the Professor Das, JP Das battery. That also is quite really good, and it's developed and standardized based in Hyderabad, standardized across the country, and that's where cognitive and executive functions. Then we need to go for broad behavioral based rating inventory. 2 decades ago, if you see, predominantly this entire literature used to come from the laboratory-based assessment neuropsychological scale, but there is a quite a preferential, there is a merit in using a lot of behavioral scale, but at the same time, which test we can use, why it depends on the purpose. Most importantly, it also depends on the user qualifications, whether we are licensed, whether we can use it. Just because I'm a trained clinical psychologist, I may not be able to use all the tests, that we need to be aware. And then we can choose any of the behavioral rating scales depending on the age. The list is quite big there. It is not necessary for us to remember everything. And then domain specific assessments also. You can make a referral to a trained psychologist. Even IPS recognizes that when psychiatrists can do that if they have sufficient training and interest. But what to really measure? Planning, working memory, both verbal and non-verbal, mental flexibility, response inhibition, and the fluency. Fluency is that how fast they are able to generate words or vocabulary, and this is where Indian psychiatric clinical practice guidelines can be used. Thankfully, in our country, for all the Western tests that are there, NIMHANS neuropsychological battery for children and adults is available. For the various norms, we can refer the scale. And I'm also happy to share that there is a geriatric battery also in already in preparation. It might be out soon at NIMHANS. And when it comes to intervention model, we understood the theoretical concept. We looked at what are things that we need to measure, how do we measure, then how are we going to improve that? In the literature, there are specific programs are there: cognitive remediation therapy, flexibility training, enhancement therapy, and use of lot of video games, and then physical exercises, social skill training. I would like to pay more attention to physical exercises, because in a family context, all these other therapy techniques would not be really possible, because some amount of technical understanding is needed. But depending on what domain we'll be focusing on, accordingly we can select a particular therapy model. Then exercise intervention. How do we nurture it? This is where in the home context it is quite feasible. One is a physical activity significantly, because it improves all 3 dimensions of executive functioning. Just imagine simple bat ball game. Say suppose somebody is just ready to throw the ball. I need to position myself, wait, I'm attentive. I'm seeing that I'm not distracted because I want to play. I'm also using a lot of motor control, etc. In case if I miss it, clearly I'm understanding, I'm not able to really hold on. I need to change my position, or ask the other person to first start slow and direct bowling, and then maybe different things they can carry on. And I'm also in real life changing my strategy, and also I'm building up depending on the bowler how they are being deceptive. Accordingly, I need to also change my strategy. So we can take up anything, right from hopscotch to or the stones thing that we do, or anything. And mini basketball game, that is wall mounted basket bin, where they do this. Lot of inhibitory control and cognitive flexibility. That wall based tennis, etc. Ping pong, which is not very common in our context, but anything to do with the ball and then bat bouncing. Fixed bicycle, not useful, the treadmill and stationary. Rather, learning bicycle, that is take a bicycle and then run around. And taking care of pets, they all teach cognitive flexibility. Martial arts, many people, parents and families will be little apprehensive to teach martial arts to children, because already they have autism, already they have hyperactivity, they might go punch somebody, but not. On the contrary, they will get the necessary body awareness, particularly in a 3-dimensional space. How do I conduct, how much of force I am bringing? So martial arts is a good thing. And each one of them have certain executive function related ability which can be targeted. It is based on the systematic review. And the question is that unlike food, unlike medicines, unlike therapies, there are no absolute contraindications or indication. You can even make a child even stationary, you can have something, or if a child is mobile, you can have some kind of game. If the child is verbal, you can have some kind of activities. Non-verbal, you can have some activities. Therefore, physical play, and that is what in the intervention sometimes we come across play-based intervention. Play-based interventions are nothing but all these components are embedded into this particular one. And home-based intervention, that what do we target? Self-regulation, attention, working memory, mental flexibility. And how do we achieve this? What to do? Structured play. I also take what Vahini madam has said, the previous speaker. Structure does not mean making it regimental. It is rather thematic based. In a day, do we have a scope to do something else? When do we do? How do we do? Lot of circumstances determine that, but it is important that the child is engaged in play. And quite often, we pay a lot of attention to the speech language intervention or some eye-hand coordination behavior, but seldom we involve children in household activities. Household activities give a natural medium through which all this planning, execution, everything is embedded. For example, if my mother is asking me, there are 3 people, you need to keep 3 plates, I need to plan, select the plates, give each one. While doing that, I need to clang it, I need to place it properly, social cognition is happening, vocabulary is happening. So we can bring in that right from the beginning, how do we involve children in the small chores that is expected developmentally, that is ecologically, it is valid. And then structured environment is good during the early childhood, because please remember, stimulating environment is needed from a cognitive point of view under 3 years, but later on it has to be very specific thing. Social emotional processing skills are more important above the age of 5 years, because when I'm more confident, less anxious, more relaxed, I'll be in a better position to use my cognitive abilities. Therefore, in late childhood and adolescence, focus more on the social emotional processing skill than to target the cognition, rather than directly targeting the cognition. And supportive parenting, that is sensitivity, warmth, encouragement, involvement is very, very important. That one component that is there in psychology is that co-regulation. Co-regulation is that when a child is already under stress, lot of throwing tantrums, anxious, parents also match with the same tone and the body language, and everybody will be in a vortex of distress, everybody will move away, nobody will like each other. Rather, the first person, because child has autism, there are certain gaps, there are certain impairment, the adult who does not have that, have the responsibility of being calm, regulate the child. This also applies to therapy. Have you seen I just take 1 minute. Have you seen where children are sent from therapy to speech therapists will say, take them to the psychologist to teach, all the calming techniques, bring them, I'll work on the language. And then psychologist will say, work on the language, because language is needed for me to give the therapy. No, we need to work collaboratively and see, because everything is needed. So this where co-regulation is very important. And then there has to be generic component with a broad theoretical basis. We need to know what to target it, but it has to be highly individualized according to the individual. And we are also more in the current thing, what I notice is that how much is enough or how much is too much. There is no certain answer, but 36 hours per week. 36 hours per week does not mean that from tomorrow onwards I'll take my child for various therapies. No, that some of this can come from proper therapeutic, from professional point of view. The remaining 5 hours in a day, I can do this through various other activities. That is what is very important. And what parents, what kind of skills they need, understanding the child's strengths and weaknesses, never focus only on one particular thing. And then we also need to very quickly understand that everything is not because of autism. If a child is opposing, the child is not following my instruction, very quickly we'll put them or see them through the lens of autism, and then we'll be highly anxious about it. Rather, we'd say, I as a psychologist very clearly believe that some amount of oppositionality, some amount of lapse, some amount of lack of structure is really necessary. Otherwise, on the other side, we'll be dealing with obsessions, compulsions, highly rigid behavior. And then emotional attunement is important. Relationships are very important. Self-regulation. There is, whenever we go air travel, the oxygen mask example very clearly says, before you put on the child, put on yourself. The parents need to work on their own emotions, their own expectation. And in all doing this, as I emphasized yesterday also, self-empathy is very, very important. Nobody will come to the parents and say, you've done a good job, you can take a little rest. It is the parents' responsibility to appreciate themselves and say, for today I have done well, I think I deserve some break, someone else can also take care of the child. That's what the energy that gives to them. conclusion, I don't want to repeat, the same points are there. Cognition is important. There are ways in which we can approach them, and the intervention is thankfully through the natural day-to-day activities. Thank you.
Thank you so much, sir. We will have one question, and then we can discuss the remaining in the lunch break. Any questions?
Hello, sir.
Hello,
Thank
madam.
you for your presentation. I'm a clinical psychologist, and from your presentation, sir, one thing I wanted to discuss and hear from you about how I've been studying that lately from 2025, the paradigm shift of theory of mind and empathy. So earlier we would understand a reduced theory of mind might also lead to a reduced empathy in people or children with autism.
Yeah.
But right now, maybe the child can empathize, but there's a misattunement with the therapist or with the child or parents and vice versa. There's also a concept of double empathy and neurotypicals and atypicals. So on that intervention point of view, I would like to hear some knowledge from you.
Yeah. The first thing that it's a very good question, thank you. First thing we need to understand as professionals is that we should be able to amalgamate all the theories and then how that really relate to the child's condition. That's the number one, okay? I should only be applying theory of mind when it comes to understanding child's perspective taking, his social cognition, empathizing, that's it. The same thing when it comes to executive functioning, I may need other things, for example, Badley's working model or central coherence, and why the child is insisting on the same thing, why the child is unable to, where the attention span is there on certain things with the child finds it very interesting, the same attention span is not there. So I cannot say that the child does not have attention span. Parents very clearly say, if attention was not there, why is he doing this one, So we should be able to integrate the theories and then explain which is the best that can explain the current one. And the last one is that whatever said and done, all our understanding has to translate into something very day-to-day functional and behavioral, okay? That is where these things are well developed, they are developed in a relational context, they are developed in a real life context, okay? So for example, can I augment attention span and teach them the flexibility by using computer-based games? Yes, I can do that. But still, will it give a guarantee for me that the child will apply that in real life social scenario? No. So for that, they need to go for that. So we also need to know where these things beyond a point they cannot really support us, and where alternative, complementary, or maybe the experiential base is needed, where we have to introduce them to naturalistic environment. When I say naturalistic environment, a whole lot depends on the environment, supportive environment. So this is how it is quite interdependent. Yes, sure, madam. Most welcome. Thank you.
Thank you, sir. Thank you so much for the detailed and comprehensive from assessment to home-based therapy. Thank you very much, sir. We have one announcement from NIEPID.
Yeah, we request Dr. Hrushi sir to take over and complete the announcement. Hrishikesh sir is also one of the senior faculty from NIEPID, and he's also a course coordinator for the early intervention course.
Very good morning, everyone. This is an announcement from Government of India. This is a free web-based platform, digital platform dedicated to the nation by Ministry of Social Justice and Empowerment, Government of India. This is a dedicated platform for children with neurodiverse conditions, and it is free of cost. It is highly data protective and works in very low connectivity also. So this platform has multiple resources that are useful for the therapists, the parents, the caregivers. So 3 category of beneficiaries here, the stakeholders, I mean. We have video consultations, we have online screening tools, we have phone consultations, dance and music therapy sessions, webinars, regular webinars are conducted. Then all the insurance schemes of government is displayed into this. You can directly download the PDFs. There are some home care videos, and we have an option for finding the nearest care center. If you are a special educator, special school, you can register with us. We will upload the content into your into our portal. So this portal is for 3 categories of stakeholders. One is the professionals, we, the medical doctors, the psychologists, the special educators, the therapists, everyone who is involved in intervention of children with neurodiverse conditions. Then we have a category of care providers. Care providers can be NGO managers, can be ASHA worker, can be Anganwadi worker, can be a regular primary school teacher who is an important stakeholder right now. And we have an option for the parents also. So I am the core resource person for this. You can contact NIEPID for further information. It is free of cost. We encourage everybody to use this, and we all will be in touch. Thank you. Thank you very much.
So now coming to our next talk, from therapy room to classroom, generalizing social emotional skills through ABA across settings. We have stalwarts with us. Dr. Smita Avasthi ma'am, speaker, and Dr. R. Shilpa Manogna ma'am, chairperson. So we've seen how they have been in the workshops, and get ready for the very good session. I request Shilpa ma'am to please invite Smita ma'am.
A very good afternoon to one and all. It's indeed my, I'm very happy to introduce my very good friend, Dr. Smita Avasthi, and sharing the stage with her once again after a long time. And to many of you who do not know her, she's the founder director of the ABA, the BMI, Behavior Momentum for India in the country, and doing a lot of pioneering work. The rest of her achievements are on the slide, and anybody wants to learn about ABA in the most scientific way, please approach her, please approach BMI. I think they are doing a wonderful job in actually doing research on evidence-based strategies which work with children with autism in one-to-one setting, in small group settings, and really trying to make a difference in the field, how they can be translated into the classroom. So not taking much time, let's all welcome Dr. Smita and listen to her.
Good afternoon, and thank you very much, Dr. Shilpa, for the very nice, kind words. We are all trying to do our little bit, and and I think I would like to just begin by asking everybody to clap for our parents who are over here. It is because of them we are doing whatever we are doing, and their children have taught us so much. So let me begin with one of the topics. It is a difficult topic, and I have been preceded by Dr. Kishore, who is such an amazing speaker, so I hope I can do a little justice to the topic. So today we are looking at moving beyond the 1:1 desk work that we all start with when we are dealing with children with autism, to making them functional and real world independent. So the question that we have over here is, why do we have the generalization gap? Why is it that the children with autism who are learning in a 1:1 setup, why are they struggling? Why do they not just learn and generalize everything in different settings, whether it is in the school environment or it is in the restaurant or it is in any other environment that we take the children to. Why is it that they struggle when different people ask them questions for which they have been trained in a 1:1 setup? And this is where we are trying to address some of the issues. So what is a therapy room? Let's start with that. So a therapy room is really centered on the child. Everything that we do is structured around the child's needs. Everything that we do is calibrated around what the child can do or cannot do. The focus is the child. There are no distractions there. Actually, we try to minimize the distractions by even making cubicles. Sometimes we have the complete attention on the child, and the kind of prompting that we do for teaching is also child specific. That's what a therapy room really is all about. Now, what is a real classroom? This is the chaotic classroom that the child goes to where he's just one of many. He is really not somebody where there is any focus. The teacher over here follows a curriculum. She's trying to, the child is trying to fit into the curriculum that the school is offering, the class is offering. There's nothing special that is arranged for the child, unless we are talking about having somebody who's supporting the child. There are plenty of distractions going around. There is no individual attention. There are no prompts, and sometimes if the prompts are, they are more like replacement of the teacher. So instead of the teacher giving an instruction, it is the prompter who's saying, okay, I'm giving you the instruction, just do this. So the child sometimes really is not prepared for what is happening in that classroom. So let's look at what are the skills that are required. Coming from a behavioral background, I mean, we like to just break up everything into the most, smallest component and work on that. So the basic skills over here are looking at attending skills. The child may learn to attend in a 1:1 situation, but may not learn to attend in a group setting. So does he have attending skills? What about language comprehension? Language is so complicated that to listen, to retain, to comprehend every word over there is pretty complex. If we look at the diagnosis of autism, language is one huge part of that. Everything that we do in our lives is all about language. So if I'm talking to you, it's language. If we are playing a game, it is rule-based and there's language over there. If we are listening to a story, that's language. If you are telling a joke, that's language, right? Everything that we do in our life is around language. And sometimes we really do not, focus on building that language enough. So language comprehension is something that is a very core skill for moving the child from a 1:1 therapy environment to a classroom environment. And the third thing is the level of independence. How independent is the child? Will the child do his work only when we say, come on, do the next one, go to the next page, pick up your pencil, hold your pencil properly, okay, let's start here. So how much independent would the child be if there are instructions coming all the time? And then we look at the advanced skills, which are about social skills, emotional skills, and perspective taking. Let's go through these quickly one by one. So when we are looking at the basic skills, attending skills, let's look at this list. Eyes have to be on the teacher and other stimuli. You have a teacher who's moving. She's moving here and there. Sometimes she's facing this side. Sometimes she's facing that side. Sometimes she'll turn around and she's writing on the board while the children are looking at the teacher. And our child with autism is not prepared for something like this. So when you're planning and you're preparing and you're teaching for generalization, we need to focus on this. Staying focused, ignoring distractions, staying on task, responding with immediacy. Okay, how often in our therapy classrooms, 1:1 setup, we actually work on teaching the child to respond immediately in 2 seconds. We many times don't. We repeat our instructions, the child gives the response, and we're happy with that. In a classroom setting, the teacher talks once. The child has to learn to listen in that 2 seconds and move on to the next thing. So that's something that needs to be looked at in terms of training. Language comprehension, of course, is extremely complex, and I'm going to talk a little bit about that later. Independence is about complete independence, even if it is as simple as doing a small matching worksheet. If we are sitting right close to the child and we are prompting the child and we are using our gestures, the child will never be independent. So generalization is going to be a problem when we have something like that. So what are the ABA principles that we use to support the transfer of basic social emotional skills from the therapy to the classrooms? The first one is, firstly, we need to know the child. So we need to conduct a language and behavioral assessment. We need to identify where the child is today in terms of his understanding and in terms of his cooperation, in terms of his attending, everything. Then we plan shaping steps. And when we are talking about shaping steps, we start from where the child is. So if the child is able to sit for 2 seconds, then we start from 2 seconds. And we go to 5 seconds, and we go to 1 minute. And then we go to 10 minutes. So shaping steps will always start from where the child really is. Then we differentially reinforce acceptable responses. These are the ABA principles that we use. And here, one of the very important things about transitioning from school to, from 1:1 to classroom is about doing multiple exemplar training. Multiple exemplar training is where you are using multiple examples for teaching a concept. If you are teaching a concept of an adjective, let's say, okay, we have to make sure that the child is able to do it across so many examples that he can just generalize without further teaching. So we are teaching to generalization when we are doing multiple exemplar training. Then we train across different therapists, because many times our children are very happy working with one person. The child becomes dependent on that person. The child responds beautifully with that person, and everybody is scared to shake that system, because we know that it will get disrupted when the next person comes in, or we ask the child to respond across somebody else. So we train across people. We increase the distance. So how about the child is sitting there and you kind of turn around, walk away, give an instruction from far. Will the child follow the instruction? Vary your instruction, use variable language. Can you do this? How about this? Can we all do this together? Can we both do it together? So using more variable language, because then we don't know what kind of language the classroom teacher is going to use. All teachers come, they have their own language. So vary your instructions and use a lot of generic words. These are the kind of support systems we start with in 1:1 setup before we think that the child is ready for going to school. Introduce distractions. How about putting a little music, maybe a nursery rhyme that the child likes, or putting some other music, or have two people talking in the classroom, or shifting the child's table from a 1:1 cubicle to a group area where there is noise, people are going, people are coming, so that there is distraction, so that child is ready for going to a school environment. And building language concepts. Teaching to fluency is extremely important when we are looking at generalization. If a child can respond very, very quickly, immediately to a large number of instructions given, we will have better focus in the class. So it's not so much about fluency, but it's about the focus. So you're working on fluency, but it's going to help develop focus. If you're going to ask 20 questions and the child can sustain his attention and respond like this, he will not be looking at the distractions that are coming. So next we look at the advanced social emotional skills, which constitute a complex set of skills such as perspective taking, which was previously talked about, social awareness, relationship skills, empathy, pro-social understanding, and emotion recognition and discrimination. These are all pretty complex. And as we are aware that in the spectrum disorder, there are many children who are quite smart, very intelligent, excellent memory. They have everything in them which can get them out of the autism spectrum label. Then what are we doing and how we are teaching and what we are planning makes a huge difference over there. So children, I've tried to take an example over here about a simple thing like a pronoun. So when we are teaching children that when I am talking to you, I will be I and you are you, okay? When you are talking to me, you become I now and I become you. So the whole thing reverses. And the third part is when I am talking to her about you, then you become he or she. If a simple concept like a pronoun, which is about language comprehension, is where we are stuck, generalization in school, coping with academics, both are going to be difficult. So we are looking at language concepts over here. This also includes a bit of perspective taking. So there is a lot going on over here when we are teaching something as simple as pronouns. By the time a child is in grade 1 or 2, the child is already reading, he said this, she said this, they did this together. So any story that they are reading has so many pronouns. Now, if a child is not able to apply something as simple as pronoun and doesn't understand the concept of pronouns, schooling, academics, both will become harder for the child. So for generalization, to the neurotypical environment, to the complex environment that we live in, it is important to focus on such concepts. So when we come back to how kids with autism perceive the world around them, look at this picture where the father is calling and asking, so what are you doing, my son? And the child says, I'm playing with this, Papa. Now the child, as Dr. Kishore said, that the child doesn't know that my Papa doesn't know that I am playing with a car or a train. He thinks that he can see what he is doing. So perspective taking, emotion recognition, discrimination skills over here, which are related to social cognition, become extremely essential in moving our children to the real world. So this is where the whole concept of theory of mind comes in, which is the ability to understand what others feel, know, and think. And theory of mind is all about covert behavior, what is going on inside, how we think, how we come to our beliefs, how we form our belief systems. That's all about theory of mind. So theory of mind skills are important factors for the development of both emotion recognition skills and also for peer acceptance. A lot of times we teach our children to go out and say hello to this one, say hello to that one. So if you actually look at the real world and you look at children below 5, 6, 7, they don't say hello. They just come. They just start talking. They just start playing. They just start asking for things. So are we teaching a right skill to our children? We need to look at that. Maybe we are thinking that greeting is a great way to start with, but is it really? We need to look at the environment, we need to study the environment, and then decide whether it is a skill that we need to teach our child. So peer acceptance doesn't start with saying hello. Peer acceptance starts with doing what the peer is doing and understanding that. So in theory of mind, we are looking at executive function, we are looking at emotional self-regulation. It helps with peer relationships, engaging with peers, playing with them, understanding them, maintaining a dialogue or maintaining conversation with the peer, and finally building family relationships. So theory of mind is a very big jump from moving from the 1:1 therapy room to the classroom, to the real world that we are looking at. So when we are looking at theory of mind, it is about the internal states of being. So thoughts and beliefs. So let's look at how do we form thoughts and beliefs. We form thoughts and beliefs which are based on conditioning from our previous histories of reinforcement or punishment. You go somewhere, you are treated well, you form a good, you are reinforced, so you are going to go back again and you'll tell yourself in your mind that, oh, they are so nice people and I really enjoyed being there and they really welcome me. So you are beginning to form some kind of a belief system over there. So what kind of exposure the child is given, how the child is responding and getting feedback from the environment will form beliefs and thoughts. Children are sometimes go to school and they are overwhelmed by that environment. They are not ready for that environment. So they engage in behaviors because they want to distract themselves from what's going on over there. They are overwhelmed. Okay, what kind of a belief they are going to form? They might say that, oh my God, this is a very scary place to be in. I don't want to be there. Okay. It is a different matter. They get into the habit of wearing their school dress, taking their bag and going there. But what's going on inside them could be fear and, not wanting to be there. Beliefs will always affect how you act, how you behave. Okay, and it also affects your feelings and emotions. So how do we encourage a child by providing positive reinforcement in different environments is going to build those beliefs. A lot of older children with autism come back. In fact, recently I was working with a child and he is quite young, about 5.5. He came back and he told his mother that my friends don't like me. And we were like, from where has he learned and heard, or has he perceived by looking at their faces? What did he do that he understood that nobody likes him? So when we come back to teaching emotions, how do we teach emotions? Many times we start by teaching emotions by showing them cards or showing them pictures of people, and we teach the child to label that this is happy and this is sad. We many times don't even know whether the child is looking at the color of that picture or is looking at the eyes or it is looking at the brow. We don't know what feature of that picture the child is learning. So are we doing the right thing by teaching a child something as simple as emotions, basic emotions from picture cards? And the answer is maybe not, because emotions, they emerge, they are observed in context. So if the child is not learning the context, even if he can label the emotion, he will not understand the emotion. So we need to go back and teach the context and teach the emotion related to the context. We look at expressions. Emotions are extremely dynamic and transitory. So you could be smiling 1 minute and the second you are serious. We have to teach the child to look at that, to grasp that, and not just label a picture, because maybe it may not really help in understanding emotions. This is all available on the internet. There are so many emotions. Okay, even if we teach the child to label all the emotions, we may not be able to actually, we may not sometimes also agree on a certain emotion, because you might say that she is looking worried, and I may say that maybe she has a question in her mind and she asks a question. She wants to ask a question. So agreement on emotions will also depend on the context. So if we have something like that, because we are looking at theory of mind, we are looking at emotions, understanding emotions, which is a higher level advanced skills. If I show you this picture, which word best describes what the person in the picture is thinking or feeling? So I hear somebody saying sad, and I hear someone saying confused, right? We are ourselves not on the same page. Imagine when we are looking at a child with autism who is struggling with so many things, and we are trying to teach emotions. So teaching emotions basically from those basic cards may not be a good idea, really. Another one, which word best describes what the person in the picture is thinking and feeling? Shocked. Okay, everybody say shocked? Scared. Oh my God. So there you are. Already we are not on the same page as adults, neurotypical adults. So think about how to teach children these skills. The idea is to think about how do we ensure that the child is understanding the concept of looking at somebody's facial expression and saying, oh, this person is looking confused. Are you confused? So teaching that to the child. So according to the SEL model, children's effective social interactions are based on 5 social and emotional skills: self-awareness and social awareness. They both rely on emotional knowledge. How am I feeling? What is the context in which I'm feeling in a certain way? All right. And the social awareness of other people in that context. These are both about understanding emotions. Then we look at self-regulation. Can I regulate my own behavior? Can I regulate when I am feeling angry, but I am not going to say anything? I'm just going to be quiet. I will just walk up and down. You're upset. Many times parents self-regulate so beautifully by walking into another room and talking in their differences rather than in front of other children. That's self-regulation. So if parents are not able to do that self-regulation and they get upset, then how do you teach the children to self-regulate and breathe and be calm? These parts of the model, self-awareness, regulation, social awareness, they lead to building better relationships, and they lead to responsible decision-making. Decision-making is dependent on learning those basic skills. Okay, and that's what we have to navigate and teach our children to navigate through, to understand when they are moving from the 1:1 therapy to the generalized natural environment. This is something that we need to do when we are looking at social awareness and self-regulation, where we are teaching the child to send, to receive, to experience affective messages. So before we go on to affective messages, which is about I'm feeling happy and you are not looking happy today, you are worried today. We are talking about sharing these messages, teaching the child. So you set up an environment in the classroom, in the 1:1 setup, where you're teaching a child that if somebody is just kind of pressing their head, then they need to walk to that person and say, are you okay? Are you having a headache? Can I do something? This is where it starts. When it starts in that 1:1 setup, then hopefully it will transfer to a generalized environment. So sharing these messages with other people of affection, of caring, of expressing, asking if they are worried, is something that needs to be worked on. identifying what are the positive emotions, what are the negative emotions in other children. These will help with improvements in social interactions. So here are some practical strategies for promoting emotional regulation. So contrive situations to teach emotions in context, not from flashcards. Train with multiple exemplars to build generalization. So if we are teaching somebody to look at someone's affect of pressing the head when they are not feeling very well, or putting the head down and expressing. So there are different ways of expressing feeling unwell, not just pressing the head, but putting the head down, or maybe closing the eyes, covering the face, okay, or just having a worried expression on the face and sharing with somebody else. So reading the facial expressions. These are multiple exemplars to teach things. So we need to build these examples in our environment to teach them for generalization. Teaching to recognize emotions through facial expressions, through tone of voice. If it is an irritated tone, many times children understand. They say, no mama, it's okay, are you okay, please hug me, and they'll kiss and they'll do all that, because they do understand certain tones. But then they get limited on those tones. So expand that repertoire so that they are able to understand different kind of tones. Kindness, what is a tone for kindness? What is a tone for sharing love? So these are different tones and different facial expressions. We need to teach our children that when you are standing with 4 other peers, and you're talking about your favorite cars, then, 1 minute please, favorite cars, then look at the other person's expression. Is it bored? Because if it is bored, then you need to change the topic. You need to talk about something else so that the child is ready for that real world environment. Observe non-verbal cues. Some more things here are about reading the hidden rules within a context. Nobody tells us that you need to be quiet during an examination. We just look at each other. Maybe the teacher has said once and that's enough. We were never told twice. Being quiet in formal environments. So these are hidden rules. We look at the context around us and then we know this is what is expected. Reading context. So a child running to catch a bus versus child running as a dog is chasing him. They are 2 different contexts. In both cases, the child is running. Teach the child to differentiate, to discriminate between them. And teaching the children to maintain personal space boundaries. It's an unsaid rule that we follow. Knowing social rules, behaviors which are acceptable at home. I can open the fridge at home but not in somebody else's house. And we teach perspective taking about false belief, knowing that seeing leads to knowing. What is the meaning of seeing? Sometimes the children will say we see with our eyes, but they don't know what is the meaning of seeing. So teaching the meaning of seeing and then teaching them seeing leads to knowing. False beliefs, true belief, all of that. Finally, just one final slide, that interdisciplinary teamwork here, collaboration between the therapist, the educator, the school teacher, and caregiver is absolutely essential for success. And making sure that the child is able to transition from an environment which is structured and protected to an open environment. Thank you very much.
Thank you so much, Dr. Smita. That was an excellent presentation. Very beautifully summarized the importance of language comprehension, ABA principles, and also contextual teaching, and most importantly, how to prepare the basic school readiness skills before we actually put them into the classroom. This we always miss out. We think that because the child is doing so well in the therapy setting, he's ready to be in the school setting. No, that doesn't happen. We have to really prepare, and ma'am has put it up very well. Maybe we can take one question, looking at the paucity of time. One question we can take if there are any. Yes. Can we have the mic over there? And you have to be really very quick, madam, in asking the question. Okay? Yeah, you can ask. Be loud enough.
With your rich experience as a behavior therapist, we understand that our logo has a neurodivergent symbol in it, where currently, now I'll tell you from where I'm coming, asking you this question, that as a trainee, I've learned ABA and different modalities of intervention working with children with autism. And we are shifting from a deficit model to more of accepting the variance in the way they think, they feel. So when we say theory of mind also, the cognitive theory of mind, the affective theory of mind, and meta-thinking. So I want to ask you, ma'am, that when we say that behavior change, when we are working on behavior change, are we still working through a deficit model of behavior, that they are lacking something and yet that's why we are helping them change a behavior or learn some things, or moving more towards accepting where they're coming from and strength-based, where modalities of TEACH and AACE and all of that is coming? So your view on that, ma'am.
Very nice question. Thank you very much. So when we are trying to change behavior, the question is, I wouldn't want to categorize it as a deficit or a strength. I would rather say, what are we trying to change? Okay, we are trying to identify what are the areas where work needs to be done. We need to know where the child is right now, and we need to know where the child wants to go or can go in the short term. All right. So what are we doing? We are identifying our target behaviors. Okay. So we are not saying the child can't sit, so I need to teach the child sit. We just say the child needs to learn sitting so that the child can do some activities on the table. So it's how you frame that statement. That would make it deficit-oriented or strength-oriented. ABA has also moved a lot since early days. So we basically formulate the constructional approach. We form the constructional approach of ABA, where we are not looking at the deficits. So for example, if a child is hand flapping, I would say I would like the child to actually engage with his hands and work with his hands. Automatically, if I keep the hands busy in so many other things, the hand flapping will go down, right? Okay. And if the sensory person says that you need to work on the sensory part, then we'll say it is your to work on the sensory part. We'll work on teaching the child to engage his hands in some constructive work. So I hope that answers.
Thank you so much. Big round of applause to the presenter, please. Yeah. I think it's lunchtime. Let's all break for the lunch. Yeah.
Just one more.
So sorry about it. So we have one more session and the next speakers are ready. Before that, there's one small tip for the participants who want to ask questions. We are running short of time. Please frame your question. You all have a pen and pad. Write the question down which you want to ask. If you get a time, be quick in asking the question. Right? Thank you.
Small announcement. So we have the paper and poster presentation between 3 to 4 p.m.
Hello. Good afternoon, everyone. These are the participants selected for platform. Please note your name. If you find your name missing, just let me know. Feel free to contact me. We have 2 sets of posters in 2 screens. These are the names. Just let me know if your name is missing in the list. Second slide, please. Yeah. Second group of participants. So total of 16 posters and 7 platforms. Just feel free to message or email if you feel your poster is not displayed over here. Just kindly take a picture so you can review, and feel free to mail if any queries. Thank you.
Moving on to our next talk, the Adult Autistic Profile, Evidence-Based Approaches to Support and Care. I invite our next speaker and chairperson, Dr. Harini Aturu ma'am and Dr. Ravi Tangela sir as a chairperson. I request Dr. Ravi to please introduce and invite Dr. Harini ma'am.
Good afternoon. The speaker, Dr. Harini Aturu, she did her MBBS from Karnool Medical College and then MRC Psych from UK, MSc in Psychiatry, a diploma in Pediatrics, and she has been certified therapeutic play practitioner for differently abled. She has 22 years experience, including 12 years in UK. And she works in ICGC, Inla Child Guidance Clinic in Hyderabad. She has been to many conferences, presented papers everywhere, and recent AI in Autism Interventions, Cognibotics. It's a 12 months prospective studies in Rainbow Hospital, Banjaras. And she has awarded with Servier Young Researcher Award to 2021 and Servier Young Researcher Award 2025. Ma'am, please start the presentation. Thank you.
Thank you. Good afternoon, everyone. Thanks, Dr. Ravi. And thanks to Yashoda Hospital to invite me. My topic, Adult Autistic Profile, Evidence-Based Approach to Support and Care. I know you're all hungry, and I'm talking about an adult autism. So I won't take too long, okay? So before I moved back to India, I worked in Sheffield Adult Autism and Neurodevelopment Center, where I was involved with adult ADHD assessments. So it's not that they didn't have ADHD at that time, but it was missed or not recognized. And also we had adult autism assessments as well. So, you know, when we went through longitudinal histories, some of them like we were diagnosing for the first time. So it was, as a trainee, it was eye-opening. As soon as I finished my training, I worked there. And it opened up a different area of neurodivergence. Every day, my clinic, there was like 3 hours of a slot, and I had to do like a one-stop clinic where I had to go through all the history of the person, their family member as a collateral history, review all the previous records. And at that time, adult ADHD, adult autism was a new evolving topic where we had only 3 centers at that time, semi-private ones. So I'm thankful for that kind of rich experience, and I hope I'll make justice to this topic. So, to start off, autism is a lifelong neurodevelopmental condition. So, there are 2 diagnostic manuals which we generally use, DSM-5 and ICD-11. Okay, the first one, 1952, first initially autism was classified under childhood schizophrenia. Okay, now we have been listening that autism has increased. And one of the reasons they have been saying that because of the diagnostic criteria change. Just let's look into what is that diagnostic criteria that changed, that the numbers have increased. And why is that we are now ending up diagnosing an adult who has grown up, not seen any therapist at any time, now coming and having this you know, assessment of autism or ADHD, and what's happening for them. So, in criteria A, you must all be knowing, some of your parents, I understand, some of your professionals. So I'll try to cover, so everyone is, you know, not out of space and understands what I'm saying. Here in criteria A, persistent deficits in social communication and social interaction across multiple contexts. So there are 3 points in here. So it's a social emotional reciprocity, non-verbal communication, developing, managing and understanding relationships. Okay. The second criteria, there are 4, but they said at least 2 is enough. So your stereotype repetitive motor movements, use of objects and echolalia, these kind of things, even you don't have that as a child, lining up your toys or doing all those kind of stereotypic behaviors, and you don't have your hypersensitivities or hyposensitivities, insistence on sameness and highly restricted fixed interests are both, at least 2 are enough to go on to make a diagnosis of autism, which is autism spectrum disorder. Okay, and the next criteria is symptoms must be present in early developmental period. Then what are we doing after, I get IT ones, adult ones, who come and say, I may be having ADHD, I may be having autism, I'm really struggling, I want to get assessed. They are nowadays coming and, beautifully asking because they want to know, they want to understand, they are going through struggles. They had those struggles as a child as well, but somehow they were masked, somehow they managed. They have been seeing, their social peer groups to learn. I had so many children saying, I don't know when, during the breaks, what to talk. If I start talking, I talk so much about the books, so they don't like me. And then I stopped talking, I started listening. And I started, listening for whole hour what they talk, go home, write in my book to understand what themes are coming up. And then I understand that these people are talking about maybe about makeup, maybe about social media, about Instagram, and maybe about politics, very few. So these are the topics which I'm not aware. So I have to go and learn. This is not one girl who said this, the teenager, after, in her teenage group. And there are so many children who don't know, who want social kind of thing, but felt awkward to, express themselves. They saw their dad, one of them when they were 12 years, and they saw that the dad was making a joke, and that's how he talks with his friends. So he thought that's how he should do. And so he went and spoke, and he was in a US, and that boy was bullied. So he thought this is not working, and then stopped. So for a long time, he went into that kind of a shell, and leading on to depression, though they want. It's not that the typical textbook description of these people don't know emotions, or probably they know, but at certain level, which is not the same as others can beautifully put words and describe and explain. I see many couples, wife coming and saying, he's such a good man, he takes care of everything, even before I can ask. But he never said, that kind of a loving word, or, that kind of a, they struggle. They want that kind of, mothers somehow have coped, learned that this child is this way, and they have been okay. But if you get a wife who is very expecting, who wants everything to verbalize, and this person is like, I can't take so much of interactions, and shutting down. And, it's not that he doesn't love his wife. It's just that, that kind of autistic brain is not able to accommodate that kind of a, jumpy kind of a bubbly girl. So now, why do I say all this? Yeah, so may not become fully manifest until social demands exceed limited capacities, or may be masked by learned strategies in later life. So what they are saying is, though it starts early in life, there may be times where these have not been manifested because of the bubble or the household structures they have been growing. And the father can accommodate, one teenager when she was in BTech first year, second year, that's where first year things started breaking. Of course, in inter, but it was blamed on, the institution, that they were very strict, they were rigid, so it was overseen. And then comes into BTech, and she was struggling with making friends. It's not just there. Whenever there were holidays, when she went to the grandparents' house, or any kind of social interactions with the family members, they struggled a lot. The child struggled a lot. And always father used to protect. But you have to understand, when these children, after growing up in this kind of very protected home environment, structured and everything, as no one says no, you're not challenged, anything, you're still taken care. They go to universities, they go to into working places, they have lots of fights, they have lots of breakdowns. So we need to, you know, these children, they are not knowing how to communicate or to express, and they are misunderstood or thought about being arrogant when they're talking in the meetings that they're cutting, or, you know, they don't know when to stop. They're waiting, they think they're done, they talk, and they get told off, you know, yeah, as if they're over speaking. So it's very important, you know, to understand that it's not, the phrase is this one, like, until social demands exceed limited capacities, or may mask by learned strategies in later life. Symptoms cause a clinically significant impairment in social, occupational, or other important areas of, so they have to be in all the domains. Now, these disturbances are not better explained by intellectual disabilities. So what it means, back in 2013, when the DSM-4 was there, so we were told to classify based on the hierarchy, like ADHD. If someone has autism, then we have to say autism, maybe with ADHD-like symptoms. Then co-diagnosing was not there. And then learning disabilities was the hierarchy. If that is there, then you don't have to specify autism. So it was that way. But comes the DSM-5, that's where they started changing. They can be co-occurrence and you know, you can classify both together. And nowadays, more and more we come to understand about these people. So the person may have ADHD, may have autism, and it depends on how much autism they have and how much ADHD they have, or just a bit, or just a bit. So the more we go on, we will try to understand, and it's not like exclusion. Sometimes when we see, you know, when we were getting referrals at that time, the GPs would see which one would be easier to fit in, or you know, but they had both. But at that time we were told, you may not, you know, we would send them. Most of them wanted ADHD diagnosis because there is some treatment. They believed their cognitive difficulties can get better because of ADHD compared to autism. But when you go to pharmacology, it's not the same. So they may have certain difficulties. And like yesterday, Dr. Isha was going through about all the comorbidities and what are all the other things, you know, about their sleep issues, irritability, and anxiety, depressions, and all sorts of mental health comorbidities also we should take care. Now, just increase in numbers, want to bring this point. So 5 subtypes were there. Now we have all brought into 4 subtypes together into ASD, and the rest is moved to different place. They were tried, and impaired social reciprocity, that's present. Impaired language and communication. So previously, if there has to be impairment in the language and communication. Now, there is no delay or anything that's they are asking. Only non-verbal communication deficits are recognized. So a person who doesn't have anything in the childhood, who has not shown up anything, you know, even the restrictive, repetitive, they were compulsory in DSM-4. When you come to DSM-5, criteria 2 out of 4, you can skip them. So you may not show anything, but you still may have those symptoms. And the onset should be before 36. Now they said social demands exceed limited capacity. So the autism diagnosis is not just ending there. It may, you know, based on how difficulty this person is going through, we may have to do these assessments. And the differential diagnosis, some of them, you know, when the things are not so clear, in sense like you see again a young female who is in their BTech, you know, and they are having some social difficulties or interactions, and you don't typically, initially, this was when I first came to India, and I had one case where I was like, the way she was, you know, having difficulties, I was standing into autism, and the therapist said it's a social communication disorder, where it's only about the social, you know, there are certain criteria, but it doesn't talk about the restrictive, repetitive, or, you know, the 4 other parts of the ASD. So it's very important. This is because now what do you do with the diagnosis? It's not about that. It's about now the family will understand, and the person also will understand, okay, how do I behave? How do I change? these children, how they were at 10, they differ by 20s, and they start self-reflecting that they want to learn, they want to change. And beautifully, somehow, these ADHD children who were always shouted, you're not studying or anything, by 20s or 30s, that's when they get more interest, and that's when they come to, that they want to do this course and that course, and somehow beautifully they present differently. Now, let me, when I see ICD 11, okay, they have not changed in what these were, but they also said that the social becomes fully, characteristic symptoms may not become fully manifest until later when the social demands exceed limited capacities. So they are giving that space because some families, some cultures, they can accommodate those behaviors without any difficulty. Yeah. And some individuals with autism spectrum disorder are able to function adequately in many contexts, though exceptional through exceptional effort, such that their deficits may not be apparent to others. A diagnosis of autism spectrum is still appropriate in such cases. Okay, so bear in mind, they are the ones who need more help. Okay, how do they present? Yeah, difficulties in education and employment. They have been very studious in their studies. They are very toppers. They only know how to study, but they don't know how to, these kind of social interactions are very difficult, and problems in relationships building. This is one thing. They want to make relationships, they're very intense, they're very serious, they get very hurt, they're very sensitive. Once it breaks, they start worrying, why am I not learning, or what is happening for me? They present with anxiety, depression, and other mental health problems. They may go for substance misuse as well. Now, forensic history, not per se, they like to follow rules, but they may also break rules. It's not like, they sometimes become very resentful. In NHS, they were saying that people who complain more or sometimes somehow with autistic features because they want things in certain ways. And forensic history, if they have a bit of learning disabilities as well, where learning disabilities are the ones who think they want to do and they think all their peer group is doing, but they don't know how to get out of the trouble, or they don't know fully how to execute certain things and end up with trouble with law. So may present with hyperactivity. Yesterday also Dr. Isha was mentioning there's a high comorbidity with the ADHD. So it's not like autism, if autism you can't treat, or there are core features there with medications you're not changing, but whatever the other core comorbidities are there, if you start treating, they are able to handle these core features better. So NICE guidelines suggest this autism spectrum quotient 10 items 1, and yeah. Comprehensive assessment is needed, where again core autism features, you should, these are very long longitudinal histories. Nowadays it's becoming very tiring because autism, anxiety, depressions are gone, OCDs are also gone. They want either ADHD or autism diagnosis. So it's taking long histories, starting from their childhood, even pregnant and post-delivery and all these histories, along with the collateral history. I say I need to see the parents as well, because self-reported can be misleading, maybe overdiagnosed, so I prefer to have a collateral histories here, even at this age. Assess early developmental history, behavioral problems, functioning at home, in education and employment, past and current physical and mental disorders, other neurodevelopmental conditions, all should be looked. And if they have any hyposensitivity, and attentions to details, observation for core autism features during the assessment also is important. Now, these are some scales which are recommended by NICE guidelines in people who don't have learning disabilities. Out of all, DISCO, the Diagnostic Interview for Social and Communication Disorders, it's classed as more reliable, right from toddlers to adult age. And if they have learning disabilities, autism diagnostic interview with a revised one, and autism diagnostic observation schedule. These are all expensive tests. They need very standard, lot of training as well. This one is a clinical and research instrument. These all take a lot of time for assessment of autism at any age, toddler to older adults, regardless of presence or absence of ID. Okay, and this is another tool which they have suggested as well. It's from the Royal College Psychiatrist interview guide. For, I don't know if can I press on the link to open up, or okay. Anyway, I have got this picture. So can I try pressing on it, on the link? Link me the press chandi. Okay, that's fine. So this is the full. It's similar to DIVA, where it has a long questionnaire, and you have to go through in a psychoanalytical way, not yes or no questions, because yes or no questions they don't work. And you do your cognitive abilities, IQ testing, functional abilities, coexisting neurodevelopmental disabilities, mental capacity assessment, risk assessment, medical problems, all should be assessed. And you thoroughly look along with all this if they have anxiety, depressions, and what's happening. All this also you will look, and you will also look if they have any other neurological disorders, epilepsies, medications, and all that. Their physical disorders, like what they are going through. Do not use biological tests, genetic tests, or neuroimaging for diagnostic purpose routinely. Okay, as Dr. Sarah was also in her thing, she was mentioning, autism is a behavioral diagnosis, not a genetic testing diagnosis. So, however, if there is a recommendation, there is your clinical need, then yes, you go on to do all the tests. Okay, and risk assessment in these people, very important. Is there a risk to self, risk for harm to others, self-neglect, or risk of exploitation? These are very important when you want to place them in any kind of residential places. So for this, the behavioral assessment, I am sure there are left and right behavioral therapists here who have drilled everything. So yeah, they have done all these assessments. The same functional assessment will be important. And yeah, no medication is for core symptoms. However, medication for comorbidity. And let me. So the other part of my talk is about general principles of care. So the staff who are working with them, they should partner. See, this should be developed as a culture into each setting where these children go for their services. Okay, what I mean by that is, only when emergency you don't go and ask for it. Okay, in hospital, like yesterday Prachi was saying, when the child was taken, when the adult was with the autism was taken, that's where it was a lot of stressful for the person, for the family, and for the hospital setting. They did the same procedure a few months ago, and it was all very planned, and the person who was doing it, they knew what they were doing it. So what sort of condition do these people go through? How should they be, when you enter the room, how should you greet them? How should you keep them, informed about what is going to happen, reassure them? As the family gets stressed, it's important, as Dr. Thomas was saying, there is co-regulation. So now this, taking them into hospital, family itself is getting stressed, then this person gets even more stressed. And looking at these people stressed, any nurse entering, they get more stressed. So it's very important that, how we train all the hospitals moving forward, that we have a lot of neurodivergent people coming up. These should not be just one-off kind of thing. It should be something like a car seat belt, where there are airbags, and all the cars are standardized to a certain extent. All the hospitals should also be neurodivergent safe. So it's not like a thing you have to think. So when the person is going into the hospital, who is in crisis? The child is in crisis or the adult is in crisis. Not the family, not the hospital. They should have their protocols. They should also have their co-regulation. Be prepared for this. And also it's like level 1, 2, 3, 4, where level 1, yes, they are doing well in the wellness in the community from terms of mental health. I'm just going through quickly. Level 2 is when they see actively mental health services, outpatient basis. 3 is when they are in crisis. So before they go into crisis and get into inpatient hospital admissions, when we were in UK, we were keeping inpatient admissions for psychiatry very minimal. That's very minimal. So even before going into crisis, if we can have strategies and plans before they break into that extent, whether it be even a medical emergency also annually checking up and having all this, and also training basic, all the setups also should be having these kind of trained facilities. Healthcare, and in all settings, it should, how the rooms should be there, no noise, all this should be a part of it. Okay, and how the family also needs interventions from the mental health point of view, and the partners and carers, how they should be involved in these people, for their loved one, how they do this journey, and professionals, how we support them in this journey. Thank you. These were all my references.
Thank you, ma'am, for the lucid presentation. And I would also spend 1 minute to discuss about one burning issue, that in future, there's so many children, so many CDCs are there, more than like 50,000-60,000 children are right now going for therapies, but we don't have enough resources for future, for next 15-20 years. We don't have enough resources for handling these adolescents and adults. I think it's a very big problem. And also, parents ask us, what kind of jobs, once if they're having a good IQ and they're doing good in their academics, but what kind of job profiles do they suit with these low social skills? And also what kind of partners? So these questions they have.
Beautifully asked. I only focused on health setup because that was yesterday's burning topic on my mind when Prachi was mentioning about what was happening. So jobs. These children or these young adults, they have very good IQ. They are no less to anyone. Given, their work, they do it. But what stops them or what struggles them is how within that system, how the colleague greets them or how the boss, respects them, or how the feedback is given. All these kind of things bother them a lot. So it's important, how we, as I said, this kind of neuro.
Guys, we have an RCI test. Please be seated. Please don't go out.
Yeah. So we should, just like as I said, safety, how we have gone up with CPRs in all over, when there is a cardiac arrest, how we take care. This is we are providing a quality of life for these children, so they live happily and the families happily. So we have to step up and bring these kind of neurodivergent safe environment, not just one-off when they are going somewhere or something. It should be ingrained in the hospitals, in the dentist kind of places, in kind of every space, because now there is a rise in neurodivergence kind of a population, neurotypical neurodivergent, and these players along with the parents, really very important that we are more giving space. Vasudhaika Kutumbam, it's very important that we don't have big families. We have become nuclear families. Then how will we teach? Maybe we ourselves have that kind of, I can't tolerate them. I can't, when we go to parties or marriages and this is the gossip, how can we expect our children? So we, whatever generation we are done. At least we have to bring the future generation into a space where everyone, they can co-regulate well, And that's where I just want to give one example here, because one mother, the child had a talk or a fight with the other friend, and this child slightly neurodivergent on the spectrum, and they didn't want to talk for some time. After that, he got bored, he called and talked. Mother was getting angry. Just now you had a fight, why do you want to go and talk to that person again? Leave him, don't talk. So who is who is training them, who is teaching them? The mother's feelings are being taught in a wrong way. These children, they fight, they get on together. Please don't interrupt your thoughts and your feelings onto them. That's how they learn. Let them regulate themselves, they regulate better. So it's parents also who think something may happen to their child. When they are labeled, it's not labeling. Let's not say that labeling, stigma, or we are trying to provide whatever is needed for the child, the interventions. So I think I have moved all over the place, but my intention is the workplaces, hospitals, right from the child is born, right till they go to school, work, relationships, old age, geriatric, everything, we have to have that parallelly into this kind of ergonomics. What you are now, we want luxury. Just like that, neurodivergent kind of a safe environments also should come into place.
Thank you, ma'am. And due to lack of time, Dr. Somashekar sir told we'll break for lunch. Any questions, please ask madam in the lunch time. Is that okay? Thank you.
Thank you, ma'am. Thank you, sir. There is an announcement from that you have to do the pre-test. Okay, here you can see
This
for
is only
RCI
for,
points.
CRE,
Yeah,
CRE, only CRE.
So please scan over there. QR is in front of you, and yeah. See, write your CRR number properly. There should be no mistake. Everyone has to fill this.
The other people can go, only CRE should be here. Thank you so much.
If there is any doubt, please come and ask. If anyone have any questions, if they have any issue, please come and talk to me. I'm here. There will be pre-test, post-test, and as well as the feedback form. Okay, so you have to do that. Slowly we will present you the slides regarding that. Right now only pre-test we are doing. After lunch it will be. After tea break, like that. We will see, and the situation will do that. Everyone has to do compulsory attendance. So for getting the points.
All the CRE participants, please ensure you sign in the attendance registers. Otherwise, it would be difficult to process your CRE points. So please ensure, meet the organizers, ensure that you sign on both the days, and fill all the forms, feedback, pre-test and post-test. That only ensures your completion and eligibility for the CRE points.
Come on.
हाँ बस आ रहे हैं बस आ रहे हैं कॉपी पेस्ट करवा के okay it's coming out this much is it possible if I connect I think it's not possible if I'll connect my laptop I have this two we have to copy one and two the first and the second one
Your name is?
fourth number Nishia fourth
Spell it me.
tell my name Nishi
Nishi.
so we can open into taskbar left that's all we can
Hello, good afternoon, welcome back. So let's continue with the post-lunch session. We have Dr. Varsha Monica, pediatric neurologist from Yashoda Hospital, to talk about early brain development and autism. To chair the session, may I welcome Dr. Raghupati and Dr. Ranjit. Dr. Raghupati is a pediatrician from Yashoda, and Dr. Ranjit is a pediatric orthopedician. Thank you, sir.
Check. A very good afternoon, everyone. Welcome to the post-lunch session. Hope everyone's settled on. So the post-lunch session will be by Dr. Varsha Monica Reddy. She is a pediatric neurologist, Yashoda Hospitals, Secunderabad. And the topic would be early brain development and autism. Over to you, madam.
Hello? Yeah. So, good afternoon, everyone. Everybody settling. It's going to be a little boring. I think they've given me a very dry topic post-lunch. So whatever you have gone through from yesterday, so all the interventions, whether to give this drug, what is about the gut, and what about the newer therapies, everything is going to consolidate to why this autism is happening, what is the etiology, how our brain from the development is influencing, and the role of epigenetics. Thank you all for being here. I want to start by telling you what this talk is not about. So it's basically a story of a 150-year-old research and development that has gone into brain development, how the human brain builds itself from a single cell, and what happens when the process is redirected, correct? So by the end of 30 minutes, whatever your discipline is, whether you're a therapist, specialist, pediatrician, counselor, irrespective of that, I think you'll walk out with a more rich biological framework for understanding what every child with autism is dealing with. So let's begin. So there are 6 frameworks that I'll be going from. So we start with a little bit of history and to where are we now. Our story of brain development begins in the 19th century in Spain. So when Cajal was working with Golgi staining technique, proved that brain is made of individual cells. There are neurons that communicate across the gaps, which we now call as synapses, correct? So this was revolutionary. And in 1949, Donald Hebb's synaptic plasticity rule says that cells that fire together, wire together. So gave us the molecular basis of how experience shapes the brain. And Hubel and Wiesel's Nobel-winning work on critical periods in the cat visual cortex showed that the brain requires specific experiences during specific time windows. That is the basis of early intervention, what we are dealing with in autism. Now, there is a century of discovery in brain development. So this timeline, it captures about 100 years of acceleration. So it took us 60 years from Cajal's finding out neuron to developing the most advanced imaging, that is MRI. But since 2000, the pace is breathtaking. There is epigenomics, the Human Connectome Project, which showed the 1200 brain connections, and now single transcriptomics, which profiles individual neurons in the fetal brain. So each advance has transformed our understanding of the brain grossly, and from a psychological construct to autism being a neurodevelopmental disorder now. So which explains specific moleculars, connectivity, and the genetic condition now. Now, where does the brain development start? So I want to make a statement that I hope you change this, like how you counsel the patients from today. because brain development does not begin at fertilization. It begins with the biological state of eggs and sperm, which is shaped by the parent's diet, by the stress exposure, by the toxin exposure, and health, sometimes years before conception. How is this happening? So, there was a study by Marcus Pembre which showed that grandfather's nutrition during his own prepubertal growth affected the grandson's mortality risk. It's surprising, right? So, through the male line, of course, and through the sperm methylation. So, David Barker's Dutch hunger winter, you've heard about it in the history. It shows that a grandmother's wartime starvation has affected their grandchildren's brain development. So, for autism, when a family asks us, why did this happen? And I think we need to look back 2 generations beyond, correct? So, it is not just at the pregnancy. So, basically, what the clinical basis for this is prescribing folate is not enough. Prescribing a healthy lifestyle, stress-free environment for the mother, stress management among the expecting couple, toxin avoidance years before conception is what the epigenomics tells us. So once the conception happens, what occurs in those first few weeks is very critical. It is all time dependent. So that is why the urgency of stressing on these factors is essential now. And brain development coming to in utero, once it starts, so most of the expectant mothers, by the time they realize they have conceived, the brain development has already started in week 3 and week 4. Correct? The human brain is built in 9 months with extraordinary precision. Neurulation happens in weeks 3 and 4, but before most women know they are pregnant, which is why folate supplementation must start even before conception, during the planning. Between weeks 7 and 16, the neurons are generated at 250,000 per minute. They migrate to the precise cortical layers from the deep inside. So every stage of brain development is extremely sensitive to disruption. It could be a genetic cause, it could be a toxin exposure, it could be infection, it could be nutrition. The first thing is a brain being affected. And each insult will leave a neurodevelopmental fingerprint. So the neurulation, the first architecture, I'm not going to go with the folding, unfolding and all those things. And failure of any of these things during the brain development due to multiple exposures that we discuss can cause malformations which we see, anencephaly, spina bifida, holoprosencephaly, lissencephaly and encephalocele. So neurulation is the first act of brain architecture. By day 22, before most women have a positive pregnancy test, the neural plate is already folding. So this is why folate supplementation must begin before conception, not after the missed period. And after the neural plate folding, there is neuronal migration and the cortical layer that is happening. So neuronal migration is one of a very beautiful event that happens where the neurons ride from the radial glial cells from the ventricular zone, which is the central zone of the brain, that is a core, to the peripheral cortical plate. So this inside out gradient means the earliest neurons, they settle deep inside the brain and the later neurons must pass to the outer layers. So during this process, so have you heard of torch infections, cytomegalovirus infections, which is very, very common. And this is one virus which can disrupt this architecture being happening at any stage. So this disrupts the process, producing cortical dysplasias, malformations, periventricular cysts in the brain, and alcohol exposure during this time also impairs this radial glial cells for migration. So these mechanisms explain why the timing of insult matters during the cortical development of the brain. Now, after the cortical development, there is next thing what's happening simultaneously is the synaptogenesis and synaptic pruning. So if you see this graph, it is most important in development neuroscience because at birth, we have 30% peak of synaptic density. By the age 2, if you see, we dramatically overproduce these synapses, far exceeding the adult levels. Then the brain prunes aggressively through adolescence. Pruning is something like a gardener chopping off the extra things that are not being used, correct? So during this time, so in autism, what exactly is happening is this pruning appears deficient in some circuits, leaving excess local connections. Those synapses are more, but the pruning is not happening. So these connections, local connections, stay. And in older adult-related issues like schizophrenia, the opposite will occur, meaning the local connections are cut off more than required. So the critical periods, what we deal with, the first 2 years of life, that is why our early intervention is based on, correct? These critical period concept means the first 2 years the synaptogenesis is forming, so that's why early intervention plays a role. Now after that is next the myelination. So myelination, it takes longer. So from birth till 25 years of life, so myelination keeps happening. It starts, the prefrontal cortex is the last, and it's only 20% myelinated at birth, where our executive functioning is happening, all the logic, correct? It continues even until our mid-20s. So that's why we are more mature probably after the 25, 30-year age, apart from when we look into our college time. So a lot of logic is happening, a lot of thinking, right? So this explains adolescent risk-taking also, and any impulsivity that we do, it's all because our prefrontal cortex is not developed. So everything, there's a science, it's not being mischievous or teenage. So for preterm infants, what happens is there is interruption in the maturation in the periventricular region because of the low birth weight and the white matter injury that happens, which is a predictor of cerebral palsy. And it is a neurodevelopmental disorder, correct? So if you see, prefrontal is the last to complete, and the spinal cord is the first to complete. Now what is epigenetics? The IT word that we are all listening, I think yesterday you would have had a lot of evidence-based medications, therapies, gut, folic acid, everything. But what is epigenetics that we are speaking about, correct? Epigenetics is a bridge between the genes and the environment. And it may be the single most important factor for understanding how these early experiences are sharing the child's brain. So there was a landmark paper in 2004 which explains that the amount of, it was a study done in rats, so where they showed that these maternal rats determined the methylation of the glucocorticoid receptor in the hippocampus, which permanently altered the stress reactivity for life. So basically it is about the stress factors influencing the maternal care. If it is high stress and low stress and optimal stress, how it is going to affect the HPA axis, which again is going to interfere with the cortisol production in the mother and the stress of the newborn. So this is maternal care and epigenetic programming. So high maternal care, what is the effect on the offspring? So there is increased expression in the hippocampus, there is increased glucocorticoid feedback, there is decreased HPA axis reactivity to stress. But in low maternal care offspring, there is increased response, increased hyperreactivity. So this is all science. So this is the most important clinical study. So when we say autism prevention and all, I think we should start with when the parents are planning, getting married, planning for babies. So the maternal care, I think now we have to come on more on prevention rather than treatment, counsel young couples to take care of their stress levels and provide adequate family support, especially for the mothers, correct? Now prenatal stress and epigenetic fetal programming. So this uterus is not just a protective isolating chamber for the baby, it is also a dynamic environment where it is transmitting everything that the mother is receiving, correct? So any chronic early gestation stress produces epigenetic changes in the gene. It permanently alters the offspring's stress response. So in humans, they showed that the infants of a depressed mother already have altered glucocorticoid receptor methylation in the cord blood before drawing their first breath. So we also do check cord blood samples in certain other studies. I think we need to check, this is already published. So these findings show that the maternal antenatal mental health care brings a lot of tremendous output on the offspring. In coming to the networks, the brain mapping, I don't want to go in a detail. If you can just see all these networks that they are there. So the human brain, as we know, operates through these major networks, and they're all interconnected. They don't work in isolation, correct? So the fundamental hypothesis in autism connectivity is local over-connectivity of these networks, and the long-distance connectivity is less. This is a very scientific evidence, and all the symptoms that there are there is due to these. So if you see, there is a default mode network, which is in the hippocampal area, predominantly in the prefrontal cortex. So the function of this is self-processing, social cognition, mentalizing, and memory. So in autism, if these networks are altered, there is hypoactivation. So there is hypoactivation in ASD during social tasks, altered internal connectivity, correct? So like you also can see in the central executive network, it is meant for working memory. In the language network, if you see, which is the Broca's, Wernicke's, and arcuate facialis. So there is phonological, syntactic, and semantic processing. So again, these white matter abnormalities cause autism symptoms that we see. Coming to the genetic influences on brain development, so we also see a lot of genetic conditions of autism, right? These are the major genes that we see. So autism is actually 83% heritable. It's published by a study in 2017. But the genetic architecture is not so simple. It's very complex, polygenic, and the heterogeneous variants that we see. So disrupting any of these components in these genes cause genetic autism conditions, and Fragile X is one which we see commonly, and even tuberous sclerosis, P10, MECP2, these are the genetic causes of autism. One more important cause, why we are seeing increased numbers of autism, what is the reason? So one of the major reason is preterm deliveries, increase in survival of preterm low birth weight babies, because preterm birth is a major risk factor for a neurodevelopmental disorder, and the risk of autism increases as the degree of prematurity is much lower. So extreme premature infants have a 7-time fold of increase in autism, and the mechanisms also converge with the periventricular leukomalacia, which is the pathological cause in preterm babies. So because the periventricular white matter is affected, the connectivity tracks that are there in that area impacts and causes autism. And there's also cerebellar injury associated, which is implicated. Everything disrupts the circuits basically. And coming to another major thing that we already spoke, infections and neuroinflammation. So torch infections most commonly, and CMV is one virus which can affect any time, and it can present in all parts, and it can present in any type of cortical malformations, be it ventriculomegaly, be it cortex, brain malformations, migrational disorders, anything CMV can present. So it is the most common congenital infection that occurs. So it disrupts the migration of the neurons from the deep inside to the cortical layer. So these produce cortical dysplasias, abnormal cortexes. And the broader concept also is maternal immune reaction to any of these infections is also known to increase the risk of autism. And nutritional influence, very, very important. See, the brain is built from what the mother eats. So we counsel the parents to take folic acid, high fat, rich protein, all these things, but we need to specifically also concentrate on what exactly they take and what is the dose that needs to be given in expecting mother. So folate and folic acid deficiency, autism risk is 40% high with deficiency of folate. And iodine, again, most common cause of preventable intellectual disability that we know in India. DHA, EPA, omega-3, also supplementation needs to be given in pregnancy. Iron deficiency also causes a lot of issues in the development period. Vitamin D, maternal deficiency, increased risk of autism, schizophrenia, and choline deficiency, so which is present in eggs and liver. So that's why they say to consume liver in pregnancy, correct? So taking care of nutrition is also one thing that influences the fetal brain development majorly. And toxin exposure, we all know no amount of toxins is safe in pregnancy. So be it tobacco, be it alcohol, so they all cause disruptions in the development of the brain. Coming to environmental neurotoxins, this we see in kids. Parents come with us tox screen and they say do chelation very commonly. So there's all toxin-free toys, paints, everything. They say lead-free toys. So yeah, they do have an influence on the development in the developing brain, because it is very disproportionately vulnerable during this first 2 to 5 years of age, because it lacks a very mature blood-brain barrier. That's why all the toxins are very easily entering the brain environment, and they have a relatively higher blood brain levels. So and brain also lacks detoxification pathways in that premature time. And coming to the most important preventable, reversible, avoidable thing is digital exposure and screen. So what exactly is happening digital media and the developing brain? So it is not just phone, screen or tab. So when we tell parents that to avoid screen time, they say we don't give TV, we give only phone. Or they say we don't give phone, we give only TV. So I think they think it is with respect to their eyesight or some weird things like that, the strain on the eyes. So every screen, even a background TV, is going to cause issues in the kids. So because it displaces the joint attention, it displaces the reciprocal response that we give, and it decreases melatonin, right? It completely aborts the melatonin secretion. So there is the sleep architecture is changed. The consolidation of the synapses is happening majorly in sleep. And the videos cause lot of overstimulation. So I'm going to tell it in the next slide. So digital screen right now are very controversial to tell the parents, like, to avoid screen, but we need to follow the guidelines, at least maximum in the first 2 years, completely limit. Tell them 0 is 0, not during food, not during sleep. They say, oh, he eats food, so 15 minutes in a day for breakfast, lunch, dinner. That's again coming up to around 45 minutes to 1 hour in a day. So the most concerning pathway in autism due to screen is the joint attention displacement. So screens precisely they capture the hours when children need face-to-face interaction, right? It is replaced by the FaceTime than the mother's face. So overstimulation and understimulation. So what we see in a normal Indian household is a child is there playing, so there is a grandfather watching a movie or some news, and there's a lot of noise from the kitchen, there's somebody playing music, there's so many toys all over the place. So the regulation, the child's brain is unable to filter all these fast paced screens, loud music, loud sounds, and also the ambient lights that we also keep in our household. Even till 10, 11, the lights are too bright and the child is not able to shut off, the brain is not able to shut off, correct? So understimulation is also one of the reason that we are seeing. There are a lot of people at home, but the child is not interacted well face to face in a direct way. And overstimulation is again with continuous noise that's happening in the house and basically fast-paced activity. So the brain requires experience, but it has to be very calibrated. It cannot take everything all at once, correct? So the sensitive period in the first 2 years that we see, it is measurable because the synapses are actually increasing in density by 2 years. And chronic adverse childhood experiences also play a role in autism, is what the newer things say, because it is again sustained cortical exposure to the child, to the immature brain. And few things about the chemicals that are happening in the brain. So the most counterintuitive fact is that up to 2 years, so everybody should know that GABA is excitatory in fetal brain. By 2 years it becomes inhibitory. This switch happens, but in autism this switch is not happening, which leads to multiple symptoms that we see. And excitation inhibition imbalance in autism. If you see this chart, there's so much of deficit, and there's excitation imbalance which we can see among the chemicals that are released. So this proposes that there is excess cortical excitation in relating to the inhibitory pathways. So the inhibitory pathways are not enough, and they're very poorly synchronized in the cortex in autism. That is what the study says. And this is also supported by 30% of the kids in autism we see epilepsy. This is again one of the reasons for that. Now coming to now how autism spectrum and with respect to brain development. So everything we have covered on development and epigenetic mechanisms, neurotransmitter systems, genetics, environmental factors, now we're all putting together on autism. Autism is not a single disorder. It's a heterogeneous spectrum, a final common pathway that multiple developmental disruptions can reach. What all we have discussed, everything has a role to play in causing autism. Despite the cause being so heterogeneous, there are consistent neurobiological signatures that we can trace back to. So little bit on the history and epidemiology. It started in 1943. There was, they told us, autistic disturbances, and then Hans Asperger showed that, it was a high functioning autistic psychopathy. So different variable terms and nomenclature was used. And then finally we are here, and the last 2023 one says the prevalence is 1 in 36 in the US. And also a little bit of what is happening with the structure of the brain in autism. So there is early brain overgrowth in autism, which you have to see, and there are other causes of genetic conditions where you can see small brain like microcephaly, but we also see normal to increased head circumference in the children with autism. And structural brain findings, what actually is happening is there is increase in volume of the frontal cortex and the temporal cortex, and the amygdala volume is also slightly larger. These are very theoretical, but it is all, there is evidence, there's a basis that is happening. It is not just a neurodevelopmental, there are actual changes that are happening in the brain. So this is what I was talking about, the connectivity. So in kids with autism brain, the local networks, if you can see, are over-connected. And normally we need to have long distance, inter-distance connection between all these regions. But in autism, this is the brain mapping that says the local over-connectivity, which is the core principle in autism. That's why we have certain persistent behaviors or issues with language and other things. And coming to another supplement related, like what we say, there is a mitochondrial dysfunction, that's why we need to give XYZ supplements. Nowadays we as doctors too are giving certain supplements which really help in the brain. This is all, again, there is an evidence. So there is basically energy failure that is happening at the molecular level, correct? And 30 to 50% of autism has mitochondrial dysfunction. The biomarkers which we do in certain cases, not everywhere. And neuroinflammation we discussed, again that is going to affect postnatally also. Postnatal exposure to any infections is going to cause inflammation in the brain. Now coming to the gut-brain axis. So this is the most important therapeutic target. So we address GI symptoms, they have a neurological benefit low. So 40 to 70% of autism kids have chronic GI symptoms. So it varies again with severity of autism. So these are the probiotics that we suggest, and we do give, and we see certain improvement. It actually behaves with the vagus nerve oxytocin pathway. So there is all evidence, and we are all going to try and use it in multiple ways, so we get benefits in all the domains. So the gut-brain axis in autism, the microbiome, the immunity, and the neurodevelopment. So GI symptoms, like I said, it's severely affected, and altered microbiome, decreased bifidobacterium, which we supplement, and propionic acid is also one of the reason, and leaky gut, which we call, so increased permeability of the gut. There is translocation and systemic inflammation which causes because of that, and there is a neuroinflammation which is triggered. So, and vagus nerve pathway also is taken care by the gut bacteria. So whenever we are feeling little jittery, our gut reacts, and then we need to use the restroom, right? So that is all vagal pathways and influence on the gut. And now coming to the autism epidemic, pandemic, whatever we are calling that, I think it is increased survival of the preterms, increased digital exposure, and increased diagnosis is very, very highest reason for the epidemic that is happening. And partly we are diagnosing more is what I can say. And sex differences in autism, the male-female ratio, if you see, males are more, but females, they say they're much more underdiagnosed is what the studies say. Meaning any female child you are having an autism, you need to evaluate even more and need to be, we need to evaluate more genetically in a female child is what the studies say, and we also see a lot of genetic related autisms in a female child. And biomarkers on early detection and of autism, the eye tracking, EEG biomarkers, MCHAT, MRI trajectories that we spoke about, the volume, plasma biomarkers for energy failure, and genetic screening. These are the things that we can do objectively. And evidence-based interventions, I think it's all talked about before. And the research that is happening here is the single cell transcriptomics. So there's so many new words that we'll be listening in the next few years, but everything is again based on what all we have spoken. So everything is hitting a different mechanism to improve or decrease the inflammation or increase the development of the brain. So clinical approach, diagnostic workup, you all know, you've been doing it every day, correct? And the comorbidities not to miss, you need to screen everything. So there is epilepsy, which is missed most commonly, and the hearing issues which are missed in autism, which are reversible and treatable. And the ASD brain across in different levels of analysis, if you can see, it is only not behavior. From behavior to the networking, to the structure of the brain, to the cell circuit, we can program, we can actually, every level of autism can be connected in this domains. It is not just a behavior problem. So this is all integrative of a single problem that we are dealing with. And hormonal influences, again, postnatally, prenatally also, thyroid, cortisol, like I discussed, testosterone, prenatally from the father, estrogen exposure, insulin, melatonin. So every hormone has effect on the brain development in different domains of development, and also with the comorbidities that we see, predominantly sleep. Preterm birth and ASD we've discussed. Extreme, the more extreme, the increased incidence of autism risk. And sensory processing in autism, either they are hypersensitive or hyposensitive. It could be auditory, visual, tactile, proprioceptive, and interoceptive. Sleep and brain development. Again, 73% of the children with autism have significant sleep disorder. 25 to 40% even neurotypical kids nowadays have sleep issues, correct? And decreased REM sleep, and also 2 to 4 more times they have greater daytime issues if the sleep is insufficient, and they have sleep disordered breathing. And precision medicine in autism for specific genes. Tuberous sclerosis, we are also giving mTOR inhibitors that targets multiple things, not just autism. And Fragile X, there is a phase 2 trial going on. And Angelman syndrome, I'll just quickly run through the slides. And epigenetic therapy, these are all advances. So take home messages is that epigenetics, role of genes and the environment, critical periods of intervention, the first 2 years, the synaptic increase and the density and networks. Screen every preterm. If you know in institution there's a neonatal ICU, screen every preterm at 18 months. You can diagnose more, you can pick up more, and you can start the intervention early. And follow it before conception. Let's work more on the prevention now. I think we are already seeing most of the cases. I think we need to start from the age the couples get married, and find masked autism spectrum in girls. They are more, and the delayed diagnosis in kids and in female kids, and also treat the comorbidities as a whole. So whenever you see a child with autism, if they don't have a medical diagnosis, if a neurologist or a neurodevelopmental pediatrician hasn't seen, please get one proper evaluation by a professional, because you'll be missing out something for the reason for autism, which may be helping with the therapy, or maybe reversible causes or genetic causes, or we will know much more, and after that the therapies can still continue. And I would like to conclude by saying that thank you all for being here, and I really appreciate the opportunity provided by Yashoda Hospital and the admin, our team, High Tech City. And it's wonderful. We've been working on pediatric subspecialty, pediatric neurology and neurodevelopmental care from the last 2.5 years. And I think this is the need of the hour. We all talk about it and we make it more inclusive. And I've seen multiple of you are already much more senior to us and who've been in this field. And I think now there are more platforms to give our voice and reach more people. So thank you all for this opportunity. Thank you.
Thank you so much, Dr. Varsha Monica Reddy. So she sort of simplified the complex brain networks into actionable things. We can do it at home or therapy centers. So she sensitized everybody regarding preventable aspects, right? Even before planning delivery, and how to like see it as a multifactorial disease, not disease, like a thing. Okay. So thank you so much. If anyone has any questions,
Yeah, we can take
one
up
or two
one
questions.
question quick.
Hi ma'am, lovely presentation. I just wanted to share a thought wherein if, as you rightly put it across, that women's mental health has got a lot of say in the childbirth, like rather than the physical factors, why is it still mandatory, not mandatory in the hospitals to run a mental health checkup? As in like, you can run tests or you can probably make it mandatory to run through different scales and stuff, which is still not mandatory. Like there can be an anxiety check, there can be a depression check and stuff like that, you know, for schizophrenia and stuff. That's one thing. And the second thing I want to ask is, as you said, epigenetics has got the capacity to prune away the older connections and like sprout the newer connections. Is it possible to apply it on the kids who have got autism spectrum disorder, and is it possible to completely reverse the disease?
Yeah, so the reason, okay, answer to the first question, actually, see, mental health in maternal is one of the isolated domain. What about mental health in India as a large? How much of us are talking about mental health in adults? So it starts from, you know, it's a cycle, I think. In childhood, we deal with neurodevelopmental issues. In older kids, we deal with anxiety. You know, we deal with very bad environments at home, a lot of stresses which are not addressed. They go into, you know, personalities when they are adolescents, that is not picked up. And then they going to become, you know, those people get married and they have their own subclinical undiagnosed issues. But in a mother, when there's so much of hormonal influence, there's so much of environmental influence about the support, over support, lack of support, baby, so many things, that becomes a very critical period, and it is extremely vulnerable period for females. So it is not just mental health in mothers that we need to reach out to, it is mental health as a whole. Only then, if a family is dealing with 4 or 5 people, everybody's mental health needs to be at check when we are dealing with so much of epigenetic influence that is happening on the future generations, correct? And we in our hospital, we get our psychologists, we get our counselors, lactation specialists, everybody to have a talk with the mother post the delivery until discharge. We talk to them in person. So we are actually started doing that. And I think the mother also feels that there's somebody who's asking about the mother. Because after the birth, the mother is the last one to be asked about. Everybody's asking what is the gender, what is the color, what is the hair of the new baby that is born. All the interest shifts to the baby. I think we as a society, we also need to redirect that and concentrate more on the mother. And in general, all adults. I think we also, if we screen for mental health, we may also be suffering for a few things which are subclinical. And the second part is epigenetics. That is why the role of epigenetics is getting more, because these pathways can be reversed. That is why the first 2 to 3 years of the influence that can be changed, the digital exposure, the toxins, the environment, you know, the infections, the inflammation, everything can be reversed. That is why if you think of the concept of epigenetics, we are able to prevent the further damage happening, and basically it is the pruning or synapses that are happening, so we can change it.
Well, that was a very informative and a very elaborate presentation, Dr. Varsha. The neurons in our brains are literally firing. Well, thank you for that. And yeah, to summarize, yeah, that was a nice question as well. Make sure you, I didn't know that you could trace back autism all the way up to your grandparents. That was a new thing for me. And maternal health, let it be mental health or the physical well-being of the mother, the most important thing, and torch infections, most importantly, and for the kids, over and under stimulation. Beautiful points put up, very informative. Thank you so much for it. Any more questions, audience?
Yeah. Thank you.
Thank you so much.
Thank you.
So you all can please stay there to chair the next session. We have we have Mr. Milind Sonavne, audiologist and speech language therapist, Children Disability Network Manager, Ireland.
So we are honored to have with us Mr. Milind Sonavane Garu. So he is a audiologist and speech language therapist, and he's running a good network called the Children Disability Network in Ireland. So he's going to add upon his unique global perspective to our Indian scenarios. Thank you.
Good afternoon, everyone. As usual, technology problems. This is a time of the day when we have had a nice lunch, nearly waiting to go home, tired from 2 days. Yeah. So I'll try and be more practical and not just keep looking at the slides. We'll try to do it more engaging way. The topic that I am going to talk about is social skills in autism spectrum disorders, and what I want to talk about is how do you assess and how do you provide the interventions which would be needed if you figure out somebody has a social skill difficulty. Do we all have social skills? Yes? How did we learn? Did somebody teach us? By observing, looking at other people, going to school, learning from our peers, looking at information on the TV, reading a book. This is how we learned our social skills. What happens for children who are on the autism spectrum? They have less opportunities, or they do it in a different way, right? Yeah, yeah. So their social interactions, what we call is not appropriate. That's their way of social interaction. And there's a lot of debate about neurodiversity and why should we provide interventions, and you know, whether it's appropriate. Social skills is one of the most debated aspect in autism spectrum disorder, where they're saying nothing is wrong with us. It's wrong, it's what's wrong is you people. You people don't understand us. You don't have the right skills to interact with us, so don't call it as a problem for us. It's you who have a problem, that you haven't made the systems suitable for us to communicate and understand the social skills. Okay? So, why are social skills important? To interact with each other. We are humans. What's the most important thing we do? We interact with each other. We make relationships. We have friends. If we had poor social skills, or if our social skills were of any problem, would we have difficulties making friends, relationships? Whether they are intimate relationships or friendships or any of those relationships which are very complicated to understand, they all develop because we have those social skills. We know the social boundaries. We know what is acceptable in a society and what's not accepted. And if we don't know, somebody tells us and we learn it and we remember it. Are they important for academic skills? Yeah. Going to school, big part of our life. Learning academic skills, learning the subjects, the topics that we are taught, going to school, higher school, education to a college, all of those depend on how good your social skills are. I can bet you if you go back to your days in school, you would often remember one or two people in your class who would have stood different than the rest of them, and we probably didn't realize, or we didn't make, or maybe we didn't talk to them because they didn't talk to us. But some people are just like that. Doesn't mean that everybody who has poor social skills has got autism spectrum as well. So for some people, it's seen as disability if they lack social skills. What happens when you meet somebody who is older to you? Or just now, Sir said Garu to me, which is with respect, right? When I meet somebody, when I talk to someone, what are the factors? What am I thinking about? What am I looking at? What's my age? What is the person's age? What is my relationship with that person? How can I say something that does not look negative, or how do I come across to the other person as respectable and give the same respect back? Would I do that with my own son, daughter, or my own very close friend? I have a different way of behaving. I can put my hand on my friend's shoulder. I can't do that with someone that I don't really know very well. All of these things are very subtle. They happen just like that. We may remember them, and we know how to behave in a situation like that when it happens again. So you need a lot of information to do this. You need background knowledge, you need exposure, you need practice, and you need step-by-step instructions on how to do it. And with children on the autism spectrum, some of these are difficult to learn because of their poor joint attention and other skills and sensory reasons that they present with. Nonverbal cues. In the morning, I was just saying it to somebody, the 70% of our conversation or communication is nonverbal. If I look at your face and I see you looking here and there, I know that you're not interested in what I'm saying. If your shoulders are down, I know you're tired for the day. How good are people on the autism spectrum to pick up nonverbal cues? They struggle. They have difficulty because they don't really look at your face. They are not tuning into your body language as much as they should be. So in our interventions, we work a lot on nonverbal communication and how to pick up somebody's body language. That needs to be taught to them, because without teaching, they'll not understand those subtle things. So using language for a social interaction or in a social environment is a significant challenge for children on the autism spectrum. It is one of the main criteria for autism diagnosis is social interaction and social communication difficulties. Social interaction is when you interact with somebody, and social communication is when you need to speak to someone else. It's also called social communication disorder, SCD, and various components of it. Social interaction is when two people are having a conversation. Social understanding is when you need to understand the dynamics between the two people. Pragmatics is what kind of language to use, what rules to follow, and what to say. All of these fall under social communication disorder. It can also be seen as a difference, as I said earlier, that it doesn't have to be a disorder. Some of the people describe it as a difference, and I just explained the reason for it to be different. So what happens when you have a social communication difficulty or challenges in social communication? You have a difficulty in social setting, so participating in social settings is going to be a problem. If you ask history to your parents, what do they tell you? What kind of sports do children with autism play? Do they play group sports? Or do they play individual sports? Why? Because it's difficult to read somebody else's body language when you're in a group play. I could be playing football and I say, so I know that ball has to be passed to the other person in the corner. But if you are not working on that, if you're not tuned to that, they'll rather choose play activities which are isolated, like they'll be very good at swimming, or they'll take a bicycle and go for a bicycle ride, or they might just walk around because there's no demands from social aspect while doing those sports and activities. So if you are working on social skills, they need to be working in groups and working with other children to learn these skills naturally. I already talked about relationship challenges, academic struggles, and occupational hurdles. Do you know what people choose their professions as? It's based on a lot of people, I'm not going to stereotype, but they say people with autism spectrum choose professions where they don't need to interact with someone else. They'll never choose a profession where they'll be teachers. They'll not choose a profession where they have to interact a lot with people. They'll always choose like an IT profession or something else where they can do their work uninterruptedly. Nobody's going to bother them. They come, they do their job, what they're told to do, and they leave. As I said, what are some of the causes for social communication difficulties or disorders, you think? Pragmatic social language. What causes it? Yeah, there's less reciprocal interaction. Is it lack of interest? Okay. What is autism described as? Lack of social interaction or interest when you are working with someone. So desire of social contact. There is an internal struggle. They want to make contact, but they just don't know how to do it, or they do it inappropriately. There's a lot of anxiety. The social anxiety is very high when you're interacting with somebody. Why is the social anxiety high? I don't know what the other person is going to think about me. I don't know what the other person is telling me. I might misinterpret that person. I'd rather not look at him, or I'd rather not engage with him. Social situations are always stressful. If you take the history, what do the parents tell us? Doesn't want to go shopping, doesn't want to go for cinema, doesn't want to go to a public place, because all of these requires them to interact with another human being or different human beings, which puts a lot of pressure on them to understand and learn body language from those people. Rejection and isolation is very common. Bullying is quite common in children who are on the autism spectrum because they are different, they don't make friends, they don't have the support system of your peer group. When you are in a peer group, if something happens to you, your friends will stand for you. When you don't have that support, you're very isolated. And as I said, they always choose solitary activities. Before me, a lot of people have spoken about theory of mind. What is theory of mind? It's a theory, that's why it's called a theory, because it cannot be proved. So what is theory of mind? What's it? So I'll put it very simply, seeing the world from someone else's eyes, okay? So what I see, it may not be what you see or what you feel. So trying to, an example I'll give you, when our friend gets injured and he has a plaster on the hand, what do? We go and talk to him and we say, how are you? Are you feeling better? Does he really feel better when you say those words? It is right thing to do, that's why we are doing it. It doesn't make his pain go away. But we are learned socially, that's what I need to say. And I can also imagine myself to be in his position and think if I had broken my arm, how would I feel and how would I be reacting to? And that's what I'm putting in my head and thinking from another person's perspective. I don't know here, anybody seen asking ice cream at 12 o'clock at night? Have to go and get it, no matter whether it's raining or your car is not working. Why? Because they're not thinking from your perspective that you're tired, shops might be closed, dad doesn't want to go out now. They want it, they don't care whether what you think about it. So theory of mind is considered to be one of the core deficits, and again, debated, as I said earlier. They think from their perspective and they think that's right. Executive functioning, in the morning as well, we heard about the deficit in executive functioning, which is the higher level control of things and how you plan, manage, organize, how you react to things that happen around you. And there seems to be a lot of theories suggesting there is some deficit in people on the autism spectrum with their executive functioning. There is also a theory called weak central coherence. What it means is that tendency to focus on fine details. So if you're talking to them, I don't know if you've seen, I had a student who had 140 logos of cars collected and knew every brand of the car and every make of the car, but then he didn't know in general about his friends or what his father did. So they focus and they zone on one particular small thing, and they forget to take the bigger picture into perspective. When you and I are doing something, whether we say something, whether we interact with something, whether we do something, we always look at the bigger picture, and that's how we make our decisions, and that's how we communicate. How do you assess pragmatic skills? Speech and language therapist, I'm going to ask you, what do you do? Or anybody else who has been assessing social communication, how do you assess? Social savvy? I can't see who's speaking. Oh, there, okay. So what does it do? Okay. 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 Have you heard about SELF, Clinical Evaluation of Language Fundamentals? It has a checklist at the back, which is scored and can be very helpful. Although it's a tick checklist, you can get a lot of objective and subjective data from that when you do that with the parents and when you go to school and observe the child. Some of the assessments that I would be doing is the Children's Communication Checklist, CCC2. We also have something called a test of pragmatic language. This is a standardized test. It's called TOPL. And then we have targeted observation of pragmatics in children's conversations. I haven't used the topic, but I've used the first two ones. This is just a modified assessment that we use in our clinic. We are looking at different aspects of social communication, because this is all what is made up of when you're looking at social communication. You want to know if the person is tuned into what you are doing. I might be playing with a toy, but that person might be looking out of the window. So how tuned in is that child with me in what I do? Auditory processing, it's really important that what you're speaking to the child, what he's processing, what is he understanding, how much is his capacity to understand. It determines whether he's going to respond back to you or understand what you're saying to him. Reasoning, how do you learn to reason? If I asked you, if it is going to rain outside, what will you do? What will you say? What will you do if it's going to rain when you walk out of this building? You'll just get wet. You'll open your umbrella. So you have to reason. And how do you work on reasoning? Using language. If you don't have the ability to reason, if you don't have the ability to verbalize and understand the reasoning using language, social skills are going to be very difficult to come, and that's why reasoning has to be worked upon from very early in life, and there's a lot of ways to work on it. Non-literal language comprehension, what does it mean? Using jokes, sarcasm. Do we use a lot of jokes in our daily life? Are we sarcastic? We are. You look good today. That's my sarcasm. I could be saying you're not looking good today, right? There's so much real language that happens, and we don't teach those nuances to our children because we think it's too difficult, or their interpretation of it is very black and white. Comic strip. Do you read comics? Anybody remembers Chacha Chaudhary? Tom and Jerry? All is gone out now. But that was an excellent way to teach theory of mind and teach perspective taking and other things that are really important for social communication. Social stories, you have heard about it? Anybody writes social stories? You know the formula to write it? I'm not going to go into the details of it, but social stories are written from a social perspective. When you look at a problem that is social in nature, you need to provide an explanation as to why, how, and what can you do if you are in a situation. And I'll give you an example. In the morning, we looked at, Smita ma'am was talking about emotional understanding, right? On one hand, you see emotions, which are individual emotions. Do emotions ever just arise from this part of the body? What's emotion in context? What do you think about this child? What do you think about him? What do you think this boy is doing? Why? When I ask the same question to somebody, they just say, oh, the boy's eyes are closed. Because they can't interpret, they cannot put the whole thing into perspective that I need to look at the rest of the environment, I need to think about why is the child doing what he's doing. So teaching emotions using single flashcards of face is never going to teach them the emotions. It has to be done in a video modeling way, or it has to be done in more contextual way. Reading books, reading your newspapers is the best way to teach understanding of emotion, which is an important part of your everyday life. These are some of the examples I used when I'm assessing their idioms, or double meaning as we say. I'll just ask you one thing. When I say it's raining cats and dogs, what do you think it means? What would a child on the autism spectrum say? He'll say cats and dogs are falling from the sky. This is 90% of the time, this is what they have told me or told us. So you can see they are very literal in what they see. You really need to teach them this is an idiom, what it looks is not what it means. And that's when they're going to understand when it is being used in your everyday language, and I'm running short of time. Multiple meaning and sarcasm. When I say mouse, it could mean two things. When I say bank, it could mean 2 or 3 different things. How do I know which one am I saying? If you don't train them to understand multiple meaning words, they're not going to understand what you're saying. Sarcasm, we really need to test them. This is an assessment for theory of mind. I'll just briefly tell you, the boy and the girl, their parents there brought a t-shirt for the girl. And the brother knows that she wanted a bike, but when the dad asked her, do you like what I got for you? She says, yes, I like it. Why is she saying that? Why is she saying that? That's the theory of mind. She understands that my father has bought something for me, even though I did not want the t-shirt, I wanted a bike. Now that he's got me a t-shirt, I must better say that I like it. What do children with autism do? Oh, she likes t-shirt, she doesn't like bike. Because they cannot understand that theory of mind. How do we do intervention? Peers, you're the best way to train social skills. The children that work with you, the children who are around our children, they are the best people to teach any sort of interventions, peer-mediated interventions they are called. Play. How many of you play with your children? Do you get down on the floor and play with them? Very difficult for us as a parent, as an adult, to play like a child. When the child is putting the toy on your head, what do? No, you can't put the toy on your head. You have to put it on the floor. No, because we can never be children unless you start playing like what they are doing. They're not going to engage with you. A lot of social skills can be taught through play, group interventions, group play activities. Visuals. How many of you use visuals in your daily practice? Yeah? Do you print out? Do you take photographs? Do you use board maker? I don't know, but without visuals, I cannot work as a speech and language therapist, because visuals make it concrete. These are some of the examples of visuals that I will use with children who have social communication difficulties based on their need. Social stories, I'm not going to go into the detail, but this is how I would write a social story when mommy's going on holidays. What does it look like? What am I supposed to do? What will happen? And what would be my response? And how do I behave during while she's gone? Video modeling, I don't know if you use, but it's been very effective with a lot of my clinical practice. We have a lot of videos, we have a lot of apps that generate videos and video clips which can be used to teach a lot of social skills. And that's really a very good tool to use when you don't have to make things. A lot of computer-based instructions. There are a lot of softwares which work on social skills and social understanding, problem solving, and you can use those to supplement your social communication work. Behavior interventions, I'm not going to talk about it, but positive behavior supports and some behavior approaches have shown to be really helpful. Peer-mediated, I've spoken about that. Comic strips. I would still write comics if I was teaching a social skill, because that is still easy to teach them what was the person thinking, what he might be having in his head, what can you do, what can you not do. All of these can be put in the thought bubble, and you can talk and describe it, and there's a particular way to do the comic strip. Social scripts. A lot of our children, when I ask them to pick up a phone and make a call to buy pizza, they cannot do it. But you give them a script and say, this is what you need to do, they can do it, because they need that support, visual support again. A lot of group work we do. Working on theory of mind. How do you really work on theory of mind? In the morning as well, ma'am was talking about it. You have to work on theory of mind. You have to use the right vocabulary, which is called the tuning in vocabulary. This is how I feel. How do you feel? This is what I want. What do you want? This is what I think. What do you think about this? This is where, if you don't use that language, they are never going to be tuned into what others are thinking, doing, and feeling. And there's a whole list of vocabulary words that you can train the parents, and the parents should be using this every time they work on the theory of mind to tune in, and that's what called is tuning in language. Working on auditory processing, as I said, there's a lot of ways to do it. There are a lot of activities. There's a program called HELP, H-E-L-P, and it works on auditory processing in children when you're working on their social skills. Verbal reasoning, we have a lot of worksheets like these that we use to work on the verbal reasoning, but you can draw and you can make your own worksheets, and it is more easy to work on those verbal reasoning skills. Anybody works on sequencing, narrating, and storytelling, which is a big part of their difficulty in terms of their ability to communicate with somebody. If you want to speak with someone, you need to be able to tell a story. You need to be able to narrate something. What do you find in children on the autism spectrum with their social, with their narrative skills? Are they good? What do? They don't have a proper sequence. They might tell you the end of the story in the beginning of the story. They might miss the middle part, and then they assume you should understand what they're telling. I went there, and he was pushing me, and then he asked me for this. Who are you talking about? They forget that there has to be a sequence to things. So working on storytelling, there is a test called Renfrew Action Bus Picture Test, and it is a test that works on narrative skills, and that's where you get a lot of information. I talked about it working on non-literal language comprehension. You really need to work and focus on that if you want them to learn non-literal language. Work on story sequencing. Books, how many of you read books and use books in your therapy as tools? Wonderful way to teach any of the things that I was talking about. The person has his hands on the hips. What do you think the person is thinking? Or what do you think, what is his emotion? There's a lot of ways to use books, and teaching social skills through books is really one of the best way to do it. So I went a little bit faster, but I hope you got the gist of what I wanted to say, and I'm more than happy to answer a question that you might have if we have time.
A big round of applause for sir. Okay, it's a masterpiece, I can say. So he has unfolded the hidden layers of social communication. Okay, he sort of simplified all the practical points. He's being practical from the beginning of his lecture to the end. Thank you so much. Any questions?
Any questions from the audience? Right. Milan sir, that was a great presentation.
Thank you.
You've projected all your experience in your slides, which we can clearly make out a lot of pictorial representation, which is much easier to understand rather than the lines, reading the lines. And me coming from a pediatric orthopedic background, we have dealt with a lot of autistic kids. We've seen so many people. Most importantly, the parents struggle a lot. So as you said, communication, most important medium. So we also teach the parents to treat the child with a lot of patience, empathy. So I mean, great presentation, sir. Thank you.
Thank you. Thank you, everybody.
Thank you so much. So we would have the paper presentation over here. Post that, we'll break for tea.
The oral paper should be here. The poster, the pending poster, 3-4 people are pending, I think. They should go for hall B. Only the presenters. The rest people will be here only. So first paper.
Confirm me with this. I'll call him, sir. I'll
Judges, sir.
Next.
Sir.
Purva.
Ma'am, ready, ma'am?
Yeah,
Yeah. The presentation should be 6 minutes.
Right.
Maybe the judges will discuss, ask questions for 2 minutes, ma'am. Thank you.
Should I start?
Who is checking the timer? Somebody is checking the timer? Okay, timer is displayed. You can start.
Yeah, so this is a study where the most important question today is, do children outgrow autism? It is a long-term outcome of children who are diagnosed with autism between 2 to 4 years of age. So this we conducted at Rainbow Children's Hospital. So we know that the incidence of autism is increasing, almost 300% increase from the year 2000. 1 in 31 children, by CDC US data, they have told that 1 out of 31 have autism. And in the INCLIN diagnostics that they had done for autism, 0.26% was found to be the prevalence in India. There is very limited understanding of autism trajectory in Indian population. There is no sizable Indian cohort assessing the diagnostic stability after 6 years of age. So because of this lack of data, whether children will outgrow autism, whether there are going to be residual impairments, and what is the burden of service dependency is what we wanted to find out. So the aim of the study was to find the proportion of children with autism who would outgrow autism. So the new terminology which is being used is the optimal outcome. That was followed up at 6 years, after 6 years of age, and then we wanted to see the developmental outcome, service dependency, level of independence, and residual deficits in children who were diagnosed with autism. So this was a 2-year study from 2023 to 2025 at Rainbow Children's Hospital. We included children who were diagnosed with autism between 2 to 4 years of age, and either by CARS-2, ESA, or any of the standard autism diagnostic tools, and they were followed up by more than 6 years of age. They were called back, and we followed up with a minimum of 2 years of gap from the diagnosis to the final assessment. And genetic disorders of autism were not included in this study. So the assessments were CARS, VABS, BKT-MISIC for IQ, DSM-5, ESA, and VSM scale. So our screening population was around 500, out of which we enrolled 107 and 92 had completed the assessment. The mean age at follow-up of these kids was 7 years. It was male predominant with 76% boys. The mean age of symptom onset was 2 years, and the mean age of diagnosis was 3 years. The most common complaint was speech delay, and they were first by birth order in 70% of the kids. So this is the most important part of the slide, where we found that 81% of the children who were diagnosed with autism at 2 to 4 years of age, when they were reassessed at 6 years, 80% of them retained the diagnosis. That means only 15% were the ones who, by CARS 2 criteria, they did not have autism at the follow-up visit. And out of these 81%, 3.3% were severe autism. So the terminology loss of autism diagnosis is those who have outgrown autism by the standard tools, that is the CARS criteria. But only 4 out of 14, so 14 had outgrown autism, but only 4 could achieve optimal outcome. That means there was no service dependency, they were going to regular school, and there was a complete independence for daily activities. Whereas 10 children, despite outgrowing autism, they still required services, which is a huge number for us to know from the Indian population. So as you can see, 94% of the children were diagnosed baseline with mild to moderate severity, but 82% later had mild to moderate severity. So the good part, at least for us to know, is that 50% of the children from severe category came to mild to moderate category, and almost 15% lost the diagnosis, but the major chunk of mild to moderate autism, they stayed in the same category. If we see the domain-wise outcome in terms of the VABS score that we had done, so daily living, communication, socialization, maladaptive, internalizing and externalizing behaviors, there were varying deficits. There were deficits in peer interaction, there were deficits in expressive speech delay, ADHD, comorbidities were there. The other important thing is this slide where the service dependency burden was very high. So out of the 101 children that we had, 94% of children required to continue to require some kind of either therapeutic, educational or behavioral support. Only 29% were fully ADL independent, 55% were completely toilet trained, and 71% of children of the loss of autism diagnosis, that is those 14 kids that we had seen who outgrew standardized tool of autism by CARS, they still required one service, either speech therapy, OT, BT or special education. We tried to look at the predictors of outcome, where we found that except the DQ, there was no other outcome, gender, age of diagnosis, age of therapy, that we were able to find the predictor having any significant finding. This is another important thing that we found. So amongst the autistic and the non-autistic group, most kids did better in daily living scale, communication scale, socialization scale, and the overall ABC score. But the maladaptive internalizing and externalizing behaviors, both autistic and non-autistic groups, they did not perform well. So behavior probably may be from another trajectory or some another connectome in the brain that could have caused the behavioral disturbance. So important to know is this is the largest Indian cohort study where we have looked at the long-term follow-up, where we have used validated tools, VABS, CARS, IQ scoring by MISIC or BKT. And this is the first study to also tell the burden of the residue in cases of children who have outgrown autism. Though this is a smaller study for loss of autism diagnosis, it is a tertiary care center, so there will be a lot of referral bias. We didn't have DQ for all kids, so these are the limitations of this study. So the conclusion is the service dependency is very high even in children who have outgrown autism, and this is the India's large study. We need more studies because this is just a drop in the entire ocean of autism where we need to look at the service dependency. Thank you.
Have you used the recently developed tool for this study?
No, so this was from 2023 to 2025, so we have already finished. We are still enrolling now because the study design is fixed, we can't change the study design. So we used CARS 2 and ESA at the time of baseline, and follow CARS 2 and IQ by MISIC or BKT, and VABS scoring.
So it's a prospective study still going on.
Correct, we are still enrolling.
So you did CARS score, you take the cutoff score of what CARS score is not autistic.
Which score you took as cutoff?
So 29, anything which is less than 30, we took it as non-autism.
Less than 30. What does exactly CARS 2 say?
So 29 is there, but
It
less
is
than
normalcy. Is non-autistic is different from normalcy.
Okay.
Normalcy is 15. Below 15 is normalcy. 15 to 20 is non-autistic, will still autistic features are present.
Okay.
So you said you did CARS to some and some to ISA. The next follow-up, you did not use ISA again.
No, so baseline we enrolled even those who had come to us at 2 to 4. So we just did the severity grading. So for us, we didn't label the numerical number. We just did either it is mild, moderate or severe, because we just compared ISA also we can categorize as mild, moderate as one category and severity as one category, and then we compared the two.
So follow-up tools are not ISA again.
No, it is CARS only, but we were looking only at mild to moderate category rather than the scoring.
Scoring itself. So once you did a follow-up, you said you did ISA also. So from what age you have done ISA for the baseline?
Correct, that is baseline. So only those who had already done ISA, we just confirmed it by DSM-5 criteria.
So you did not do any particular scale. Already diagnosed case of autism you have taken.
Correct.
You did not do any personal basic, already diagnosed cases.
So either they were diagnosed outside and they came to us for a assessment, or when they came to us, we do CARS for everyone. We don't do.
Is it blinded?
Sorry?
Is it blinded, double-blinded or blinded, single-blinded?
This is not a RCT, so this is.
You're doing a follow-up study, right? Still, there should be bias. Some amount of bias can be there.
Because we already know who is autism. Unless we don't know who is not autism, we'll not be able to do the.
Okay, thank you.
Okay. Who is the next presenter? We already announced, right? Yeah, next, sir. Sir.
Name. Next to it. Name.
Name. Archika. Archita.
Sir, I'm here.
Yeah, right. Yeah.
Can I start? So good afternoon, everyone. Because it's a very limited period that I cannot introduce myself. So the topic of my study is mapping the intellectual structure of autism research. It's a bibliometric study of global inequalities and knowledge gaps. So as we all know, ASD has been emerged as a significant global neurodevelopmental condition with increasing research across clinical, neurodevelopmental, and developmental and social domains. Over time, autism research has shifted from a very purely, it has evolved from a purely medical model to include psychosocial, educational, and policy perspectives. Despite this growth, the field still remains fragmented across domains. Autism research is unevenly distributed with dominance in the global northern regions like Europe, North America, and Australia. So there's also a growing shift towards the neurodiversity framework, which emphasizes on inclusion, accessibility, and rights-based approach. Given this evolving landscape, it becomes very important to examine how autism research is structured globally and what themes dominate, and also whether it aligns with the study, with the equity, with the neurodiversity principles. So review of literature, historically autism research has been dominated by biomedical and diagnostic paradigms, and it has also expanded to developmental and cognitive research, including social interaction, communication, and even executive functioning. And recently there's a shift towards psychosocial and public health perspectives. These studies highlight autism as not only a clinical condition but also a social and public health concern. And moreover, it has the increased attention to psychiatric comorbidities, as mentioned yesterday by Dr. Isha Sharma, emphasizes the overlap between autism and other mental health conditions. And from the structural perspective, autism research has shown a lot of strong collaborations in the global north regions and recent shift towards the neurodiversity and inclusion. So despite extensive research in this area, several critical gaps still remain. there's a lack of integrated understanding of the global intellectual structure. So here, while individual studies focus on specific domains, there's a very limited work of study which has focused on, has simultaneously examined the themes, collaboration, citation patterns, everything in a unified manner. There's also a limited focus on geographic inequalities in research. And there's a clear knowledge bias towards, using biomedical models more, and there's a less focus on social and lived experiences. So, and although neurodiversity is gaining attention, but it is not fully reflected in the research landscape. So research questions I'll be discussing along with the results. So the aim of the study is to analyze the intellectual structure, thematic trends, collaboration patterns, and knowledge biases in global autism research using bibliometric methods with a focus on inequalities and WHO-aligned neurodiversity perspectives. So the methods used here were, the research design was a bibliometric research design, database was totally from the Scopus, and the search strategy that was used to search the literature was a structured Boolean strategy, and inclusion and exclusion criteria did apply. And all of these search happened through a screening process which involved 4 steps, which is identification, screening, eligibility, and inclusion, which was based on PRISMA 2020 guidelines. And the type of data that was extracted for the study was authors, keywords, citations, affiliations, and country. The 4 data analysis techniques were used. One is keyword co-occurrence analysis, co-authorship analysis, bibliographic coupling analysis, and co-citation analysis. The tools and software that were used here were, for the database, it was Scopus, and VO's Viewer was used for bibliometric mapping, and Microsoft Excel was used for data cleaning. As it utilized the secondary bibliographic data from publicly accessible database, no ethical clearance was required for the study. So moving on to the results, my objective 1 was to determine the prevailing research themes, conceptual clusters, and new trends in the literature on autism using the keyword co-occurrence analysis. So here, according to the results reveal that the global autism has a highly interconnected and multidimensional thematic structure. And moreover, 4 major domains emerged, which is a psychosocial and public health domain, developmental and diagnostic domain, and neurobiological domain, and psychiatric comorbidities domains. A smaller cluster also reflected epidemiological and population level studies, and moreover, the biomedical and diagnostic paradigms were more dominating in the field. However, there's a gradual shift towards the neurodiversity perspectives, which includes inclusion and accessibility and equity. Moving on to the, this is the visualization using bibliometric analysis, which popped up. And this is the objective 2, which was to again map the collaborative structure of autism research and pinpoint key writers and research groups using co-author analysis. So here, the results revealed the highly influential authors who come together, who collaborate, and here the dominance, as mentioned earlier, was more in the global northern global regions. And the key feature here was the presence of bridge authors, and the research was also limited to the LMIC representation, which means the low and middle income countries. Moving to the objective 3, it is to determine, to investigate the foundational knowledge base, citation communities, and intellectual structure of autism research using bibliometric coupling and co-citation analysis. So the results showed that autism research is organized into densely connected citation clusters, reflecting shared conceptual foundations. So 4 core domains emerged as shown here. And this indicates that together, 2 analyses were used for this objective, which is bibliographic coupling and global, and also the co-citation analysis, as you see here. So one thing from the co-citation analysis was that it reveals that the intellectual foundation of autism research is highly centralized with diagnostic frameworks like DSM, the Diagnostic and Statistical Manual of Mental Disorders, was the key point using which all the researches are being done. So that is the standard diagnostic framework that is being used globally. And however, this also indicates a persistent epistemological bias toward medicalized models with limited integration of alternative frameworks such as lived experiences, cultural differences, and neurodiversity perspectives. All of that has been limited, and they do not emphasize that. And then together, bibliographic coupling and co-citation analysis suggests that while the intellectual base of autism research continues to be anchored in the biomedical prevalence, emerging citation clusters indicate a gradual transition towards more inclusive and WHO-aligned neurodiversity framework. And finally, the last objective was to evaluate critically how geographical disparities, knowledge biases, and the shift towards a neurodiversity-informed and WHO-aligned framework are reflected in the bibliographic landscape of autism research. So here, the analysis highlights three major concerns. One is the geographic inequality, as I showed, the dominance in the global northern regions, and then the knowledge bias, which is more towards the traditional biomedical models, and the third one is the partial shift towards neurodiversity. So here, the findings suggest that autism research is currently in a transitional phase, gradually moving towards frameworks aligned with the World Health Organization's emphasis on sustainability, equity, and inclusion. So concluding, overall, the study highlights the need for greater integration of culturally responsive, participatory, and neurodiversity-aligned approaches to ensure that future autism research supports sustainable, equitable, and inclusive policies and practices. So with this, I'm ending my presentation. These are the references. Thank you.
Of the early all except autism, other than autism, most of the researchers what have done for early integration and illness will be like that.
Sorry, sir, I didn't get you.
Remove autism. Other research, whenever any disease or illness is evaluating or under evaluation, whole the research will be like that. It will be mostly towards the northern side, funded side.
No, sir. So this analysis, the bibliometric analysis says that these are the co-authors who have been done, or the autism research is actually more happening in these global northern regions. Everywhere else it's happening, but the size, the picture that I showed you, the size of the nodes also reflects how frequently the themes have emerged, which themes have people focused more on. So earlier it was more of epidemiological base or biomedical models that was focused, but neurodiversity framework has been recently, and there's a gradual shift towards this neurodiversity framework is what this bibliometric analysis brings forward.
So it's based on the studies where it happened largely.
Yes, sir.
So it doesn't define everything. That's what I'm trying to say.
This is telling us the gaps which future researchers should be focusing on.
Good, thank you.
Yes, sir.
Have you studied the Indian context of ROLs with regard to your topic?
Yes, sir. Yes, sir. So when we were doing this bibliometric analysis, all of these were the inclusion and exclusion criteria, where Indian studies and the foreign studies were all included.
Yeah, I have one question.
Yes,
you
sir.
said you followed Prisma.
Yes, sir. Yes,
Can you help me to understand what variables you identified from your entire set string, and what is the parameters, how many records you identified? Because you referred to Western. So how many records you got it? How many you filtered?
Yes,
What
sir.
is the
So
mechanism?
there's a lot of quantitative terms here, numbers, which journals were taken. So inclusion, exclusion criteria, the journals, peer-reviewed journals were taken, and those which were in Scopus, because Scopus has a large reach, and a lot of quality journals, quality articles actually get published there, and open access is also over there. So that was taken, and also language-based, English language journals only were taken. Whereas when we look at the other part which were excluded, those were about the non-English or the letters to the editor or the editorial journals, those were excluded. So there are each and every inclusion exclusion criteria that I'm talking about has its number, because we were given these guidelines that we have to restrict our number of slides also. I could not include that, but the visualization was shown, however.
Okay, thank you.
Thank you, sir.
Nishi. next presenter, please. After this, please sit there on the front side. What is the name? Next presentation.
Shall I start? I'll start, sir.
Pratiksha. Okay.
Timer.
Okay, the topic of my research is pragmatic speech profile of minimally verbal and verbally fluent children with autism spectrum disorders. And myself, speaker Nishi Rai. These are my co-authors. So half of the topic has been covered by, I guess, Milind sir in his presentation. Pragmatics is the study of how context contributes to the meaning, which includes the conversational situations, making inferences. And obviously we know that these particular skills are deficits in case of autism spectrum disorders. Children. So these are my review of literatures. The need of the study is by using the natural sampling method, we will see how are the pragmatic skills of minimally verbal and the verbally fluent children in autism spectrum disorders. And these study also provides insights on pragmatic profiles among minimally verbal and verbal fluent children. The aim lies in exploring and investigating the pragmatic skills in minimally verbal and the verbally fluent autism spectrum disordered children. Now there are two objectives. First is exploring and comparing the pragmatic profiles of these two groups and examining the correlation between the pragmatic skills and its severity. Moving to the methods, we took 30 participants where 10 was typically developing, 10 was minimally verbal and 10 was verbally fluent. So in case of minimally verbal, the child should be ranging, means they should be having few words to simple phrases. And in case of verbally fluent, they should use varied sentence structures and grammatical and grammar, which should have a logical connections between the sentences. Moving to their criteria, in case of ASD and both the groups, they should have 5 to 8 years of children in them. ASD should have a range of mild to moderate severity in, as per score by Isha. They should have borderline IQ and they should be attending speech therapy for a minimum of 6 months. And in case of typically developing, they should attend normal schools and they should have no history and no comorbidities with them. So the materials used were data sheet, reels, socio-economic status, and self, as been told by sir. Self is clinical evaluation of language fundamentals. It is used for the children in 5 to 21 years of age, and they have various pragmatic profiles in them. For example, rituals, understanding humors, they have following complex intentions, turn-taking, and the scoring ranges from 1 to 4, in which 1 is almost never, 2 is sometimes, 3 is often, and 4 is always or almost always. So there were 3 phases of study. First was stimulus preparation, in which we took natural sampling tasks like coloring, building blocks, and various other play activities, which were being made on the basis of the question given in Self 5. Script was also being prepared by, for the children based on each task. And the task was validated by senior SLP. We took 15 minutes for each task and 3 to 4 sittings were being taken. The second was data collection, where all the permissions was being taken from the child development centers, and 5 to 8 years children were being selected. 3 raters were being evaluated here. One was me, the researcher, second one was regular SLP, and third was parent. Parent were also given the form, and whatever the confusions they were having, they were asked to clear it from us and then rate it accordingly. Session was approximately 45 minutes, and the whole test required 3 to 4 sittings. Reinforcement was also being provided to the children. Third one was scoring and analysis. Here, scoring and analysis were done by the 4 which were given in the Self 5. 1 was almost never, 2 has been rated as sometimes, 3 as often, and 4 as almost or always. So each individual scores of the subsection. So there were subsections. We took scores of each subsections. And in third point, all the subsection scores was being evaluated by the total pragmatic scores into 100. These are all the tests which we took, crucial values. And inter-rater reliability was also done, where we find there was a very slight agreement in all the 3 groups. Spearman correlation was done for pragmatic skills and severity. Moving to the results, the first one was to compare and explore the pragmatic profile in minimally verbal, verbally fluent, and typically developing. In this, we see that in typically developing, they almost got all the, like they got the highest score compared to verbally fluent and minimally verbal. So the reasons maybe you can say that typically developing, they know how to have a conversation, they even understand humor. So obviously they have the highest scores. And in case of verbally fluent, they score more than minimally verbal because they have the ability to at least have a logical connection between the sentences as compared to minimally verbal. So maximum scores were in the sections of rituals, use of body language, and awareness and use of prosodic cues in case of all the three groups. And in minimum scores was being obtained in understanding humors, obviously understanding expressions of complex intentions, because this is the section where the autism spectrum kids have most problem dealing with. So the second is to explore the relationships between the severity of ASD and pragmatic skills. In here, we found that there was negative correlations in case of severity with respect to pragmatics. As the severity is increasing, the pragmatic scores are getting lesser and lesser. So implications were, it gives deeper insight in verbal and non-verbal aspects of pragmatics in the group. Data can be used as a normative reference of pragmatic skills for VF and minimally verbal children. And the study emphasized the needs of parental input along with NLS, that is natural sampling, to assess pragmatic skills in ASD. So these are my limitations and future directions. Where the limitations are, pragmatic, interventional, motivational factors was not there. So NLS was only implemented by researchers, and adopting the same method by regular clinicians was not possible. Future directions are, this study employed different conversational partners, that is familiar and unfamiliar figures, situational context, as output may vary. And this pragmatic profile, we can use it for other neurodevelopmental kids as well. Thank you. These are my references. Thank you for giving me this opportunity to present this.
What is the criteria you adapted for use of materials?
Sorry, sir?
What is the criteria you adapted for use of
Criteria. For ASD kids, we did the ISHA scoring, where only mild and moderate level children were taken as per ISHA, and they should be attending 6 months of speech therapy as well. And for normal kids, they have to just go to school. They should have age till 5 years, 5 to 6 years we took. And they should attend normal schools. And yes, they should not have any other comorbidities with them. These were the criteria of both the groups. And minimally verbal kids should have a word. At least they should have a word where they're expressing something, or a simple phrase, not the sentences. And in verbally fluent, at least they should have like, Mama, give me food, or I'm thirsty, like that, where we can have a logical meaning with the sentences. So these were the criteria we took.
But it is not, it's difficult to make the sentence at the age level, no?
Sir, if basically in verbally fluent, what I got as my...
Below 5 year students?
Below 5 years I did not take, sir, actually. It was more than 5 years. The kids were with more than 5.
You said the 5 years age group on speech therapy. So do you differentiate regular speech therapy or GLP, or everybody, you took everything as same?
I took, sir, overall I took same. It's nothing.
GLP already have phrases. Gesture language process already speak phrases. So meaningful comes later part. So speech therapy is on gesture language processing, or just speech therapy what you have taken in domain? Your domain, your
no, it's not related to, sir. I did not focus on gesture language or something. It's like overall, they should have at least words they are expressing, or at least a phrasal where they are asking for the things.
So you do not differentiate in
on
therapy also, they are not on specific therapy?
No, sir, no. Because if I would have taken like that, maybe I could get less number of population for my research, because it would take a longer period of time there.
Yeah. Thank you.
Any more questions? Thank you.
Guys, please do remember to sign for the RCI credentials. There will be a poster, scanner will be displayed. You will have to do it mandatorily, and we need to have a group pick. So if the credentials are not, if it's not appropriate criteria, then we might be missing the credentials.
Good evening, everybody. This is Pratiksha Shri.
Excuse me, doctor. Wait. Timer. Start.
Good afternoon, everybody. This is Pratiksha Shri, speech language pathologist from Talk and Learn Rehabilitation Center, Hyderabad. Co-authors followed by Siri Vandana, Ms. Prerna Reddy, Ms. Mansi Karnad. My paper title is Bridging Traditional Therapy Gaps, Gestalt Language Progression in Telugu English-speaking children with autism. So the introduction is basically just what is Gestalt. So Gestalt language acquisition is the process by which children may pick up language in longer segments or gestalts. Maybe it can be a complete sentences, phrases, or conversations that they hear in real life. It can be through media, it can be through random rhymes, it can be through environmental exposure to some situational scripts. So they just repeat verbatim frequently without having an implicit grasp of lexical, semantic, syntactic structure of gestalts. So language gestalts, the unit of meaning at the outset of gestalt language development, can be short as a single word or as long as an entire song or a movie. So this gestalt language process, how we found it is, it was found by Marge Planck in the year 2012. So this is the natural language acquisition framework. It was a detailed framework. This research was already done before by Peterson and present in 1983. So this natural language acquisition got 6 stages. So stage 1, here the side we have put some examples in association with all the stages. So stage 1 gestalts have longer sentences or scripts from the daily conversation or movie. That's gonna be the stage 1. And at stage 2, the child started mitigation and where the gestalts are mixed with other segments of utterances. At stage 3, it's referred to the referential, where the child will start combine a single word with noun, that is noun plus noun. For example, Pani Puri plus Papa, Papa plus aeroplane. So they started combination in stage 3, and moving on to the stage 4, so they are combined grammatically. So now single words are combined grammatically to create simple phrases and sentences, includes basic grammar. Moving on to the stage 5, gonna be the advanced grammar, which then evolves into a complete grammar system by the end of stage 6. So these are some of the Telugu scripts we put forth here of various stages. Can have a look. So the major aim of a study is to document the language acquisition pattern of Telugu English bilingual autistic children age range from 4 to 8 years. So why did we do this research? Especially because in Indian context there's a lot of lack in Telugu English bilinguals. So there are very limited studies in gestalt language processor. So it's indeed to do more research on this gestalt language process. So the basic method include study design has retrospective case studies, and the study duration is 6 months, and the sampling technique is purposive sampling, and sample size we have five children. So these are the case study, 5 children we have put forth here, age range between 4 to 8 years, and we gave the diagnosis of spoken language disorder associated with autism spectrum disorder. The children all had ASD feature along with spoken language disorder, and the baseline speech and language characteristics include unintelligible scripts related to songs and tune of rhyme. So the children started with lot of singing different tunes of rhymes from movies, from daily scripts where the parents started talking. So those were like single word gestalts. And some scripts from the environment, single words gestalts were also identified. Single word structures are nothing but the child will have only stuck on to the single word, which is very restricted to language progression. And all participants had undergone traditional speech and language intervention between 6 to 2 years. So minimal progress were reported by parents. So the procedure, so we took a baseline of language sampling at the start, and we gave some support strategies. So there are various support strategies according to different levels of GLP. stages. So support strategies using NLA acquisition framework were given. Multimodal supports includes AAC. So we included AAC with verbal modeling, and parent education were provided so that the parent can implement those therapy techniques at home to bring about the progress, and mid-therapy language sampling were carried out at the end.
These graphs indicate the pre-therapy and post-therapy performances of each child. Here we can see that at the pre-therapy baseline, most of the cases, the children were there is a high proportion of utterances seen in stage 1. For example, we see they were more dependent on gestalts, which were script-based communication. Like there is a child who would come, whenever she enters the therapy room, she would start singing, "Come on, let's play, play, play." So that is the script that she had to express her intention for play. Another child would say, "Let's blow bubbles." Another child would say, "Hello, nice to meet you." So those were some of the examples of the stage 1, which most of the children has showed. Later, after the intervention, we see that there is a shift in progression of the stages across stage 2 to 4 to 6, where the child who was saying first, let's play, later she progressed to saying, "Let's dance, let's sing, let's go out, let's go home." That was the type of progression seen. So these findings suggest that appropriate stage appropriate strategies are required for us in a GLP processing for the intervention. Otherwise, there would be very challenging for them to develop their language. To give another funny example, there was a child who was not earlier recognized as a GLP, so the parents would ask them many questions. So the child one day during a therapy session, he asked me, "Do you want to go to potty?" That was a big pause for me, but then later, since I understood the child, I know that he actually wanted to go to potty, but that was a script that he picked when mother was earlier kept using to him, asking questions to him. So when the right supports were not given, that would be the challenging we can see in GLP. So it is very important to give stage appropriate supports to the child for a better progression. And it is also, I want to also bring to notice that this progression is very individualized. Each child has their own journey and their own pace, and it is very important to also train the parents about it and use the neurodiversity affirming interventions by going by the child-led, not giving much pressure to the child. So in this study, we found that Telugu and English-speaking bilingual autistic children exhibited this identifiable progressive patterns of gestural language processing, where they were able to transfer from echolalia to more flexible combination of gestures, where they reflected a meaningful language development when they were given support appropriately. So I emphasize that there is a need to recognize, identify the GLP and support the GLP to see a good progression in their communication intent and their communication use across various communication functions. Thank you. Thank you for the opportunity.
Existing study, no, Idi?
Yes, it was it is a very existing study, but research in the Telugu speaking and English speaking, Telugu and English bilinguals, the study is very less limited.
What are the major modifications you incorporated for your study in this?
Modifications in terms of
Any adaptations?
Adaptations.
Modifications?
No, so the supports and the strategies we included were both bilingual. So we did not restrict to a particular language. We used both bilingual.
We used AAC for patients who ever come in our clinic, we ask them to download the AAC app and we give scripts on them.
What is the inclusion and exclusion criteria?
So the exclusion criteria would be a child who does not process language, it is called the Gestalt way. And so we are trying to tell you that language is processed in two ways, the analytical language processing and Gestalt language processing. So we want to understand that how in India, in Telugu English population also, we see children who are processing language the Gestalt way. So the study is not, we are trying to because it's lack of research in Indian languages, we have tried to understand in the clinical way whether our children also exhibit Gestalt language processing. Okay? how children process language. How do you receive information of the language that you get? We were talking about that.
Like why I am asking this question, in Telugu also we are observing.
Yes, we are observing the same pattern as we observed in America as well, or in any other language as well, for that matter.
Yes, that is the reason I am asking any.
No, we don't have to exclude anything, sir. We just have to follow the same thing. We follow a language sampling pattern. We put, so Gestalt follows the 6 stages, and we are doing so our children, are they following the 6 stages of language is what we were checking.
I thought any Andhra Telugu, Telangana Telugu you observed.
So we cannot restrict that, sir. A child who is developing language will have scripts from English, from the media that the child from the media that the child is seeing, the parents and the maid, everybody in the house is from where the child is picking up language. So you cannot tell that the child, I will do it only in the Telangana dialect or Andhra dialect. I had a child who would always speak like a very typical Telangana accent because the maid was only interacting with the child and all the scripts were from the maid. So you really can't pick up, have an exclusion criteria like that.
What is the prevalence of GLP in autism kids?
There's very limited research on that, sir, but they say that about 70 to 80% of children.
Then the sample size is only 5. If
yes,
it is 80%, 70% is there, why sample size so less?
In my clinic, what I could analyze, in my clinic, I have around 30 kids. We have 20 kids who are on GLP. What sample we could collect and what we could present was 5.
Okay, because sample of that size can't do much justice for your study. Study was fine, but that size will not help you to predict what you want to do exactly. And 80% of kids are GLP. If you think about what are the studies say, 70 to 80% kids are GLP. And most of the parents said they speak, but they can't reciprocate. That is the problem. So thank you, ma'am. Thank you so much.
Sir, paper presentation.
Hello everyone, this is Gito Shri
Dr.
here.
Timer. With the timer.
Okay.
Timer. Yeah, start.
So I'm a music therapist. Let's start it. So okay, so we all have heard a lot about autism. I'm a person who like moving a lot, so it's very difficult for me to stand and talk, but I'll manage. So autism is, we have heard from morning till now about autism. So as you can see over there, I will be mainly focusing on motor difficulties, communication, social impairment. Gone. It's playing hide and seek with me. So, yeah, these are the therapies which usually follow, but I will be showing you how music has worked effectively for autism. Thank you. See, what's music? Now, lullabies, can you sleep without music? No. Can you have athletics without aha moment and shouts? No. Can you have a scary movies without the sound effect behind it? No, it will not be scary anymore. So what are the 3 things I have been focusing on when I'm working? I'm working on rhythm, melody, and structural interaction. Okay, so there is a difference between noise and music. Now if I tell a child, pick up the bottle, that's a noise to the child. But if I say, hey dear, the bottle is there, can you please pick up? I'm not using music, but I'm musical in talking. Okay, so what was the aim of my study? It's here, social communication, emotional expression, and behavioral regulation. So the target group mainly was children with mild and high functioning autism. So these children who came down for the research work, it was merely a very small count of children we took. They were all into mild and high functioning autism. Now what were the methods? As you can see, we took only 30 children. We did it for 12 weeks and from 5 to 12 years. Now what did we do? We had singing, we had playing instruments, we had interactive games, rhythmic movement, and my most favorite, musical storytelling. I had Milind sir here who was talking about it. So when I incorporate music into it, they remember it better. So here we go. Click करने से चलेगा. The child is having a flapping issue. So I think someone in the morning speaker told that it can be generalized into some other movement. So I'm trying it here, but you can see the child is not able to follow the rhythm. Let's move on to the next child. How you have to play? Okay, so it flipped. Can you see the pattern how she is following? And that's how what music does. Very good. Now see, 1, 1, 2, 3. 1, 1, 2, 3. Okay, now here you have, see how this child being a Telugu and I being a Bengali, trying to teach a Bengali song just for communication skill. Rule is when I play, you play. When I sing, you stop. When I play, you play. When I sing, you stop. Shall we go? Yes, sir. I to besha ho chori hate hate. Nachi behi sihaga hi. Okay, so I need to follow her now. But she's not singing the song which I sang. She's singing it from her memory, the other song. This is a very important session where I'm teaching them gestures and through music, and then I will take out the verbal instruction and make it non-verbal over there. Big sound. This is low sound. Okay, less sound. Okay, less sound. This is harder. Fast sound. This is slow sound. Yes. So you got all the instructions? Yes, ma'am. Fast, slow. Akshay, start. You observe the child who is sitting between those two. Stop. Very good. Start. Start then. Vedu. I think more than me, music has spoken. So I'll go to the start. What you have to do? Go to my work here. It's about neuroplasticity of the brain, which has helped me to work with music. I'm not going into depth of that. And this is the what I have used, the scale, the Corners parent rating scale I have used to take the evidences. This is the result. And as you can see, music is everywhere. You can read music, you can listen to music, you can have memories associated with music. As you can see about that girl who was singing another song, we can move to music and the emotional response to music. Thank you so much for listening to me. More, you can read my book. So I took the students who came to our school. I'm basically a school counselor. These children came for admission to our school. From there, we came to know that they are mild autistic, and then we started working on them.
But there are certain amount of prerequisites required, no?
Yes, sir?
There are certain amount of prerequisites required for
Yes.
the music therapy.
Yes, sir. So we have, no, the child who has been assessed with autism, mild autism, and the child is going for therapies. So this was the criteria which we selected. The child goes for speech therapy, occupational therapy, behavior therapy, and we included music with it
So
to
have
see
you
the difference, how it is after the, application of music on them.
So have you followed any kind of instructions before assessment of this kind of music therapy?
Have I followed?
Any instructions or guidelines for the music therapy?
Yes, sir. We follow the music therapy guidelines. Like it, the music which I am choosing has to be more appropriate with the age group. And I basically love working with instrumental because it in words you take the child somewhere with the words, but instrumentals work much more effectively is what I have seen, and it is more interactive. It's not a receptive music; it is an active music therapy session. So I'm not using receptive form of making them sing a song or something. I'm using active music therapy where the child also communicates with me through music. Like if the child is angry and bangs the duffly for a few seconds and then again come back, I'm telling about an ADHD child. So I try to find out that the aggression which is inside the child is getting channelized. I start singing a raga behind so that the child can follow the rhythm which I am trying to bring him down. And in this raga bhairav, then ahir bhairav, this has worked effectively well for my sessions.
So overall, you followed in the traditional one only, or any non-traditional kind of thing in this music therapy?
Yes, sir, both traditional and non-traditional.
Why corners in autism? Corner scale, what is the purpose of corners, doing corners in this?
To take the feedback from the parents, sir. I couldn't find any other scale which I could use for taking the music therapy responses.
So it's choosing the focus to look at the focus and decrease hyperactivity.
Yes, sir.
The
To
whole
find out that, because out of this 30 children whom I have chosen, 18 of them had the characteristics of having less sitting tolerance. Then they were not able to focus. So these were the main criteria. Actually, in this less session, we couldn't.
Whole point of study is to start with something, do intervention, then the result. So sir was asking the same thing. There were already prerequisites you have taken, then you have done some intervention, there should be some result.
Yes, sir.
So your inclusion criteria was very different, your study was there, and exclusion criteria, again the result was on a different scale.
No, it was.
Autism, music,
Yes.
ADHD.
No, it was not ADHD. I gave an example of ADHD. But even
read the scale,
autistic children have a difficulty of sitting tolerance.
I know,
sir.
but you did the scale of ADHD, right? Corners.
Yes, because I couldn't get any other scale where I could measure this from the parents' side.
That's what sir was asking. Thank you, ma'am. Thank you so much.
Thank you so much. Thank you, sir.
Next, Satyash.
Mike. Mike.
Good evening, everybody. I'm Dr. Satyesh. Today I'm going to present a study on clinical profile of children with autism spectrum disorder who have been tested for cerebral folate receptor antibodies. As we know, and which was discussed extensively yesterday, folate is critical for the physiological systems associated with neurodevelopment, and folate receptor autoantibody testing is increasingly becoming ubiquitous in children with autism spectrum disorder. But overall understanding of their function and implications of testing and management are in their infancy. Folate uptake generally in the CNS is regulated through the folate receptor protein alpha, which is known as FR alpha, into the CNS. But the folinic acid that we are supplementing does not require the traditional folate receptor, and it requires a reduced receptor. But the overall sensitivity, affinity of this receptor for folinic acid is low. That's why we give high dose folinic acid in these children. Now when it comes to antibodies, there are two types of folate receptor antibodies, blocking and binding. And in literature, there has not been extensive analysis regarding what kind of clinical profile children with autism spectrum behave with blocking or binding antibodies. There are very limited studies. So overall, there is a lack of consensus regarding the concentration ranges of the blocking versus binding FRAs, and differences in quantifying methods and techniques, the absence of precise quantification, and overall a lack of consensus regarding age and gender specific nomograms for both types of antibodies. While folate metabolism disorder can be caused by both, their functional roles remain fully unresolved in the pathogenesis of autism. And recent literature has also shed light on administration of high-dose folinic acid for a brief period and seeing their overall neurodevelopmental outcomes. However, causality has not been established. Hence, we conducted a retrospective study with the primary objective to first evaluate the clinical profile of children with autism spectrum disorder, and with the secondary objective to assess the correlation between the FRA levels and the severity of the autistic symptoms. As I mentioned, it is a retrospective cohort analysis. The study duration is between Jan 2022 to March 2026. The study setting was Yashoda Hospitals. Inclusion criteria range from 1 to 18 years of children who have been diagnosed with ASD as per the DSM-5 criteria and who have also undergone FRAT testing. Exclusion criteria are children with developmental epileptic encephalopathies and epileptic encephalopathies who have presented with autistic traits. So we've screened all the medical records. Children diagnosed with ASD and who have undergone FRAT testing were also enrolled, and with DE and EE were excluded. Their demographic details, the symptom analysis, developmental assessment scores including CARS, DQ, social quotient, and associated scorings were all taken into account. The medication details were also collected. The FRAT testing was also, reports were analyzed, and overall the statistics were seen. Here in India, as of now, whenever we do the FRAT testing, it is the titers which you get is for both the binding and inhibiting, because the test which is done out in the West is a patented one, and we do not yet have the means to separate both on a commercial scale. So we have seen 46 children who were enrolled, of whom 76% were males, and the median age of presentation was 73 months at the time of FRAT testing, but the median age of symptom recognition was around 33 months. The median folate receptor antibody titers were 250 nanogram per ml, and 58% had levels more than 300. Mean CARS2 scoring was around 33, which falls between the mild to moderate spectrum. And 25% of these children, that is 54% of these children were on folinic acid treatment, and 5% halted the treatment in view of increased irritability and hyperactivity. And on a side note, serum B12 levels were assessed only in 6 children, and all children were deficient in B12. So overall data pertaining to FRAT titers and correlation with ASD is scarce. As in most studies, majority of our study population is also boys, but we see a more number of girls. But the overall sample size is too limited to comment further about this particular statistic. Western literature points to elevated antibodies in autistic children versus controls, but there have been recent studies from Asia, Southeast Asia, and Middle East where they are saying that even normal children have higher antibody titers. That correlates to our dietary habits, our environmental influences also, because ours is a very dairy heavy diet, and cow milk and other dairy products are also known to cause induction of multiple autoantibodies. They have also demonstrated serum level of binding FRA in autistic boys is weakly negatively correlated with age. So they say as age increases, the titers of the FRAT antibodies also comes down. And multiple studies, including few that is mentioned here, showed mild intake is considered as a trigger of FRA activation, that is dairy products. So as I said, dietary preferences of ASD children, their propensity to eat a lot of carbohydrate-rich food, processed foods, along with poor vegetable fruit intake can explain the reason for low folate levels. Also, prospective studies measuring RBC and serum folate levels, and if possible, corresponding CSF folate levels can throw a light on real-time folate deficiency status in children with ASD. Low serotonin levels are also associated with folate deficiency, and studies have shown that low serum serotonin levels in children with ASD are there. And there is literature evidence that folate supplementation helped in the treatment of SSRI-resistant depression. Hence, it is postulated that folate supplementation can be beneficial in children with ASD as well. Although few studies in the Western literature showed increased B12 levels, Our minimal testing showed that most of our children were deficient in B12. So the notion that B12 has a inhibiting potency on FRAT antibodies cannot be fully ruled out. Strengths, we have a detailed analysis of symptomatology, assessment scores with treatment details, and most children were under regular follow-up and were compliant with therapies and medication. And the FRAT testing was done at a single accredited lab. The limitations are its limited sample size, the retrospective nature of the study, multiple confounding factors pertaining to our local demographic, including the diet, micronutrient status, and differentiation between the binding and inhibiting FRAT antibody was not possible. So conclusion, I would like to say that although this is becoming a more ubiquitous test, they are also elevated in children with, without ASD, pointing to multiple associated factors. Causal relationship and correlation with severity of symptoms is lacking, and treatment with folinic acid is found to be beneficial in some, and the demographic in whom it is found to be more useful is to be studied more. That is, which antibody type will respond more. Hyperactivity and increased irritability is a known side effect, and the reasons are not clearly understood. Hence, we must always go with caution when counseling parents that even though we advocate it, it is not a magic drug and it is not a one-time solution. Thank you.
Have you gone through the IMA guidelines before this topic research?
No, sir, not fully. The thing is, overall, this overall testing has been going through for the last 4 years, the FRAT testing and all. So the guidelines have come later to that. So when we counsel to the parents, especially who come with elevated titers, we take more than a 3-fold titer as significant. Because as I said before, our population tends to have more of autoantibodies for various reasons. But the implication is not very sure. So when we give them a choice that we are seeing a positive result and you can give a trial of high dose folinic acid, it might help, but if you are seeing a side effect, we can titrate the dose or completely stop it.
So is there any study related to the normal population and this category?
There was one in China, there is none in India as of now. So the Chinese study found almost similar titers in both non-autistic children and autistic children.
Most of the parents with positive will have FRAT positive in parents. One of the parents usually will be positive. And what are the doses you have used? And what is the dosage schedule you have to give?
So 15 milligram to 20 milligram folinic acid, high dose 2 mg per kg, we can go.
So we can go up to 2 mg per kg. Maximum doses?
Maximum, there is no cutoff per se. So for bigger kids, we go up to 20 milligrams usually.
What is the latest status of USFDA of licoverine or your folinic acid?
Full details I'm not sure, sir.
It has restricted to give in autism. It's not validated to give. USFDA is not approved for autism.
Not approved. They have put it as a cautionary thing, saying that it's not.
But dosage is 0.5 mg per kg per day, with go up to maximum 50 mg. So initially start with the 0.5 mg, go up to 2 mg per kg per day, maximum is 50 mg. That's the dose, not more than that. Thank you.
Namaste, sir. So my topic is on transforming neurophysiology through stillness, a randomized controlled trial of yoga therapy in autism spectrum disorder. So the background of this study is all you know that it starts with the chronic stress and maternal stress. So this is what we found during pregnancy. The chronic stress tends to lead autoimmune disease, during pregnancy with autism, means autoimmune disease, if they are taking intake of a high fat diet or exposure to pollution or exposure to infection leads a kind of immune alteration or activation during the maternal. So that's what we say as a maternal stress. So imbalanced inflammatory cytokines in the plasma, placenta, and amniotic fluid that tends to microglia activation. With transient neuroinflammation from maternal stress to autism spectrum disorder by changing the collateral neuronal dysfunctions and psychological imbalance and the cognitive impairments. It leads to behavior impairments. So we found the root cause. Noi nadi, noi mudal nadi, adudanikum vai nadi, vaipachal is a Tirukural. It's a traditional Tamil scriptures. So from that we found, of course, the root cause of the disease also given in the scriptures 3000 years before in Tirumandiram. So Mada Udaram, Malamigil, Mandanam, Mada Udaram, Jalamigil, Mungayam, Mada Udaram, Yanukke, Kannillai, Mada Udaratil Vanda Kuravike. It's a verse of 743, Tirumandiram. It is given in 3000 years before. So we have taken the help from the Tirumandiram and Tirukural for root cause of disease and disorders and the treatment for the disease and disorders. So the treatment for disease and disorders, noi nadi, noi mudal nadi, adithanikkum, vai nadi, vaipachal, that is physiological function, neurophysiological dysfunctions that leads to sensory motor dysfunction, where it's supposed to be integrated, but it is dysfunction. And these 8 sensory functions are dysfunction, which leads to behavior impairments that listed in the 15 categories of childhood autism rating scale, 2nd edition, high functioning scale. So the aim of this study is to evaluate the effect of neurophysiological functions, regulations, and behavior impairments in the individuals with the autism spectrum disorder. The participants are based on the sample size calculation, based on the previous studies. 36 children, means individuals with the autism spectrum disorder, were screened from age between 6 and 25, including the criteria, followed the inclusion and the exclusion criteria, and those 36 individuals were equally randomized into 2 groups, yoga group and control group. So this trial was approved by the AVMC Ethical Committee and registered in the Clinical Trial Registry of India. So the intervention group received 60 minutes yoga therapy session per day, 2 weeks per day, Tuesday and Thursday they have received per week for a period of 6 months, along with the regular school routine in the Satya Special School, where the special school is fully 200 school children were there, more than 21, 25 schools age also there. So the control group only regular school routine. So there's a yoga therapy protocol, various selected techniques based on the pilot study. We have selected the techniques, 15 techniques for 60 minutes, and the outcome measures are hand grip strength, visual reaction time for the sensory motor and the neuromuscular coordination, and childhood autism rating scale for the behavior. On 3 times we assess pre, mid, and post. And the analysis we're using based on the repeated measures of ANOVA with Bonferroni adjustment, and then the Pearson correlation were used. The neurophysiological and behavioral outcomes were the changes in the yoga group. We found that the significant in hand grip strength, almost 4.7 within the group, and between the group 3.27, whereas in the visual reaction time decreased almost to minus 523 milliseconds. But in the control group, it remained and increased also. Autism severity course rate also, scale also shown significant reduction in within and between. So from the analysis clinical significance, the behavior improvement showed that within minus 10.56 milliseconds course category was reduced. Minimum of 4 changed, means that is threshold minimal changes. So based on that indication, this is the faster behavior progress compared to the minimal change in the control group. The mechanisms of the improvement are attributed to the multidirectional neurophysiological modulation and group interaction fostering engagement, peer modeling, and social reciprocity, baseline social isolations. So overall findings that biweekly yoga therapy sessions over a 6-month enhanced neurophysiological regulation, sensory motor integration, and accelerated cognitive, emotional, and behavioral improvements in individuals with autism spectrum disorder. The feedback from the special teacher also received some of the activities during the daily living. So cheerful tendency, independency also increased, and there was an emotional response after appreciation, and emotional and expressions were understanding also they have received, and structured player activities also improved, eye contacts were improved. So like this, the responses also developed from the awareness through the techniques. Thank you, sir.
Have you observed any specific yoga for neurodevelopmental disorders?
Yoga techniques, or all the techniques were breath coordinated movement. So neurodevelopmental disorders can be brought into the sustainable developmental goals, sir.
In our country, there are 84 yogas. Those are authorized kind of, according to our country, whatever be the asanas suggested and recommended. But for neurodevelopmental, especially for autistic and intellectual disability, 3 asanas are recommended: Paschimāsana, Trikonasana, Uttasana. So have you observed any kind of specific yogas recommended for this category?
Yes.
Tell me.
Not a single asana I cannot describe. This is just one asana. It's a means a collective of asanas, techniques I can say. Like Matsya Mudra, which directly influences our cortical, that influences sensory integration also. As you said, the Trikona Asana and Pavana Muktasana will be helpful for increasing the cardiac vagal tone. So not only the specifically these 2 asanas, and there we need more techniques also to support.
Was the child was only exclusive on yoga therapy, or other therapies are all going on?
As usual, additional to this regular school routine, sir.
So you did all other yogas. Sir was asking exclusive, only 3 yogas were done, which are mentioned only for neurodevelopmental disorder. You did everything. There was no tailor-made.
No, there are 15 techniques I have chosen.
No, there were no tailor-made techniques you have developed.
All the techniques were given in the three rounds, 3 minutes, like 45 minutes.
Thank you. Thank you so much.
Can I start, sir? Can I start?
Present timer, please.
Start. Good afternoon all. Myself Mohan Kumar, rehabilitation psychologist. The topic which we are going to review is the critical analysis of Indian Gazette guidelines of autism assessment. The researchers who are worked on this is Mr. Dheeraj Babu, Krishina, and Dr. Sunita Deep. So we all know the prevalence of autism, and we are discussing more about how much percentage is there. I wanted to just think about like DSM-4 and DSM-5. DSM-4 published in the year 1994, and DSM-4 TR came in 2009, and DSM-5 it was in 2013, and DSM-5 TR was in 2021. So the the year is very important to note. That will have a later discussion, we will see, okay? So background of the study, so long we have discussed about the schemes and benefits of persons with disabilities. Yesterday, Sai Kishore sir told that the UDID card is a basic requirement for getting any beneficiaries. So the UDID card is provided on the basis of Indian guidelines given on 14th March 2024. So I'm going to see about this. So this disability guidelines of autism divided the guidelines into two types, which is below 6 years and above 6 years. In below 6 years, it mandated that using of Ames modified incline ASD tool, and for above 6 years, the diagnosis should be based on Ames modified incline ASD tool, and the diagnosis percentage of disability should be based on Indian scale for assessment of autism. So if you see, these are the medical professionals they have to do. So below 6 years, they will get temporary disability card. After 6 years, from 6 to 18 years, they will get also temporary. After 18 years, they will get permanent disability card, okay? So analytical methodology here is critical review. So if you see, again I explained that pathway 1, which is below 6 years, Ames modified INDT ASD, and they will get a diagnosis of moderate autism with 60 to 79% of disability below 6 years. Above 6 years, diagnosis should be based on INDT ASD, and diagnosis should be based on INDT ASD, and the percentage of disability is based on ISA. So if you see, the problem where it is rises, the inclined ASD is, the age range of inclined ASD is 1 to 14 years, but similarly the ISA, which is officially published, the age range is 3 to 20 years. But if you see, the Gazette is saying that below 6 years, we should use and diagnose based on only INDT ASD, and percentage of disabilities also should be based on this, even though ISA is available from 3 years. And the diagnosis should be in directly moderate, nowhere the severity of mild or this thing come. This creates an ambiguity among the professionals. If a professional A is referring for INDT ASD and giving the diagnosis of moderate, and the another professional who is using ISA from 3 years and giving the diagnosis of mild, that will create a professional ambiguity in this diagnosis. And in Gazette, there is no clear-cut explanation given for why below 6 years only INDT ASD and directly moderate with this percentage of 60 to 79% was given. So this is the example. If you see, 3 years, they are all below 6 year children. In INDT ASD, all are getting positive. That is the ISA corresponding scores. And that is the percentage of disability and diagnosis based on ISA manual. If you see, there is a huge discrepancy. If you go with autism guidelines, according to Gazette, everybody will be in moderate and higher the percentage. So this is create a huge ambiguity in the person who is referring Gazette or person who is referring ISA manual. So that should be reviewed. Second is above 6 years. So in above 6 years, the percentage of disability, if you see ISA, the percentage of disability given in Indian Gazette and the ISA manual, it is a very huge difference that is not nowhere aligning. So if you see, particularly all the discrepancy ranges which was given in Indian Gazette in compared to ISA manual is very underestimated. Lower percentage of disability was given. Particularly, if you see the scores from 124 to 140, there is a huge 30 to 70% of delays there. So the percentage of disability has a huge impact. So the professionals who are giving for certification, if they measure if the disability certification is given based on ISA, there will be a different level of percentage band. And if they are referring Gazette, there will be a very different percentage band. So that is the ambiguity it is creating. Second is the percentage of disability it is giving is range, not in a single unit. If you see ISA manual is giving it as a single unit, but Gazette is giving us a band, like 60 to 79%, 40 to 59%. But if you refer any UDID card, the nowhere the range is mentioned. It will be 60%, 70%, 80%, it kind of definite single percentage is mentioned. So this Indian Gazette doesn't have a guidelines like how they have it for physical disabilities or locomotor disabilities to derive the particular number for percentage of disability. Even though RPW Act says that more than 40%, irrespective of what kind of range of percentage of disabilities here, everybody will get uniform schemes and benefits, but this ambiguity in deciding the particular percentage and ambiguity in deciding which guideline should measure, that is the huge discrepancy we are facing. So what, along with that, if you see the year of ISA was developed is 2009, then the year of INDT was developed is 2021, modified was 2018. So at the time of ISA was developed, it was based on DSM-4 criteria. Currently we are using DSM-5 criteria, so updation of ISA should be done. So there should be uniform guidelines between ISA and Gazette. That discrepancy should be reworked and it should be eliminated. Thank you.
With reference to your study, now tell me, according to the UDID or whatever be the DSM, so will you consider the global developmental delay for the UDID or not?
Sir, according to our Indian Gazette, below 5 years, UDID, we should use global developmental delay. More than 2 domains in VSMS was, should be low. But if you see on practical difficulty, in UDID Southern portal, the global developmental delay, the domain was not showing. So whoever in Telangana currently not getting under the category of global developmental delay, everybody are getting in the category of intellectual disability only, sir.
But in our system, we are providing the services for from the early intervention to early childhood special education up to the age of 10 years.
Yes.
So what is your comment?
Sir, if you see in NIEPID, most of the model, below 6 years we are using early intervention multisensory models, where from NIEPID, the disability certificate is still we are giving us a developmental delay or global developmental delay. But when you are applying for Southern portal, in Southern portal, the category is not showing. But in some instance, the certificates I got it from Andhra Pradesh and Tamil Nadu, I have an incidence of seeing global developmental delay, but particularly people would have predominantly getting the UDID card in Telangana, the incidence was not shown and the particular category of global developmental delay was not showing. So even in, according to UDID portal, there is a separate forms for each disability, even though our Indian Gazette is saying that ISA diagnosis should be based on incline and percentage of disability should be based on ISA, even for children below 6 years, the forms which UDID portal is giving only has ISA forms, no incline forms are there.
So now which one we have to follow, ICD or DSM or ISA or NIEPID?
Sir, the diagnosis should be based on DSM-5 criteria and the percentage of disability should be on ISA. And as ISA is based on DSM-4, it should be updated.
So what do you think the benefits will be if there is a change in percentage?
Sir, there is no change in percentage, sir. RPWD Act clearly says that whoever crossing benchmark disability of above 40% will get same kind of disability. But the person who predominantly using, like I am working in NIEPID, so predominantly I refer Indian government guidelines. But private practitioner, or they don't have to measure they don't want to give the disability percentage, or they are not predominantly practicing Gazette. So that if the person who are trained and predominantly working in the private sector, and they wanted to quote the percentage of disability, they'll obviously will follow the manual which the test says, rather than the Gazette guidelines. So that will be a difference in the percentage, sir. So that is the ambiguity it is creating. Particularly if you see below 6 years, I am referring Gazette and I'm giving.
I got your point. There is no problem in providing the services.
No, sir.
So there is nothing deficiency in that. The only problem is that should be corrected. Percentage should be corrected. That's what your point is. That's what your point is. So they have separate guidelines. Disability is different from percentage of disability. If you see mild category of intellectual disability, if you take, it is from 50 to 69. But the
55
percentage
to 69.
49, sorry. So in that, the percentage will be very different.
Yes, sir.
So like that, divided, the guidelines have come from AIMS. Dr. Shafali Mehta madam was a DM neurologist professor. She made a guidelines based on England, ISA. She divided like that so that everybody gets benefited. And based on that interventions, divided whole larger percentage into smaller percentages. So when there is no discrepancy in services, and this card is issued by the government only. Only government is issuing, no private organization is issuing a autism certificate. There is ambiguity, definitely that can be explainable. There is no change in service. What is the point of in all these things?
I am adding this. If I am saying the person is having moderate autism, and again I am doing ISA, and it is coming mild. So if I am explaining to the parent that, like at the age of 3 years, if they are coming and I am using INDT, incline ASD, then I am saying moderate autism by referring asset, and I am using same by ISA and saying that mild. So am I claiming that moderate autism comes to lower level of mild? That is create professional communication error.
That's what. So every setup center has a different way of assessment.
Yes, ma'am.
So that should be only common thing is only for government. Every center has different assessment setup.
Uniform guideline system. Sir,
uniform guideline system is there in already in government setups, but the percentage is difference.
Yes, sir.
That is the only value that is.
The category also different, sir.
Yes, category is also different. That's what it is there already there. That is under correction now. That is going on. That's the government problem. But differences does not make anything. It's only we have to explain. The problem is explaining them manually.
Yes, sir. Communication part will
be the only problem, right? That can be done.
Create a discomfort in professional categories, sir. Professional among the professionals, sir.
That we have to face every day. Every day. That's okay with it. Thank you so much.
Our work. Sir. Thank you, sir.
We have our last session by Dr. Anas. He will be talking about autism mimics. Dr. Mohammed Anas has completed his MBBS from KMC. He did his MD Pediatrics followed by his DRNB Pediatric Neurology. He passed in flying colors in first division. He has several achievements and has special interest in neurometabolic syndrome and neuromuscular. Over to you, Dr. Anas.
Thank you. Hello. I know everyone's tired, so we'll try to wrap it up quickly. So, autistic phenotype is not a diagnosis. It is a final common behavioral pathway of diverse brain insults. So one must yeah. So the key is to always look for red flags. So landscape of neurological autism mimics is very wide and large list. It ranges from treatable metabolic problems, epileptic encephalopathy, neurocutaneous syndromes, storage disorders, neurogenetic disorders, structural conditions, neuromuscular conditions, and various several acquired conditions as well. So we'll approach this in this manner. We'll start with history and examination. We'll see what made it an autism mimic and what was the red flag that made us question the diagnosis. Investigation that nudged us towards the actual diagnosis and the diagnostic reveal. And we'll see what can be done and what is being done. So always history and examination first. So zinc, biotin, folinic acid, creatine, low protein diet. Can you tell what's common between all of these conditions? So they're all supplements, and we'll explain about this in the further slides. A boy with golden hair. A 3.5-year-old boy born to third-degree consanguinity, diagnosed as autism in view of delayed speech, repetitive hand flapping, obsessive with spinning objects, now was brought with increased tantrums and head banging. On examination, he had inconsistent eye contact, he was restless, poor sitting tolerance, lots of stereotypies, and surprisingly mild gastrocnemius spasticity. This was a red flag in itself. On inspection, we can see he has golden hair, which was non-familial. This prompted us to do a TMS, and what do we find? A 10 times elevation in phenylalanine. We had done an MRI brain as well, which was consistent with PKU. Genetics further confirmed it. So what did we do? We started a low protein diet, phenylalanine free diet. There was improvement in cognition, even hair color, but of course not optimal improvement because it was diagnosed quite late. So what happens in PKU? The high phenylalanine competes against tyrosine, tryptophan. As we know, these go on to form dopamine and serotonin. So these are lower in the prefrontal cortex, giving to the above symptoms. Unfortunately, India has a no universal newborn screening program. So TMS is still an important test when the suspicion arises. So key takeaway, non-familial hypopigmented hair with microcephaly, think PKU. A tale of twists and turns and lessons learned. This is about an 8-year-old boy born to third-degree consanguinity, first seen at 3 years of age, with background history of speech delay, stubborn behavior, sensory issues labeled as autism, and started on therapies. On probing, there was mild motor delay as well, which got aggravated after febrile illness, following which he came to us. There was imbalance, which was worse on taking turns, abnormal flinging movements of arms, tremors on reaching for objects. So this is video. I hope it will play. Yeah. So what can we see? We see this boy for 3.5 years of age is staggering to either sides. There's abnormal movement of the hands as well, which is coriform. MRI showed delayed myelination. And genetics, we found FOLR1, which was consistent with the clinical suspicion. So what is FOLR1? So basically, it codes for the protein that makes sure the folate that is there in the brain goes to the, that's there in the blood goes to the brain. Decreased folate eventually causes impaired 1-carbon metabolism. There's neuroregression and epileptic encephalopathy. So what did we do? We started him on folinic acid. Over time, there was improvement in his behavior, gait issues in EEG improved as well. Of course, again, not optimally. So when you see ASD features with movement disorder and epilepsy or even subclinical seizures, one must consider the possibility of FOLR1. Earlier, we would do lumbar puncture to see CSF, MTHF. Now with genetic confirmation, it's more for reverse phenotyping rather than the first line. So this is him on the last follow-up. So we can see his walking and balance has significantly improved. The balance is better and no coriform movements. So key takeaway, autistic features with seizures and movement disorder, consider FOLR1. Missed milestones and misread and misunderstood. Now, a 6-year-old girl born to third-degree consanguinity was first seen at 3 years of age, with history of poor response to name calling, speech delay, motor delay, delayed attaining by walking by 2 years, no improvement on therapies. On examination, what was subtle was their sparse eyebrows. Her social gestures were relatively good. There was no response to auditory stimuli, not even jingles, which was orange flag, we can say. Generalized hypotonia, which is non-specific. Here, we had done EEG and MRI in view of polymorphic multiple seizures, and what do we find? We did BERA as well, which showed profound hearing loss. Biotinase levels was done, and what do we see? A significant reduction in the enzyme levels. We see 0.2, the lower cutoff is 4.2. Significant reduction in biotinase. Genetics further confirmed it. So what did we do? We started him on folinic acid. There's improvement in understanding motor milestones, improvement in hair as well, but no improvement in hearing, which is consistent with what is seen in the literature. I'll not bore you with the mechanism. So when you see autism with sparse hair, SNHL, plus minus epilepsy, do consider biotinase. It's a simple test and has a even simpler treatment, which will require for lifelong. Head drops in clusters and a missing peak. A 3.5-year-old boy born to non-consanguineous marriage, brought with speech delay, noted at 18 months, poor socialization, hyperactive, hand flapping, repetitive fixed interest. What was surprising was he had lots of staring episode, which was attributed to just zoning out. Later, he developed head drops and falls, for which he was brought. On examination, he was hyperactive, stereotypical behavior was there. Mild generalized hypotonia, which is non-specific again. His gait was normal. MRI showed brainstem and globus pallidus hyperintensity. But what clinched the diagnosis was MR spectroscopy. So this is the spectroscopy of the child on the left. Don't worry, we'll not go into technicals. So this is the child's MRS on the left, and the one on the right is normal. What difference can we see? Okay, I'll make it easy for you. So this and this. So we see creatine on the left side is much lower as compared to creatine on the right side. So this shows that there's low creatine in the abnormal areas. We further did urine testing, which further corroborated with our diagnosis. So what is the treatment? What is this, anyone? So this creatine monohydrate. So people familiar with going to gym will know this, but here we give it for the brain, not for the body. But of course, it does help for improving tone as well in such kids. So he was started on creatine, ornithine, arginine-free diet with sodium benzoate initially. There was improvement in epilepsy, language, and social domains. 75% of children with GAMT have autistic traits if undiagnosed and untreated. Polymorphic epilepsy is a red flag. MRI brain has to be done with spectroscopy. MRI brain alone may misguide us, and urine testing helps. So refractory polymorphic seizures, look for MRS and urine screening for cerebral creatine deficiencies. There is a range of cerebral creatine disorders, starting from GAMT, AGAT mutation, CRTR. As you can see, all of them have something common. They have development delay, cognitive dysfunction, speech and language disorder, seizures, epilepsy. Some of them have hypotonia, some of them have myopathy, and movement disorders are seen in GAMT. So it is a close mimic and which is treatable as well. Moving on to the next case, beyond the label, a case for Hickham's dictum. A 13-year-old boy born to non-consanguineous parents was diagnosed with autism at 2.5 years age, was stable on therapies for the past 10 years or so. At age 11, they noticed worsening behavior, scholastic decline, slowness in motor activities. He was tested for vitamin D and B12 and started on supplements. Unfortunately, there was no response. They continued this for the next 2 years and had no significant improvement. They came to us with genetics and report, and what we did, on examination we found bradykinesia, which was attributed to myopathy. It was rigidity as well, and a large spleen, which was surprising. I think we can guess where this is going, or maybe not. So fortunately, genetics was done. Unfortunately, this report was there with them for the past 2 years. There was no pathogenic variant in the first page, but second page had an additional variant. We find a compound heterozygous mutation of ATP7B, which is for Wilson's disease. So this is a representative image for what we see, this KF ring in slit lamp. MRI was done by us to corroborate the genetics. What we can see, this bright spots, what you can see in the basal ganglia, is consistent with Wilson's in the right context. Cerebroplasmin was low. So now we have finally proven that this is Wilson. The child was started on low copper diet. Penicillamine was started as a copper chelator and later started on zinc. He was started on ropinirole and pacidin for his bradykinesia. He also had chronic liver disease, which was missed, for which he was sent to gastro people. So what is the issue here? The issue is anchoring bias. One must look past ASD when clinical situation is discordant. So look for KF ring in an unexplained or new worsening disorder. Slit lamp, ceruloplasmin, and urine copper always helps. So we'll move beyond metabolism. The diagnosis unlocked when the child started walking. A 5-year-old boy born to non-consanguineous parents, speech delay, social difficulties labeled as autism. He had falls and difficulty in squatting, which was attributed to clumsiness and behavior. On examination, he was aggressive, hyperactive, but what was stuck was his prominent calves and difficulty in getting up from floor. So quite a prominent calf for a kid of this age. CPK was done, which was very high. MLPA was sent because of the clinical suspicion of DMD because of male child, which turned out to be negative because we were quite confident this was DMD. We had sent a whole exome as well, and that is what we found here. DMD hemizygous X-linked pathogenic variant, explaining the motor difficulties. So dystrophin isoforms are present in brain as well, and these are responsible for synaptic functioning, which can explain why there is autistic features in these kids. Up to 30% of children with DMD have some form of cognitive or neurodevelopment comorbidities. Usually the motor phenotype often precedes the diagnosis of ASD, but sometimes motor difficulties are often dismissed. So when you see a boy with autism, look at his calves, and if prominent and motor delay is there, send CPK. There are lots of treatment options available. We'll not discuss that now. The answer popped when the holding stopped. A 3-year-old girl with normal development until 1.5 years of age had sudden regression of speech, stop pointing, stop waving, and was not holding object with her hand anymore. Now she was brought with hyperventilation spells, which was attributed to stereotypical behavior. An examination, she was restless, non-verbal, and this is what we found. I'll play this video. So we can see some midline hand movements and hyperventilation, which is very classical for Rett syndrome. So this is what we found on genetics as well. So MECP2 encodes a transcriptional regulator for synaptic functioning. Again, can affect, tell us why there are autistic features in such children. 61% of them do meet criteria for ASD at some point of their course. A problem is this can sometimes lead to the delayed diagnosis of Rett syndrome. So clinical pearl is look for loss of purposeful hand movements in a girl. There are treatment options available, upcoming. Trofinetide has been approved. Still optimistic, we'll see. Spots, dots, and developmental drops. Now, a 7-year-old boy with developmental stagnation past 3 years was brought with poor social interaction, poor communication, learning difficulties, and attention issues. There was no history of any seizures as such. He was restless, hyperactive, unable to follow simple instructions. But what gave away the diagnosis was his clinical features. We can see he had subungual, you can see the look at the finger, this subungual fibromas. You can see at the skin, there's hypopigmented macule, and look at the face, angiofibromas. Any guesses? Yeah, we have smart people here. So this is what the MRI showed, cortical tubers, lots of them, lots of cortical tubers. This MRI of a different child, we can see SEGA, astrocytoma here, and calcification. These are the various spectrum that what we can see with TSC. How common? So ASD phenotypes are seen in up to 36% of children with TSC, which can fit in the broader spectrum of TAND. So what is the clincher here? Hypopigmented macules, facial angiofibromas, and subungual fibromas should alert us for the possibility of TSC. People have tried early vigabatrin, which has helped for spasms and subclinical seizures, which has also shown to have long-term improvement in behavior. But this is still, we need a prospective study to corroborate. So any child with autism, please look at the skin. The skin may have the answer, which of course MRI will confirm. Scales, delays, and developmental fails. Now, a 7-year-old boy born to 3rd-degree consanguinity, symptoms noted from 2 years of age, prior development was absolutely normal. Again, a huge red flag was gradual regression in speech, behavior, hyperactivity. He was diagnosed as autism with ADHD. He also had frequent falls while running and sleep difficulties as well. He had a coarse facies, dry scaly skin, which was thought to be eczema. They were tried multiple lotions over past 2 years, no improvement as such. So we can see coarse facies, depressed nasal bridge. Skin is very rough, dry, scaly, with lots of eczema, which is failing to respond to routine medications. MRI was done because of the regression. We see lots of bright spots in the periventricular region. A possibility of metachromatic leukodystrophy was considered, and aryl sulfatase was sent, which was low. but genetics gave us the answer. It is SUMF. It is multiple sulfatase deficiency, which also encompasses some features of MLD as well. So unfortunately, the younger siblings also had the same gene, but fortunately we were able to do hematopoietic stem cell in the younger sibling, and there was improvement in enzyme levels, and the child's development is normal so far. But this is not a proven therapy as of now. It's still experimental, but there's some optimism here. So ASD with ADHD, with coarse facies, eczema, these are our additional clues. Aryl sulfatase may be low, but it can, it's not specific here. Coarse, hoarse, and sleepless coarse. Now a 6-year-old boy born to third degree consanguinity had issues with regression in speech and hyperactivity, hoarse voice, persistent sleep issues. He had quite coarse faces and short stature. Any clues? Sorry? Yeah, correct. It is MPS. So we did a skeletal survey, and we find anterior beaking of vertebra and shallow acetabulum consistent with MPS. Unfortunately, no clear therapeutic options here. Subtle coarse facies with severe insomnia, which fails to respond to regular medications. Always think of MPS, do a skeletal survey, it is easy to do. Here, this was Sanfilippo, MPS 3. So other mimics, which will not go in detail. Speech regression is a red flag beyond attaining actual speech, not just non-verbal. Visuomotor issues, intellectual delay, microcephaly. Of course, they can be, it can be associated, but this should also alert us for other options. So a child with relative microcephaly with coronal ridging, a CT skull with 3D bone window was done, and fundus was done for papilledema. What do we see? I know we are not radiologists, but we'll give it an attempt. So what is the odd point here? Okay, I'll mark it. Yeah, so if you can see on the right, there's a line which is absent here. This is early fusion of coronal suture. So options are endoscopic versus open suturectomy. This was a study which shows that up to 12 kids in 44 had autistic features. Many of them do improve, but some of them continue to have such features. So, of course, features can be coexistent, but it may have some treatment application. Hypoglycemia and neonatal period with significant fine motor issues with visual inattention should alert us for hypoglycemia, NHBI. Treatment is visual rehab, and prevention is better than cure here. Speech regression after attaining speech in an older child, worsening school performance, EEG has to be done, both sleep and awake. And what do we see here? CSWS, or now as we call it ESES, electrical status in sleep. Treatment is anti-seizure medication with steroids. Children with autism do have lots of epilepsy as well, and they may have abnormal discharges, but not all discharges need to be treated, only when they are significant and causing obvious regression. Sometimes intellectual delay is also mistaken for autism. This is a child was told to be autistic, had lens subluxation, long arm span, Marfanite habitus. Homocysteine and methionine was elevated. Treatment was simple B6 with low methionine and betaine. Although I say it's simple, it's very complex to manage such kids. So we can see high homocysteine and high methionine takes us towards CBS. So what is important here? History, examination, and targeted testing. So these are the red flags that one must keep in mind. Family history is important. If it's consanguinity, consider autosomal recessive disorders. Girl child, think of Rett. Male child, think of DMDs. Regression is always a red flag after obvious normal development. Look for additional clues like movement disorder, epilepsy. A clinical examination like microcephaly, macrocephaly may sometimes have an answer. Tall stature, Marfanite habitus for homocystinuria. Hair, as discussed, golden hair or sparse hair for biotinidase deficiency. Neurocutaneous markers are paramount. And of course, general examination must never be skipped. These are my references. I would like to thank and acknowledge my mentors, Dr. Lokesh and Dr. Ramesh. Thank you.
Thank you, Dr. Thank you, Dr. Anas, for the wonderful talk. It had comprehensively, you have given a list of all possible cases that you have seen. That was a huge list.
Yeah.
And the one-liners, almost riddle-like, were very entertaining and kept us wanting to know the diagnosis. So any questions from the audience?
Sure. No, we can do it quickly. What we do many times, we do an outpatient evaluation. We don't admit kids unless it's required. We examine the child. If we have any targeted testing, we do those. And usually, simple things like X-ray will come on the same day. Blood test may take a couple of days or so. Genetics is something which will take time, but because it requires counseling, understanding, family perspective, and in India, it's very tricky sometimes. So this all can be done in a single day, but of course with follow-ups. And of course, we know the importance of our other colleagues in other behavioral and psychological. That is key. That will continue to go on and will help from our medical side with supplements. Yeah, we can do everything. We can do everything. Yeah, we have
one more question. There should be can we start AED without any clinical seizure, only EEG abnormality? In ASD cases.
So ASD, many of the kids do have lots of temporal discharges. If there's no obvious speech regression and it is not like an ES EEG, the role of starting antiseizure medication is it's no scientific value.
And one more question about your FOLRS positive. We have given folinic acid. If there is MTHFR gene variation positive,
so
there are two versions of giving it, quadrifolate and folinic acid. So
correct.
Can
That
you
is
explain
correct.
that?
That is correct. Fortunately, polymorphism is not very high in India, but that's a valid point. So many of the labs are now doing polymorphism as well. Of course, it comes with a cost. So if family is happy to bear it, we can do it as well. But that's a good point.
Thank you, Dr. Anas. So I think we'll take the further questions in the tea break.
Yeah, I think tea is required, yeah?
So now we have a very exciting session. We are going to announce the prizes for the posters and the papers. So I request Dr. Srinivaslu sir to please come onto the dais to hand over the certificates. So the third prize for the poster goes to Sri Vandana from Talk and Learn Rehabilitation Center for the poster Effectiveness of Using the NLA Framework to Facilitate Language Use in Adult Autism. Poster competition goes to Ajay Ganta Paul from CDC Madhapur for topic Effect of Functional Communication Development on Caregivers' Stress Levels in Children with Autism. Place for poster competition goes to Ms. Harita Singaraju from Oyster CDC, phrase-based AADC modeling in Gestalt language processing.
Apurva. First prize goes to Dr. Apurva. Oral paper.
Oral paper presentations.
Nishirai. Nishirai. Archika. Archika Johari. Archika Johari. I think she left the seat. Okay, thank you.
Speech and hearing community rocks today. Most of the awards are for us. We wish to see more and more participation next
Because
year
most of the
too.
papers are from that, ma'am. That's why.
Sir, they took a step forward to send papers.
Till kudos.
That's what.
We wanted to felicitate parents as well who are over here, who've taken time and attended this conference, because we know you all are the primary caregivers and the primary therapists. So I would request the parents who are present over here to please come onto the dais. Yeah, please give them a huge round of applause.
Round of applause, please.
Because as professionals, we learn a lot from parents. Day to day, their experiences, their thoughts, they really shape us. So thank you so much for teaching us as well.
We need to have a group photo for RCI. Your credentials, your responsibility.
So does anyone want to speak or share their experience just for a couple of minutes?
Yeah, first of all, I'll thank all the leadership team from Yashoda for giving us the opportunity, and especially the participants who are coming from different parts of the country. So I'm one of the senior parent who was talking from day one till the closing session. So something which I want to convey to all the parents and even the therapists, most of the time everyone is talking about early intervention, transformation, or even talking about inclusion. It is always good to think about or even counsel what would be the future, because most of the time what happening is working professionals, they pay less attention towards their children and talk about only sending to therapy, or they assume that something magic or miracle will happen if they send it to therapy or even a medical. Some parents will come and ask, even me, even I am an early interventionist, can my child speak? A non-verbal child can speak within 1 month. That's the kind of questions that come up. So it's always good to go with more practical and ensure that even future, even if I wear a cap of a parent, I don't know what would happen after my retirement, who will take care of my son. That is what made me to transform from a technology architect to early interventionist and a researcher. And I'm personally working with almost 60 countries. Maybe I'll talk to the leadership of Yashoda how we can connect and then see how we can bring more research publications, because I'm the only Indian who is gold certified architect from IBM supporting 60 countries. So this is something which I want to bring. So now the goal is to look at the future. Till date we are talking about historical data, we are talking about transformation, early intervention, but the goal is to look at P2G, pediatric to geriatric life. So till date we are talking about pediatric and adolescents, but geriatric is something which is needed, not just only for parents like me or anybody. I'm talking about any human being. Geriatric life after 65 is similar to below 10 years. That is where P2G life programs are very much important, and it's need more attention towards geriatric age group as well for future.
Thank you, sir. Just one more parent. Yeah.
Hi all, I'm Dr. Kavya. I'm lead consultant gynecologist working for Kim's Cuddles Gachibowli. Also, I'm a special needs parent. I have a child of ASD. So one thing is that because I'm a gynecologist, I'm a surgeon, I deal with so many insurances. But when it has come to my child, I'm not able to claim, all insurance companies are rejecting knowing that the child has autism. I think for the next conference, I think you should come up with something that will help the special need parents. As Sir said, from pediatric to geriatric, geriatric is the end. But during the course of the child's life, because everything is expensive in autism. So, but at least when it comes to health, I think, some insurance companies have to come up and help the parents like us. So.
Good evening, one and all. Firstly, I would like to thank Yashoda Hospitals on behalf of all the professionals here. And I feel so honored to be here on the stage, and I dedicate this presence of mine on this stage to my son. He's 17-year-old now. I've started my journey with him from past 16 years. So I have learned a lot just because of him. So thank you.
So hello everyone, myself Krishna Mohan. So I'm a parent of my son, who is 14 years old, and he's 9th grade now. So I belong to IT background again. I worked with a firm called ADP for almost 16 plus years. Then my journey started with him when he became 9 years old. Now I run a center, CDC, which is named after him. It is Jayaditya Foundation, which is in Manikonda. And I'm a special educator and I'm an early interventionist. So whoever visits my center, any walk-ins or any referrals, so I don't keep myself into a center-head shoes. I speak like a parent. And I think these kind of awareness sessions should happen. And I think I must thank Yashoda that, the kind of awareness sessions they're doing, for the past 2 days. I think it's really required need of the hour for the parents. So thank you very much, Yashoda.
So firstly, thank you for the wonderful platform and insight knowledge. So small, 2 minutes here. Actually, I work for Mercedes-Benz R&D, one of the biggest R&D out of Germany. So daily we are fed up with recalls and other technical activities, and we see how much stress it is. But since 1 year, I'm in sabbatical leave, I'm taking care of my son, and daily I see how much stress this is, but in a positive way. But think in the perspective of therapist, the sample size is big. So thing is, the clock is ticking around, and histogram is of ADHD, AST, everything is going up. Be prepared, and I feel it's the future generation is with you. That's what I see. And most important thing, I would, let's be practical. Though these special educators are low-paying jobs, but they are doing wonderful jobs. Respect, huge respect for you.
Good evening all. నా పేరు గీత. మా బాబు ఇప్పుడు 15 ఇయర్స్ అండి. తన 18 మంత్స్ ఉన్నప్పుడు నేను ఐడెంటిఫై చేశాను. 18 మంత్స్ నుంచి అంటే 14 మంత్స్ అప్పటి నుంచి ఉంది, బట్ డయాగ్నోస్ అవ్వడం 18 మంత్స్. లోకేష్ సారే చేశారు, ఏఎస్డి విత్ ఏడిహెచ్డి. సో అక్కడ నుంచి స్టార్ట్ అయింది జర్నీ. నా ఎక్స్పీరియన్స్ చెప్పడానికి ఇప్పుడు టైం లిమిట్ ఉందండి. సో అందుకని నేను ఒకటే చెప్పగలుగుతా. నా ఎక్స్పీరియన్స్తో నేను నేర్చుకుంది ఏంటంటే, పేరెంట్స్ అందరూ స్ట్రాంగ్గా ఉండాలి. ఫస్ట్ యాక్సెప్ట్ చేయాలి మన చైల్డ్ని.
యాక్సెప్ట్ చేసి వాళ్ళ లెవెల్ తెలుసుకోవాలి. వేరే వేరే చైల్డ్ తోటి కంపేర్ చేసుకొని మీరు లో అవ్వద్దు. బీ స్ట్రాంగ్, ఆల్ ద పేరెంట్స్ షుడ్ బీ స్ట్రాంగ్. అండ్ ఇంకోటి ఏంటంటే వాళ్ళ అంటే స్ట్రెంగ్స్ తెలుసుకోవాలి, వీక్నెస్ అండ్ వాళ్ళ ఇంట్రెస్ట్ మెయిన్. దాంతో మనం జర్నీ చేయాలి, వాళ్ళని ముందుకు తీసుకెళ్ళాలి. నేను ఇప్పుడు ముందు అంటే ఈ కోర్స్ కంప్లీట్ చేసి ప్రైవేట్ క్లినిక్లో అంటే మా మ్యామ్ ఉన్నారు, తను బాబుకి ఏంటంటే 5 years తర్వాత నాన్ వర్బల్ అని డయాగ్నోస్ అయిందండి. కానీ 5 years తర్వాత వర్బల్ అంటే వర్డ్స్ స్టార్ట్ అయ్యాయి. నాన్ వర్బల్ అన్న తర్వాత నేను డిప్రెషన్కి వెళ్ళిపోయాను. కానీ 5 years తర్వాత అంటే వర్డ్స్ స్టార్ట్ అయ్యాయి. అప్పుడు నేను NIMHకి తీసుకెళ్ళాను. యాజ్ వెల్ యాజ్ అంటే ఎకనామికల్గా మనం కొంచెం అంత ఎఫర్ట్ చేయలేము కదా, అప్పుడు మ్యామ్ దగ్గర తీసుకెళ్ళాను. అంటే థెరపిస్ట్ గైడెన్స్, కౌన్సిలింగ్ కూడా మనకు చాలా చాలా ఇంపార్టెంట్. ఓన్లీ వాళ్ళ పైన డిపెండ్ అవ్వకుండా ఈచ్ అండ్ ఎవ్రీథింగ్లో మన ఇన్వాల్వ్మెంట్ చాలా చాలా ఉండాలి. ఇంకొకటి మనం కిడ్నీ జనరలైజ్ చేయాలని అంటే జనరలైజేషన్ ఇంపార్టెంట్. వాళ్ళు ఏమనుకుంటారో వీళ్ళేమనుకుంటారో అని అనుకోకూడదు. మనం ప్రతి దాంట్లో మన బాబుని ఇన్వాల్వ్ చేస్తూ వాడి ప్రతి యాక్టివిటీలో మనం కూడా ఇన్వాల్వ్ అవుతూ ముందుకు తీసుకెళ్ళాలి. తను ఇప్పుడు క్లాస్ ఫస్ట్ వస్తాడు, 9th standard, నార్మల్. ఇది నా సక్సెస్ స్టోరీ. అండ్ ఇప్పుడు నేను గవర్నమెంట్ సెక్టర్ స్కూల్లో స్పెషల్ ఎడ్యుకేటర్గా వర్క్ చేస్తున్నాను. నాకు ఈ ఆపర్చునిటీ ఇచ్చినందుకు థ్యాంక్ యూ.
First of all, I appreciate all the parents here who are educators. They are not taking their children and they are servicing all the many children. So definitely we have to appreciate. It should be it's a model for next generation maybe. So many educators are coming and doing nice job, and they are good educators also there, and they are getting good name, and they are taking care of their children also. But okay, nice. Thank you for giving this opportunity for all the children.
Rishikesh sir and Anas. Dr. Anas for his wonderful talk. Standing along with them, although my nephew has autism, he's 15 years, he's non-verbal. And I do see for the whole family also, sometimes it gets so difficult, it's overwhelming. So I think all of us deserve a pat on our backs, everyone in the audience as well, because as a community, we need to be there to support each other.
Last but not the least, the hero of the event. So
So we know Somashekar Garu, he's been the backbone. Although he's an introvert, he doesn't want to be on the stage, but thanks to him, we've had such a wonderful conference over the last 2 days. Thank you, sir.
Hello. Yeah. We are doing this autism conference for the 5 years. 5 years onwards, we are doing regularly the national event. So everybody is supporting, being a parent, teachers, therapists, doctors, everyone. Without you, we can't do this many. So the whole reason we are doing it is, so you every day the therapist, you are going for dealing with the many kids. At least I think 78 kids, one parent, one therapist is dealing. So you just learn here. The concept is to learn here. You just apply it in your platform. Thank you.
assemble on the stage for a group picture. Presentation of Dr. Rishikesh. Thank you, sir.